Good morning, everyone, and welcome in. We are so glad to have you here with us today. Please, if you're as you come into the room today and join us, if you will, post for us where you're from, who you are, where you're from, and if you want to give a good shout out to your dental practice, to your medical clinic, or your business, do that. We love that kind of stuff. We would absolutely love to see that. There's nothing wrong with giving a good shout out to your clinical practice, and we would love to see that. So if you will, come on in, uh, tell us where you're from, and we will do our best to say hello to each and every one of you. We'll even give a shout out to your business. We love a good cheer section. So come on in and cheer on your business and your medical practice or your dental practice. And we will most certainly say hello to you this morning. But my name is Violet Crabb. I'm in Clarksville, Tennessee. Danielle, you are in, if you want to go ahead and say hello to everybody this morning, and I'll be sure to type in and say who I'm over in the chat box so everybody knows where I'm from. So,
Hi, everybody. I'm from sunny California, and it is still dark here. We're at just about 5 a.m.
oh, yeah. And then we'll introduce Dr. Montez when he comes on in his introduction a little later. But I'm so glad to see everyone making their way in this morning. We'll get started here in about a minute and a half, and we are so excited to see all of you here with us today. We are so excited to see you with us. So,
I love it. It's a nice turnout right in the morning, right when we first start. It's always nice to see.
so you are not alone, Danielle. We actually have two folks in here from Northern California. We've got Ibrahim Integrative Dentistry in California and Paula McCarthy from Northern California. So early risers, good morning and welcome, because I know how early it is for all of you. Good morning. I'm in Central Time, so it's still it's 7 for me, but it's not quite as early as it is for you guys. Wow. And there's someone from Utah, from the Rocky Mountains of Sky, Utah, Jennifer in Colorado. Good morning from Illinois. I think you're in the same time zone that I'm in. There's Cheryl Scott from Reno, Nevada, 5 a.m. Beth
Oh
from
man.
Connecticut. Yeah, there's someone else from California, Nicola from California. Good morning, everybody. So, yeah, we've got some really early risers with us
Oh
this
nice.
morning. Wow, nice, very nice. Good morning, everybody, and welcome in. Welcome in. I want to give everybody another minute to kind of walk the way in here. Guys, we're going to have a packed house today. We have over 80 people registered for this event. Kirsten from Frisco, Texas, and Preston Ridge Dental, good morning.
Yeah, so
Stephen
scooch in,
Harrison.
get close,
Yeah, Stephen Harrison
scooch
is
down.
from Washington. Good morning, Stephen. You're up early as well. Wow, we've got some good early risers in here. Good morning, good morning.
So nice to
So,
see you.
yeah, it's so nice to see all these great folks that have come in so early this morning. We are certainly glad that you are here. Good morning and welcome in. We are always glad to see all of our folks from around the world. It's one of the great things I love about this organization is that we have people literally from all over the world. Danielle and I have been running an audit of our membership to try to kind of figure out where everybody's at, because one of our goals in 2026 and 2027 is to see if we can start hosting live regionals again. Glenda, good morning from Illinois. We really do want to start doing some live regionals with you guys again, and we have just been shocked at where all of our membership is from. I mean, we have members in New Zealand, we have members in Japan, we have members in France and Germany and all over the world, and it's really neat to see just how far aaosh reaches across the world, and it's invigorating and exciting, and we really do love it. And we are what we're going to do. I'm going to give everybody one more minute, and then we're going to get started. And guys, if I lose my voice or my voice cracks, please forgive me. I have been sick. I came back home from an event in Kansas City. And I know there were some people behind me doing some really hefty coughing on the airplane, and I knew I was doomed by the time that I got back home, and I was right. I was doomed. So I got pretty sick, but I'm doing much better now. So please forgive me. If you hear a croak in my voice or something doesn't sound right, I promise it's not. I'm not over here dying. It's just a little bit of what I had still hanging on for dear life. So, guys, if you're just coming in with us, please post where you're from. We'll try to give a shout out to everybody to say good morning. But I know we've got quite a few early risers in here, and we are going to go ahead and get started with opening remarks for this morning. So, again, welcome. We're so happy to see you, and we are excited to get started this morning. So, that was a sound I didn't want to hear. Oh, hello from East Tennessee, Debbie. Quick story. Guess where I grew up? If you can't figure out from this accent, I grew up in East Tennessee, actually in a little town called La Follette. So I know exactly where in the world you're from. Welcome in. We are certainly glad to see a fellow East Tennessean in here this morning. Welcome, welcome, welcome. We are glad to have you. So let's go ahead and get started. So I want to start out this morning with kind of a weird start. Normally you say thank you in the end. We're going to say thank you in the beginning, but I want to say thank you. We are so pleased to be able to present to you today an all-star lineup of thought leaders, industry giants, and academic scholars who are ready and set to provide you with a day of learning and connection. And I promise you a day of collaboration, excitement, and fun as we spend the next few hours together. My name is Violet Crabb, and I'm the Executive Director of aaosh. Danielle Springfield, our Senior Digital Marketing Coordinator, is also joining me for the entire day. And on behalf of our entire Board of Directors, we all welcome you to our first virtual full day of learning of the year. Before we dive into today's programming, I would also like to take a moment to recognize all of you, those who support this organization, member and non-member alike. Over the past 6 months, aaosh has gone through a season of change. Change is often difficult. It's an upheaval from what you've been used to. Most of us cringe at the idea of change. When I was asked to step into the executive director's role in November, I took on that role knowing that my vision for this organization was different from previous leadership, which is okay, but it aligned with our board's mission. And at that point, we started to see so many great things happen. We want to take aaosh back to its roots, saving lives through the understanding that the blood that flows through your mouth and what's happening inside of your mouth affects the rest of your body. We believe that our comprehensive, multidisciplinary, holistic approach changes lives. That we have the ability to take a sick care system of reactive care to a healthcare system of preventative care that treats health issues before they become chronic diseases. For all of you who have joined us today, I am honored that you've put your faith in this organization, our key opinion leaders, our thought leaders, scholars, our board of directors, and in me. We've seen unprecedented growth in the past 3 months, and I'm humbled by it. Our membership numbers are growing by a lot. We are breaking goals we never dreamed possible, and it's all because of you. I want to give you some examples, and one of those is our sustaining partners. We have so many year-long sustaining partners, and you're going to get to hear from a lot of those today that have decided to join us for the next year. One of the great things that you'll get to see today is these partners get a chance to you to talk about their products and services and the assistance that they offer that can help you grow your practice, help your patients, and save lives through the mouth-body connection. We are so grateful for their support, and I'm humbled each time that someone reaches out to me and says, "Hey, we want to get on board and support aaosh because we believe in your mission and your vision and what you are looking forward to in the next year." Every time we gain a new partner, I'm humbled by it, and we will have more as we continue to go through the year. If you have a business and you're interested in being a part of our partnership program, we would love to have you join us. If we keep growing with this, Danielle, I don't know how much more we're going to be able to take on, but we'll welcome each and every one of you with open arms. And we're so glad to have each one of these partners join us. Another example of this is our annual session. If you haven't signed up for 2025 annual session, we hope you'll do so soon because I'm about to announce our speaker lineup, well, most of it. And like what I'm about to share with you is an example of how we are getting back to our roots. This is the first announcement of our speaker lineup. I think you'll be pretty pleased with what I'm about to announce. Some of our speakers include Dr. Bradley Bell and Amy Downane, Dr. Mark Cannon, Dr. Susan Maples, Dr. Susan Estep, Dr. Ellie Campbell, Dr. Whit Wilkerson, and Laura Hooper. And we hope to make a huge announcement very soon about two other all-star key opinion leaders, which will create an amazing lineup of speakers. Not to mention the fact that you will get to see old friends and make new ones. On top of that, we will be announcing our location very soon for 2026, 2027, and 2028 very soon. We are not letting grass grow under our feet. We are so ready to go and so pumped and ready to bring you these new annual sessions that have been revised to make it so that you feel like a community again, so that you feel like you get a chance to collaborate, learn, connect, and meet each other again and feel like the family that we know that we are. This is an exciting step. And folks, I mean, I was telling Dr. Montez just a few minutes ago, I think we're down to maybe our last 15 to 20 hotel rooms. So you need to get moving. It's at least it's available at the Cooper Clinic. There's hotels also in the area. But this show's going to be sold out very soon. I'm humbled by it and thrilled and can't wait to see all of you in Texas. It's going to be a great time. And like I said, once our speaker lineup is announced, the last two that we think are coming on board, it will be a sold out show very quickly. So please join us. We would love to have you. And like I said, if I haven't said thank you already, let me say it again. Thank you. What's amazing about all of this is that it's just the beginning. This board and Danielle and I are dreamers. We've not even scratched the surface of where we're headed, our plans for the future, and what we hope to continue to do to secure your faith in this organization and what we believe in. By we, I mean you, me, Danielle, our board, and the future of healthcare. From the bottom of my heart, thank you. Thank you for your support. Thank you for your faith in this organization. Thank you for your willingness to grow with us. Thank you for everything. We are so grateful for everything that you do for this organization. aaosh loves you, your family, and we want to see you stay with us forever and ever and never go away because we love you. Speaking of from the bottom of our hearts, and we do love you from the bottom of our hearts, I am wearing red today, not just as a sign of support for anything with a Super Bowl, but today is Go Red for Women or Wear Red for Women Day. As I'm sure many of you know, heart disease is the #1 killer of women, causing 1 in 3 deaths each year. We know that there is a strong connection between oral health and heart disease. Gum disease can increase the risk of heart disease, stroke, and high blood pressure. So today we wear red to stand up for awareness for heart disease, the oral systemic connection, and we know that heart attacks are optional, heart disease can be prevented, and that our members can help lower death rates and save lives. So if you're not wearing red today, go grab something red and put it on. I'd love to know that everyone sitting behind us that we can't see is wearing red for women. So, a few things that you can do today to kind of make this a really great interactive experience. Tell us who you are and where you're from in the chat. If we know each other, we're already fast friends. Use the emojis, the chat, the Q&A, and interact. Not only will you feel more engaged with the speaker, you will also feel connected to each other, and that speaker will know that you have an interest in their content and their presentation. Please ask questions. We love questions. So do our expert speakers. So please don't hesitate to ask. And lastly, enjoy the presentations from our speakers. We are so excited to have great partners who want to come in. The presentation from our partners is just as important as the presentations from our speakers too. They want to share their life-saving and life-changing products and services with you. So please stick around while they give their talks about their products, and they will be here to engage with you, answer questions, and share all the information that they have possible. Guys, if you hear barking, I have two very silly dogs, so please excuse them. They don't know any better. If you have any technical issues during the event that might prevent you from remaining on the live feed, issues with sound or video, or anything else, my email address is there. Please reach out to me. I will do what I can to help. Just a quick reminder of how everything's going to roll out today. We're going to roll out here in just a second with Dr. Sergio Montez. He will be first upon the list. Then we'll cover a sponsor break. And then we will have, we'll go through to Dr. Katie Lee, then to Liz Lundry, then to lunch break, then Dr. Cami Haas, Dr. Parul McCarr, then Laura Walls, and then we'll close out the day. So these are the last things that I'm going to go through today. I'm not going to go through all of these with every single course. It's going to save us some time. We are updating a little bit how we handle our CDE and CME. So I do want to make sure that I go through some of these before we get it. This will be the same for every presentation. It'll save us a little bit of time. So this is our course information for all the courses presented today. We will do a review in 3 years of all education with our advisory council. That's just basic information. Same way with this. This is our AGD PACE accrediting body, as well as Westbrook University for CME as well. Disclosure of unlabeled use, so that we don't have to go through this every time, so that you can see that. Disclaimer for the presentation for all courses. The method of participation, as no fees for receiving credit are required, just so that you know that. And what we're going to do now, if you will, I'm going to stop sharing my screen. And Dr. Montez, if you will go ahead and pull up your presentation. While you're doing that, I'm going to go ahead and introduce to you guys Dr. Sergio Montez while he is pulling up his presentation. So welcome in, everybody. And I'm going to go ahead and introduce Dr. Montez. So it is my honor to introduce a true leader in the field of health-focused dentistry, Dr. Sergio Montez. Dr. Montez is passionate about helping fellow health professionals understand the deep and vital connection between oral health and overall systemic health. He believes that dentistry is far more than just filling cavities. It's a crucial part of achieving whole body wellness. His journey began in traditional dentistry, but he soon felt called to take a different path, one that led him deep into the world of integrative and biologic dentistry. After dental school, he built a thriving, health-focused practice in northern Arizona, which became a premier clinic for biologic dentistry in the region. He has also worked in multidisciplinary clinics in Utah, where he has helped create interdisciplinary teams that focus on true healing. Today, he practices at Dental Solutions in Bountiful, Utah, where, in addition to patient care, he leads the Holistic Dental Education Series, training practitioners from around the world on how to diagnose and treat oral health issues from a health-first approach. Dr. Montez holds a degree in molecular and cellular biology from the University of Arizona and has worked as a research scientist at the Savar Health Center, where he published multiple studies. He earned his Doctor of Dental Surgery from the University of Iowa and later became a board-certified naturopathic physician. As a founding member of the Academy of Biomimetic Dentistry, he continues to push the boundaries of innovative health-centered dental care. Beyond his professional work, Dr. Montez is devoted to his family. He and his wife Lisa live in beautiful northern Utah with two of their 6 children and their beloved dogs, Axel and Slash. Dr. Montez is here today to share his expertise and inspire us to rethink dentistry and its role in overall health. So please join me in welcoming Dr. Sergio Montez.
Good morning, everyone.
Good morning.
Well, I'm real glad to be here. Apparently, I am a thought leader and industry giant.
You are to us, so most definitely. So, well, let's go through these first few slides, if you will, please, and let me get through these. So we have no conflicts of interest. If you'll go to the next slide. We've already done that slide, so you can go to the next one. We've already done that one, so you can go to the next one. You can go to the next one there. Go on to the next one and to the next one. So here's the course description, and I will leave that up for just a second. And you can go on to the next one. And you can go on to the next one. And to the next one. And I've done your biography. So, sir, you are good to go.
All right. Well, thank you very much, Violet. I am honored to be here. I feel blessed to work in the space that we work in. As mentioned, I'm not just a practicing dentist. I'm also a board certified naturopathic doctor. And you know, there were times I'd share my story about how I came into this space of more, I guess, health focused or integrative and biologic dentistry. But it's just an absolute honor to be able to be one of these physicians who looks at disease from a different perspective. I love this quote from Thomas Edison. The doctor of the future will give no medicine, but will interest his patients in the care of the human frame and diet and in the cause and prevention of the disease. And I aspire to be one of these doctors of the future, and I hope you all do as well. Today, we're talking about autoimmune disease, and it's kind of a group of conditions or a condition that plagues our population nowadays. The Autoimmune Association lists over 150 autoimmune conditions on their website. Many of these conditions occur in clusters with some very often more than one condition presenting at a time in any given individual. So it's something that's very pertinent to our practice nowadays. And a lot of folks don't understand the implications that this has on their practice. And as we're diving into this, I want to touch on um, the autoimmunity from the perspective of oral health physicians or dentists and dental hygienists and the where we live and the effect that that can have. Um, Autoimmune diseases can affect anyone. Research has found that there's different groups that are more susceptible to certain conditions. For example, for some reason, over 80% of individuals living with autoimmune diseases are women. In the case of lupus, African American women are 3 times more likely to develop this autoimmune condition than white women are. And talking about clusters of autoimmunity among Americans who have autoimmune disease, up to 25 of them have more than one presenting autoimmune condition. And as we get into things, I think we'll see that some of the reason for that is what the underlying situation is with autoimmune disease. Too often, I think we in the dental realm will look at our patients like this. We'll see what's going on in the mouth. We'll formulate right away. And I know some of you are doing it right now. You formulate a treatment plan based on a set of radiographs and what we see in the mouth. And what I'm inviting you to do is something more like this. This is my son Ammon some years ago. But this is Ammon doing what I'm going to invite us all to do today. And I'd like you all to join me on a journey that I take all my patients on, looking beyond the teeth as what is really going on with their health. This is going to be a theme kind of through my presentation and hopefully through the entire day. And that is an invitation to embrace your role as oral physicians. I am a DDS, a doctor of dental surgery. Some of my colleagues are doctors of medicine and dentistry, and I think we should embrace that and wear that on our sleeves, and that be what kind of guide our practice from day to day. So talking about autoimmunity, we have to understand the immune system. The healthy immune system functions to protect the body from harmful invaders from the outside. And there's controls in place to avoid that immune system attacking the body's own cells and tissues. The slide here shows what's called the major histocompatibility complex, MHC. That little MHC molecule is found on almost all nucleated cells in the body. And what that MHC does, it takes little proteins from the inside of the body or inside of the cell, brings it out to the surface and shows it to the immune system. Now, in healthy cells, they'll typically present normal self-peptides that the immune system recognizes as self and as harmless. And so these immune cells, cytotoxic T cells and whatnot. They're not activated, but that's how they learn that, okay, this is me. I don't need to do anything about it. And then infected or cancer cells will present little foreign proteins or mutilated proteins. They'll bring those cells out from the inside, or those proteins out from the inside, and present it on that MHC molecule. And that'll then trigger an immune response. The T cells will recognize and destroy that abnormal cell, and there'll be antibody responses to those antigens. Anyway, and you'll notice there's a class 1 and class 2. This isn't a course in immunology, but I wanted to lay out some basic understanding for those who are interested. Class 1 MHCs are found on all of our nucleated cells. Class 2 MHCs, those are mostly found on cells like macrophages and lymphocytes, the immune cells that go around engulfing the bacterium and the foreign invaders. And then they engulf those foreign invaders, break them down, and then what do they present on the surface to other immune cells? Those antigens that help the immune system recognize who's foreign and who they're supposed to be attacking. Now, in autoimmune diseases, something goes wrong in one or a combination of different factors. There's genetic and environmental and host factors that lead to autoimmunity. It's a very complex dance. There's iatrogenic factors. There is a breakdown of tolerance. That term tolerance, that's referring to the immune system learning and recognizing what self is. And so self-recognition is what that term tolerance means. And so if there's a breakdown in recognizing what is self and what's foreign, that's going to lead to an autoimmune attack, or that is our immune system turning against our own cells. Molecular mimicry is when outside pathogens, drugs, chemicals, toxins, anything foreign resembles the body's own proteins enough so that the immune system mistakenly attacks our own tissues. And there's, because this is such a vital function for survival, there are a lot of controls in place for the immune system and to control the response of the immune system. But if there's a loss of some of these immune controls, if there's a breakdown, often because of inflammation and an overreactive immune response, then we're going to tip into autoimmune disease. Now, today in our conversation, we're going to be focusing right here on the environmental and host factors, and specifically those factors that pertain to what we do every day in the oral health realm. So according to the published peer-reviewed literature, these are all major factors that can contribute to autoimmune disease. And there are also factors, as we go through our discussion this morning, that lie within our scope of practice to have an effect on in the dental and oral health realm. And so we're going to look at these individually and maybe explore what role we might have in screening for some of these conditions, and within the time that we have, I'm going to offer some resolution strategies to address these different factors. So the first one, low stomach acid. What does that have to do with autoimmunity and inflammation, right? Well, let's talk about what's called the orodigestive route. So we have introduced into the oral cavity lots of foreign bodies, microbes that eventually make their way, or can make their way, into the intestinal tract. Now, what lies between the intestines and the mouth? The stomach. The stomach acts as a barrier, and specifically stomach acid acts as a barrier to these microbes making it through into the intestinal tract. But there has to be adequate stomach acid there to be an effective barrier. So if the stomach acid is low, which it has been found to be epidemic these days, if stomach acid is low, then we will have this oral dysbiosis transferring into a gut dysbiosis because those same pathogenic bacteria are getting through the stomach barrier. And the same can happen with certain foods. If we don't have adequate stomach acid to break down our foods, common one nowadays is wheat and gluten, then we get food particles that pass through that aren't fully digested. And then that undigested food elicits an immune response in the gut that we're going to talk about in just a sec. So if that, for example, gluten, if that gluten molecule isn't completely broken down by the stomach acid into its constituent amino acids, then we're going to get a reaction in the gut. And so I like this diagram. This is what's happening in the lining of our intestines when we don't have adequate stomach acid. You'll see along the top of the image, there's toxins and microorganisms, food particles that are partially digested that make their way into the intestinal lining. And then as these foreign objects get absorbed, they meet the GALT, the gut-associated lymphoid tissue. That's the immune cells that reside in the gut. And it's important to understand the role that the gut plays in immune function. The gut houses about 70 to 80% of our immune cells. And I think, the good Lord designed us in this way because as the mouth and the oral cavity is one of the ways that our body is introduced to what's outside and what's around us. So I really think it's a divinely designed system. And what's introduced through our mouth informs the body as to what's outside of it and allows us to develop protections. But when these unhealthy things start passing into the intestinal lining and get absorbed, that immune system triggers, there's an inflammatory reaction. And then what were tight connections between the cells in the mucosal cells in the lining the intestines, you think of tissue swelling with that inflammation, that tight junction now becomes a little bit of a sieve, which allows more things to start leaking through. You've heard the term leaky gut. That's that intestinal permeability that we're seeing here. And then more stuff starts getting through that shouldn't be getting through, which triggers more of an immune reaction, and it becomes this vicious cycle. And that's why we'll see really sick individuals who started with a little sensitivity to some foods, and now everything they eat will trigger a response. And that autoimmune reaction and that gut inflammation and leaky gut kind of becomes a self-perpetuating problem. So how do you tell if you have adequate stomach acid? Sorry, I just want to see if you're awake. The burp test. So there's an easy at-home test that I share with almost all of my patients to determine whether there's low stomach acid. And this is the recipe here. I'll explain it to you. So any of my clients who present with a high degree of root caries, if their oral pH is low, meaning their mouth is more acidic, or if in our conversations there's and our new patient intake involves questions about their diet and their digestion. If there's any little red flags that come up in that conversation, one of the first things that I want to determine is, do they have low stomach acid? And this is the way we test that. It's called the burp test. You might remember in elementary school, during the science fair, someone would make a little baking soda volcano. You'd make a little volcano and then you mix the baking soda and the vinegar together. And what happens when the baking soda mixes with that acid? You get that volcanic eruption. Well, so this is based on that concept. And so first thing in the morning, before you've eaten or drinking anything, and you all can do this yourself, you get a quarter to half a teaspoon of baking soda dissolved in a cup of water, and then you drink that little baking soda solution, and then start a timer. And we want to see how long it takes from the time you drink that baking soda till you get the little gas eruption or a burp. And what we would hope to see is that within 3 minutes, you get a burp. That tells us that there's a good, robust amount of stomach acid at that baseline first thing in the morning. And so if the patient takes a burp test and it takes longer than 5 minutes to burp, then I'll tell them we can take it to the bank that one issue here is low stomach acid. And there's resolution strategies that we can look at to help address that. But this is foundational to health. As a dental surgeon, if my patient has low stomach acid, the reason I care about that is when I put an implant in the mouth, I expect that to integrate and heal with the bone. If they're not absorbing nutrients, if they're not extracting their minerals from the essential minerals from their diet, they're not going to heal, and we're not going to get the healing outcomes that we'd want to see. If we're trying to remineralize teeth, but the mouth is still acidic because there's some gastric reflux because of low stomach acid, that we're not going to be able to remineralize the teeth and reverse the decay process. So lots of things that this is connected to. So this is foundational, and I start with this with a lot of my patients. Here's a research study looking at the gut microbiome and how that triggers autoimmunity and can affect immune dysregulation. I should point out here, there's a number right here. All of the research articles that I share, all the peer-reviewed research is going to have this PMID number. That refers to the PubMed identification. PubMed is a government website, if you're not familiar with it, and it's kind of a clearinghouse for all the published literature. And so as I'm sharing these things, if any of these research articles interest you, you can make note of that PMID, and what you would do is just on the PubMed website, you enter that number into the web search, and it'll pull up that exact article. And I'd invite you to do that. I think it's important for us to, if we're relying on what we learned in dental school and what we learned in dental hygiene school or medical school to guide our practice today, we're way behind the curve. Because it takes a long time from this published article in 2023 for it to distill its way down into the curriculum in our professional training programs. Sadly, that's how it is. And so we need to take responsibility for our own learning. Here's another article showing that the gut biome contributes to rheumatoid arthritis. And then this is an article I really loved. I found this is published last year in the Journal of Translational Medicine. And it showed that dysregulation in the oral microbiome, so this was specifically looking at the profile of the biome in the mouth and how it can trigger autoimmune diseases. And it shows several mechanisms by which that can happen. This is just a little snip from that article, but the oral biome will trigger autoimmunity via microbial translocation, molecular mimicry, autoantigen production, amplification of the immune response. And this is a diagram. It's a very busy diagram, a lot going on here, but up in the upper right, microbial translocation refers to what I was just touching on, where if there's an inadequate barrier of stomach acid, some of these unhealthy dysregulation of the biome in the mouth can translate to microbes getting in through the intestinal lining, and then that triggers an inflammatory response. And there's a release of inflammatory cytokines, and those aren't just locally released, they're getting into the bloodstream and going to result in systemic inflammation, which leads to a breakdown of some of these tolerance mechanisms. Up in the upper right, molecular mimicry. This is a fun one where foreign molecules that are in the oral cavity will mimic self or our own molecules. A classic example of this is rheumatic fever. You remember that there were antibiotic recommendations for heart damage due to rheumatic fever. Well, rheumatic fever, the reason we have heart damage is it's an infection caused by a streptococcus bacteria, but it results in an immune response that cross-reacts with our own heart tissue, leading to inflammation and damage of the heart tissue. Autoantigen overproduction, that's what autoantigens are, antigens against self. And so if there's an overproduction of those, that's going to lead to autoimmunity. And then that cytokine storm that results from all of these things is going to ramp up that immune system to the point where it overpowers the controls that are in place. And there's a quote from that article. I don't read my slides, but this is one that I'm going to read. Due to the indispensable role of oral microbiota in the initiation and progression of autoimmune diseases, targeting the oral microbiota might be an effective strategy for preventing and treating autoimmune diseases. So what we do every day in attempting to balance the oral microbiome is an effective way to treat and prevent autoimmune disease. And we're talking about good oral hygiene behaviors, low carbohydrate diets, maintaining a healthy lifestyle. In addition to these things, the use of probiotics and prebiotics and symbiotics will help reverse the dysbiosis in the oral environment. It's also been demonstrated that prebiotics enhance the production of beneficial metabolites by these bacteria, which will also further improve the gut barrier. On the right, you see OMT. That's referring to oral microbiota transplantation. And these are kind of new and novel techniques that are discussed in this one research article. But this is similar to fecal transplants. You've heard of that, where oral bacteria can be encapsulated and taken as a kind of a probiotic from healthy individuals into the mouth of someone who has a severe dysbiosis, and that can help balance that out. And fecal transplants are done similarly to help solve some intestinal dysbioses. And there's been some fun case studies of reversal of autoimmune diseases. Well, a lot of conditions that we don't associate with the gut that are improved on by fecal transplants. Nanomedicine, that's very much in the forefront. That's using a little small RNA to block the translation of specific RNA sequences into inflammatory proteins. Personally, I like the approach of the Greek physician Hippocrates, who said, let food be thy medicine and medicine be thy food. So this is what I do. I recommend and share with all my patients the virtues of fermentation and fermented foods. This is a sampling from my basement refrigerator. Full disclosure, I'm like an 86-year-old grandma. I like to ferment and can. I do canning, preserving foods. This is one of the things this is one of my happy places here. And so this is a sampling from my refrigerator. And this is full of healthy probiotics. These items came directly from my garden into the crock where they fermented with we controlled growth of healthy bacteria. And these jars are full of all these healing factors that are mentioned in that research article. And for any of you who are interested in fermenting, you can take a screenshot here. It's the easiest thing in the world to do. You start with good organic, clean fruits and vegetables. I get a good garden every year, and so I'll take from my garden what we don't eat immediately, and we'll do some fermentation and preservation. You wash and clean, you cut them up into consistent small pieces, and then you put them in. I just use glass mason jars, and you allow that to ferment. You use a starter. You can get some juice from a store-bought sauerkraut or fermented vegetables to add to it. I'll use the juice from my previous batch. You can just use salted water or celery juice as a starter culture. And then you set them on the counter in an area where they're not in direct sunlight. They're not going to be disturbed. And you let the flavors ripen and enrich. And then once they've fermented to the right point, you store them in the fridge for months if they last that long. But anyway, that's one approach to naturally supporting the oral microbiome. And it's kind of fun. It's something that I geek out about. I love fermentation and so many health benefits. For those who have low stomach acid, I believe that you take what you don't make. Meaning if the body's not producing enough stomach acid, I might need to supplement that hydrochloric acid. And this is one supplement that we carry in our office. There's other ones that are available, but this is actually, Zypan is actually a hydrochloric acid tablet. So if you go home and you take the burp test and you find that you have low stomach acid, the first thing you're going to do as you're building up your gut and doing all the nutritional things you need to support that stomach acid production, you might take with each meal 2 to 4 of these little acid tablets to jumpstart the stomach acid in preparation for digesting your food. Now, of course, well, it's a whole course in and of itself discussing stomach acid, but that just kind of is an introduction to the importance of that role. So the next thing, we've touched on these first two, the oral and gut dysbiosis and stomach acid and leaky gut. So we're going to move on to the next couple. Infectious pathology in the teeth and the jaws can also be a cause of release of inflammatory cytokines and increased systemic inflammation. Here's an article by, let's see, in 2000. So it's not a new article. And this is information that we're all familiar with. I think this group understands the oral connection very well, especially as it pertains to periodontal disease. And like I said, this article just verifies that there's high inflammatory cytokines in patients with periodontal disease. This next article is an important one for the dental realm because the oral systemic connection is so well understood and has been elucidated as it pertains to periodontal disease. This article is looking at periapical lesions and periapical disease. And what they found is similar systemic effects from periapical lesions that they'll see in periodontal disease, meaning an infected root canal is, as far as the body is concerned, the same as a severe periodontal disease. So there's no difference between this and this insofar as how the body reacts to it. And so subsequently, there's been some interesting studies looking at that and what the effect is of removing jawbone infections and how that's lead to resolution of the autoimmune crisis. This is a case report by Dr. Johann Lechner. He's one of the thought leaders in jaw pathology and infective jaw pathology and the effect that it has on cytokine expression and inflammatory disease. And what this is going to look at here, this case report that we'll share together, is the cytokine expression before and after the removal of these infectious areas. So Dr. Lechner uses what's called transalveolar bone densitometry with ultrasound. It's TAU, tau. His tau system is able to, using ultrasound, get measurements of differential bone density in the jaws. And so what we see along the bottom of the slide here, those little colored circles, those are taking slices at each of these tooth sites through the jaw and looking at the bone density. Green is solid, healthy, cancellous bone, and the red and the orange then is areas of reduced bone density, which are suspicious of cavitational osteonecrosis or fatty degenerative osteonecrosis of the jaws. There's a few different terms that are used in the literature. And then in this published article, he went through and then confirmed those same units with a CBCT evaluation and Hounsfield units. Anyway, for this patient, what Dr. Lechner and his colleagues did is they identified this patient was in autoimmune crisis. They went through and removed the areas of fatty degenerative osteonecrosis in all quadrants of the mouth. Where it was associated with titanium implants, those implants were removed. Where the root canals were infected, those infected root canals were all removed. And he followed up by placing immediate ceramic dental implants. Any bone augmentation done was used was done using autologous bone. So there was no foreign material introduced into the patient's body. And then Dr. Lechner took histology samples from each of those surgical sites. And what he found, as compared to normal healthy bone, is about 1,300% increase in inflammatory cytokines, local inflammatory response. And then when these are removed, the results are this individual who had severe dermatitis and was in autoimmune crisis gets her life back. One of my favorite movies. I really believe that, my presentations always have movie quotes because I like a good movie. But I really believe that this is a life or death issue. Our generation, we're going to be dying from diseases of inflammation. Among the top 10 causes of death in the United States, cardiovascular disease, Alzheimer's, diabetes, cancers, all those are diseases of inflammation. So this really is a choice of we got to get busy living or get busy dying. Now, at this point, as I'm preparing my presentation, my older son looks over my shoulder and he says, "Dad, stop pretending you're a real doctor. You're a dentist. All you need to know is how to count to 32. Thank you, Isaac. Here's another similar case of an individual who was in an autoimmune crisis. And what we found here is that the dental infection was a prime cause of his autoimmune disorders and required, again, a surgical intervention. And what I love about this is that ozone therapy was introduced as one of the healing modalities. This is he's a field worker. This farmhand was found. He was on ultra high doses of prednisone just to control his symptoms enough so that he could work out in the field and earn a living for himself. When Dr. Robbins found him, or Dr. Rollins, he suspected dental contribution here. And so what he convinced this individual to go see his dental professional, and sure enough, there were failed root canals and teeth numbers 7, 8, and 9 that were removed, and then some osteonecrosis at a wisdom tooth site that had to be cleaned out. And then he had more definitive dental work, had 3 other root canals removed or infected teeth removed. And what we see is almost complete resolution of this autoimmune dermatitis. This is his arm rash, completely gone. And just look at the change in his countenance. What's interesting here too, about 3 years later, this individual started noticing a return of some of the joint aches and some faint skin blotches. And within 2 weeks of that happening, his dentist had to remove 2 more infected teeth, numbers 2 and 15, and his symptoms resolved virtually immediately. So a powerful case illustrating the effect that infections in the mouth can have on autoimmunity. Now, this last one, this is something that unfortunately, as professionals, we've been doing to our clientele, and that's the metal implantation. This is in 2019, the FDA came out with this paper looking at the biological responses to metal implants. But let's look at some of their findings regarding this disease process of inflammatory disease process. We have bacterial colonization of these metal implant alloys. They contribute to the pathogenicity of the bacteria. There's nickel in a lot of these alloys, and the lipopolysaccharides, the bacterial endotoxins, corrode or lead to corrosion of these metals and failure around implants. And by the way, that nickel is one that's associated with Alzheimer's disease in the literature. Metal reactivity may result in generalized pain, fever, syncope, palpitations, arrhythmia, serosal effusions, vasculitis, hair loss, poor wound healing, dermal rash, eczema, etc. All those are, or many of those can be connected with autoimmune responses. In the International Journal of Implant Dentistry, this article came out showing that titanium ions are deposited systemically and they can lead to toxic reactions. Here's a case that we saw in our office. Sadly, I would have to admit that in the past, I probably would have been excited to have a patient walk into my clinic ready to have an implant restored. But you can see the implant in that lower right area, excuse me. Patient came in saying, I feel like I have infection in my jaws. The dentist says there's nothing here. I've had a low-grade fever for 5 years, have heart issues. This is the radiograph. And what would you say about this implant? I look at it, I wouldn't have said that there's anything remarkable. But then we investigated a little bit further. We took the little healing cap off and notice how that implant screw is just coated with, what is that? That's pus. That's a little biofilm. We look down inside that implant and we're going to see there's just this schmutz, all this bacterial gunk that's been building up over time. Well, that implant came out, and I don't know if you can appreciate on the image here, but there's all the little bubbles and little fatty vesicles. That's that fatty degenerative osteonecrosis that Dr. Lechner referred to in his paper. Anyway, another article here showing that titanium particles are released from the peri-implant tissues. This is in the Journal of Periodontology. And what happens is the macrophages, those immune cells, go around and they start absorbing and try to eat up these titanium particles. And it results in, and then they release their inflammatory cytokines. But the problem is the macrophages don't have any way to break down and dissolve that titanium that they've absorbed. And so there's this chronic inflammatory release because of the titanium that's released into the tissue. And those macrophages, depending on the type of cytokines they release, they're responsible for both reparative and destructive processes. And if we move on to the left side, so M1, M2, that refers to our two types of macrophages. The M1s are the killer macrophages, the ones that are releasing the inflammatory damaging cytokines. And then the M2s are what's leading to cell proliferation and healing. And there's this whole cascade of what titanium and metal implants can lead to in the body. And all these are, inflammatory diseases. So what's the solution? Instead of using metals in the body, maybe we look at ceramic implantation. Now, here's an article. The literature available indicates that there's an increased risk of allergies due to titanium exposure, meaning that immune response because of the implanted metals is leading to just systemic hypersensitivity, which makes individuals more susceptible to the development of other allergies. And these authors suggest that little hypersensitivity and material testing be done to determine what's suitable for our patients. Individuals with autoimmune diseases were found to have a higher concentration of blood mercury. And I love this article because it looked at many different forms of mercury, organic mercury, inorganic mercury, methyl mercury, all these. And they found that every form of mercury is associated with some autoimmunity and inflammation. This is an interesting one for those of you who have your cell phone sitting on the table next to you there. This study shows that the electromagnetic radiation emitted from just mobile cell phone use will increase reacts enough with the mercury amalgams in the mouth to increase the amount of mercury that's released. I'm going to share another case with you. This is one from our practice. And I just invite you to listen to her own words. And while we're listening to her, look at her countenance and her coloring and tell me if you feel like she looks like a happy, healthy person.
And can you please tell us what brought you here and a history of your health concerns? have Lyme disease, chronic, for a long time. And as I work with Dr. Klinghart's associates, I'm told that I need to get the metal out of my mouth, including about 19 root canals. I also have some implants as well. And it's pretty traumatic because that's really major for me because I teach singing and I use mouth resonance all the time. So I need to know how that will affect me and what I will have to do to adjust to all of that. The Lyme disease has had a lot of co-infections. I've had some gut problems that started in 1993 and they have flared up recently, especially post-COVID. So I'm a little concerned about the general overall health that I have.
So this is how Ada came to our office. She wanted to get all the metals out of her mouth. And I'm looking at this and I'm just thinking, are you sure about that? Not a, this is a real complex case, not an easy one. And then you start looking closer in her mouth and we see these periapical radiolucencies, the implanted titanium alloys. And you have to ask yourself, based on what we've been looking at in the published research, is it any wonder that she has these chronic health issues? She's got this, and tell me if you see any signs of autoimmunity here. There's a chronic bacterial infection. She has a rash, history of joint pain. She's got diabetes or pre-diabetes. And so with what we've reviewed together, what would we need to do here? Well, I like this example. Here's this little fish swimming around in the tank, and this fish is starting to act kind of sick. How would you treat this sick fish? Do we medicate the fish or do we clean up the tank? And my argument is the first step that we should be looking at is ways that we can clean up the tank. And in Ada's case, well, she was so heavily restored, and it was some nice dental work done. I think the dentist that did this rehab probably feels pretty good about what they did. But what they may not feel good about is what we needed to do for her. And so we went in and we cleaned out all the metals and the root canals and placed a ceramic prostheses in there, top and bottom. She had some virgin untouched teeth, but she went from this to this. Now, this is 24 hours later. So the day after the surgical procedure, we fitted her with, full mouth temporary splinted temporary restorations. And this is how she left the office. She went back home and we let things heal. She comes back in a month. And then, of course, the temporaries don't look as pretty as they did before. They've yellowed. There's been some shrinkage and recession. But I want you to look at the gum tissue here compared to, let's see, where does she first present? I want to back up to the very first photo there. Look at the tissue here around these metal PFMs compared to the tissue at 1 month. And she's not able to maintain good oral hygiene. These are all splinted temporaries. She's doing her best. But the tissue loves that ceramic material as compared to the metals. It looks healthier here than it did in her initial photos. Well, this is after 3 months of healing, and you can look at that tissue response. Finally, we took the temporaries off and she's able to clean around underneath there, but it's beautiful response in these tissue level implants. That's the lower. And then we went ahead and restored her with all ceramic individual crowns, upper and lower. And this is where we went, or this is where we started, and this is where it took her. This individual who's in an autoimmune crisis had complete resolution of all these symptoms. And just look at her coloring, look at her countenance. She looks more vibrant and healthy. Just a great. This is our privilege to be able to bring this type of healing to our clients. And one more movie quote. Love that. If it wasn't hard, everyone would do it. The hard is what makes it great. And this is our opportunity. You know, we need to embrace the hard and and step outside of the traditional boundaries and become and embrace our role as oral health physicians. Um, I think we have some time for questions. I thank you so much for your attention, and I'm so excited at opening our eyes to how we can have an effect on these significant health issues that are plaguing our population.
Guys, real quickly before we get into questions, if you will leave that screen up for us, Dr. Montez, that is our way that everyone can access how to get credit for today's for your presentation. So we'll put this up every time, guys, that we have a presentation, and I'll have Danielle put the link up as well in the chat. That was incredible. That was absolutely incredible. Thank you so
Thank you
much.
very
That
much.
was
My
absolutely
pleasure.
incredible. So I want to share some comments and some questions as well. So Cheryl Scott was saying that bleeding gums is the same as a leaky gut. That was one of the comments that we had.
That's a great comment. And you're right. And we see the connection between when that dysbiosis in the mouth transfers to the gut and why it self-perpetuates itself. And we need to get to the root of solving it.
Yeah, absolutely. And one of the questions that we have from Nicola was, how do GIP-1 meds affect stomach acid?
So there's so many the pharmacological approaches, the GIP-1, you know, specifically, all those are going to have a negative impact on that stomach acid production. And so that's why, again, I a couple years ago at the midwinter meeting here, I gave an hour-long lecture just on stomach acid production and the nutritionals that are necessary to help support stomach acid production. But there's about 8 things that we want to be having our patients starting to take to, because the medications that are given for, you know, acid reflux, these acid blockers, they just make the root problem worse. And so we need to understand the physiology, and it's a little beyond the purview of our discussion this morning, but understand the physiology, what's necessary to support proper stomach acid production.
Absolutely. So another question was, what is your method to identify cavitation?
So I think the gold standard nowadays would be Dr. Lechner's tau, which is the ultrasound unit that he's developing. And I don't think it's available in the United States yet. So it's really exciting to have that being coming out soon. But we're using cone beam imaging and taking slices through the jawbone and comparing healthy areas of bone with areas of decreased bone density and the Hounsfield units, which most of our imaging software is able to give us those Hounsfield units if we calibrate it to it.
Someone asked, Mark Smith, can we get a list of your referenced articles?
Yes, absolutely. I'd be happy to provide that for you.
Absolutely. So if you will provide that to us, what we'll do, guys, is we will include, we can actually send that out to everyone as a link when we send out the email that has how you can access these recordings after the fact. So just really, and Beth, I believe it's Meglin. Beth Meglin says, I wish I worked with you. So that's a real compliment. So there you go,
Thank you.
Dr. Montez. It's a real compliment. So one of the things that we'll do, everyone, with your recordings is when we finish up today, I will try my best this evening or first thing in the morning. It'll definitely be by tomorrow, this time, well, by tomorrow afternoon. I'm going to load the recordings up to Venmo and then, or Vimeo, I'm sorry, to Vimeo. And we will load these recordings up and you will have access via password. What I'll do is send out an email to everyone who paid today so that we've got some folks who have already reached out to us and said, I want to watch these so bad, but I just can't be here today. And they paid. So I want to make sure everybody gets access. You'll have access for 90 days to the recordings in case you missed something or you want to go back and watch it and you're like, man, that was such a great presentation. And I really want to go back and I want to see something. I want to catch something. I want to be engaged with something on there. So we will definitely get those to you. They are password protected. I ask that you not share the password with folks because it kind of, defeats the purpose of you paying if you share the password. So you ought to be sure that you keep that to yourself and that you can go back and access it. And then after 90 days, we'll close that window up and then we'll offer the recordings up for people to purchase. But we want to make sure that you guys get 90 days to be able to enjoy those and be able to watch and apply for credit for anything that you might have missed. So again, up on the screen is how you claim. You can scan the QR code or you can use the link to get those credits. So I want to open up for any more questions. I actually have a question for you. So I'll tell that everyone kind of already knows my story a little bit, but I've had a mouthful of let's see, the ADA, well, we'll get into me. I'm not important. Olena Lambert, the ADA shared an article this week in the Daily Huddle email indicating that ceramic dental implants have lower long term survival compared to titanium implants. Thoughts on this?
Yeah, they're ceramic implants require because of the true osseointegration that takes place around that ceramic implant. You need to have a good host response to receive it, and the healing is excellent in the right conditions. That's why I lecture about these things, because every patient, before I touch them in the surgical operatory, we're making sure that their nutritional status, their stress, and all the other things that contribute to good healing outcomes are in place so that we get good outcomes. Now, and a lot of surgeons are placing ceramic implants now that have been placing titanium, and they're placing them as if they were titanium. It's a different material, and you have to understand how to work with it and how to use it properly.
Yeah.
Um,
Well, I feel great that I got a titanium or the start of a titanium implant just a few days ago. I've had a mouthful of dental issues growing up in rural Appalachia. Didn't have the growing up very poor, didn't have the world's best dental care and paying a price for it now. But I have a mouthful of ceramic zirconia now crowns and a zirconia bridge, but these implants they're putting in are titanium, and boy has it been an experience. So I'm hopeful that everything we did some work on the bone and some work on the gums. So I'm hoping everything looks as good and stays as good as it possibly can so that I don't
Me
lose.
too.
I got a lot of money invested in my mouth right now, so I'm hoping that it lasts for a while. So hopeful on that. So
Just one more comment. The question was asked about the GLP-1 medications, and they're so prevalent right now.
oh
I
yeah,
mean,
everybody's doing it.
everyone's doing it.
Yeah.
The way those work is it slows down the gut mobility, gut motility. We talked about stomach acid, but another factor is as that gut motility is slowed down, the food spends more time putrefying in the intestines, and so then that further exacerbates that little inflammatory response that we showed in that one slide where unhealthy byproducts of that putrefaction is slowly being absorbed by the intestines and leading to all kinds of systemic inflammation. And I think we're going to see a huge uptick in inflammatory diseases because of these medications.
Yeah. So I have a question from Sarah Jensen. She says, I take Zypan with every meal, so I was happy to see that recommendation. Do you have any other tips on how to increase and have a healthy level of stomach acid, like stress management, not eating when stressed, etc.?
Yeah, there's so the stress management is number one on the list of what I call the grade eight. We have to balance that balance the autonomic nervous system, get out of fight or flight mode. It doesn't just happen. We have to carve out time to reduce and mitigate stress. But then we need to have adequate sources of magnesium, vitamins, let's see, magnesium, iodine, zinc, vitamin B1 or thiamine, uh, salt, potassium, and stay well hydrated. Those are kind of the 8 things. So getting out of stress and make sure you have those essential nutrients in place, all of which, like I said, this is a whole lecture in and of itself, but all those nutrients support good stomach acid production. So go back and review this little recording here and then write each of those down.
Yeah, absolutely. Someone said also bitters and chewing thoroughly, Cheryl Scott,
Yes.
in helping with that as well. Absolutely. It is, chewing thoroughly is so important. I know people, we tend to be in such a busy world that we, eat it, swallow, chew as fast as we can, swallow it and get it
But
down.
that stimulates those digestive secretions. And then, yes, digestive bitters will also stimulate the secretions of in the digestive system, including stomach acid production.
Absolutely. Absolutely. So, guys, I'll give it another minute for questions. Dr. Montez, please don't be a stranger. We love you here at aaosh, and we absolutely love it when you come and speak for us. We are always thrilled to learn from you and your
I feel
knowledge.
blessed to be part of a team of such professionals.
Well,
Uh,
we're grateful for you. So we are, guys. This has been a great presentation, and we're always looking for folks. If you are, also I'll say this: we have a lot of professionals on here. If you're interested in speaking for us, we have the ability to. We actually have a great programming committee this year that has the ability to be able to read through abstracts and create a speakers bureau. And Dr. Montez is a part of our speakers bureau now, so we are always looking for new speakers and for folks to come on board. If you're interested in doing something like this for us, we would love to be able to have the opportunity to read your abstract and see if you are, if you are one of the hundreds of speakers now that we have that are part of our speakers bureau. We would love to bring you on board. So I'll have Danielle at some point today put up where you can submit abstracts to us. We would love to hear what you have to share. That's one of the things that makes this organization great, is that this is a place where you can bring multiple opinions to the table, and we want to hear them all. We want to hear what people have to say, and we want to feel that this is a space where differing opinions are welcomed and where everyone is allowed to come and share what they know with everyone in a way that is scientific and in a way that is practical, in a way that helps grow your practice, grow your business, help your patients, and save lives. So, Dr. Montez, I think we are done for the day. Thank you for getting up so early with us this morning. I
yes,
know
I was an early riser too today.
super early. Yes, super early. Thank you so much for your willingness to come on with us today. Everybody, I see a lot of hands going up in the air and a lot of hearts. So I love seeing that. A lot of celebrations. That's fabulous. Thank you
Thank
so
you.
much. And we are so grateful for you. Wait a minute. I see something in question and answer. Hold on just a second. Oh, so that one was answered. We answered that live.
All right,
So
thank you. God bless
thank
you.
you. Thank you so much for coming on with us today. And you're welcome to stick around. If you need a link to come back into this as as a participant, let Danielle know and she'll get you one, and we'll do that. But thank you so much for being with us today. We are so grateful, and don't be a stranger. Come back around again soon.
Thank you.
Absolutely. So, guys, let's real quickly. I want to go through. I want to talk to you for just a few minutes about something, and then we'll take a real quick break. So, let's let me, Danielle. I'm trying to share my screen, and my computer's being a little. Okay, so now I think everybody can share my screen. So let's go to. So we're going to talk for a minute about, you want to talk about the aaosh getting back to their roots. We've never really gotten away from Beldonine, but we are certainly going to get back to our roots. So one of our great sustaining partners this year is Beldonine and the Beldonine method. And we are so pleased to be able to bring Beldonine back as a partner with us. And we are just super thrilled to have this opportunity to talk about Beldonine as oops, I think everybody can see my notes. Hold on just a minute. Let me swap displays. There we go. Danielle, how is that? Is that, can
Perfect. That was
Okay,
great.
there we go. So nobody needs to see my notes. Y'all don't need to see those. So let me talk to you guys for just a few minutes about Beldonine. I know everyone in here, if you're a fan of aaosh, you know Beldonine and you know the importance that Beldonine brings to this organization and what it represents. So for Beldonine, we know that heart attacks are optional, strokes are optional, that high blood pressure is optional, and we are just so thrilled to have Beldonine back with us. So I'm pleased to present our very first great partner of the day, the Beldonine Method and the Preceptorship. So what is the Beldonine Method? Well, the Beldonine Method enhances and saves lives by offering a cure for arterial disease. It is a science-based methodology designed to establish arterial wellness. Clinical application not only prevents symptomatic heart attacks and ischemic strokes, but also the more common asymptomatic arterial damage. The more prevalent silent injuries lead to many chronic diseases of aging, such as dementia, heart failure, kidney failure, peripheral artery disease, erectile dysfunction, and visual impairment. In achieving arterial health is necessary to maintain wellness throughout life. The Beldonine method provides an opportunity for individuals to have a health span that matches their lifespan. The Beldonine Preceptorship has been dedicated to offering education in support of the method through a 2-day program attended by both medical and dental providers. As a result of COVID-19, the Beldonine method modified its in-person event to a virtual live stream event, and the response has just been overwhelming. And we have the opportunity here at aaosh to offer our members a very special rate for Beldonine. So one of the great things that we get to offer is this 16 hours of credit, along with the opportunity to become an aaosh member. So here's a couple of things that we're going to offer today. So the Beldonine Preceptorship, just so you know, this course will teach healthcare providers necessary measures to prevent heart attacks, ischemic strokes, and type 2 diabetes. The intensive presentations use an interactive format of CV prevention. Continually updated literature and sound, measurable, evidence-based science and peer-reviewed journals are utilized in this dynamic method of prevention that applies research directly to the clinical setting. You will return to your practice with tools to help you implement what you've learned about optimal care and CVD prevention. This course welcomes all medical providers as well as dental providers who are interested in patient wellness, the prevention of heart attacks, ischemic strokes, and diabetes. The Beldonine method was co-founded by Bradley Bell and Amy Donine for the prevention of heart attacks, ischemic strokes, and diabetes. The Beldonine method is designed to improve and save lives and is being integrated into practice by medical and dental providers on a global basis. We hope that if you're not an aaosh member, you will join us today so that you can take advantage of this incredible rate and bonus that is being offered in addition to the discounted rate. So we hope that you're an aaosh member. If you're not today, we're going to offer you 30% off our membership if you use the code WINNER30 at checkout. Once you become a member, then you can get access to the Beldonine method at the price of $9.49 for this program. That is a huge savings on this preceptorship. Plus, they will give you 1 month of the Beldonine signature membership program for free. That's $149 value. So once you finish the Beldonine preceptorship, I'll tell you, our current board president, Dr. Mike Zubiak, has gone through this program twice. One of our former board members, Dr. Ellie Campbell, loves this program, has based her career on the Beldonine method and absolutely loves it, lives by it, and she will be the first to tell you, even in her book, that heart attacks are optional, that strokes are optional, that you can save people's lives by understanding how the mouth and what's going on in the mouth is connected to so much that goes on through the rest of the body and how it affects the heart. And I think bringing Belladonna first on today, especially with it being Go Red for Women Day, is so important to understand that you can save lives and there is a cure for arterial disease. So we hope that you will take advantage today of this offering. This is special for today, and that Winter 30 deal will only be through today. We'll take that discount code off after today's session, but we do hope that you will take advantage of the Belladonna method, their training, and also too, once you've trained, you can come hear Amy and Brad speak at our annual session, which we are so thrilled to be able to announce them as speakers today. That was our first big speaker announcement that we were thrilled to make today. So I'm going to stop sharing here for just a moment and bring everyone kind of back. We're going to take, Dr. Katie Lee, we're going to take just a few minutes of a break to give everybody a chance to run take a bio break for just a minute. And then once we bio break for just a few minutes, what we'll do is take 5 minutes, folks. So that's what we'll do. We'll take 5 minutes, let everybody take a bio break, which I think will still get us, we'll still be pretty close. Yeah, let's take a bio break for 5 minutes. And then when we come back, what I'll do, Dr. Lee, if you want to go ahead and pull up your presentation, what I'll do is introduce you. We'll go through your presentation, do those few slides that we have to do in the beginning. Then I'll introduce you and we'll go through your slides. But let's go ahead and take a 5-minute bio break, guys, and we'll come back in 5 minutes. So everybody go ahead and take a break. We'll see you in 5 minutes. Hi, everyone. I'll give everybody a chance to get back in to the room. I just wanted to come on and um, again thank Dr. Montez for his presentation and kind of give a little bit of update on time. It looks like we're running right on schedule, which is fabulous. I'm so glad to see that. Hopefully, we'll continue to do so all day. And we're actually running a little ahead of schedule. So while we're ahead of schedule, a couple of a real quick reminders that I can give everyone. If you have not signed up for a webinar series, please do so. We are um, we are really excited about a lot of our webinar speakers. Our next speaker that's coming up is actually Dr. Ellie Campbell, who used to be on our aaosh board of directors, who's now moved on to our advisory council, which is an honor, is always an honor to serve on our advisory council, because that's all of our leadership from all of the years. That's Brad and Amy from the Belden E Method are on there. Dr. Chris Kammer's on there. Dr. Mark Cannon, Susan Estep, Susan Maples. That's all. We call that our wisdom board. That's our board of wisdom from all of these years that's joined us. So we're always so glad to see our board that break down, come on down into that wisdom group. So we're always thrilled to see those folks make that progression. So we are so thrilled to have Dr. Campbell. Dr. Alan Reisinger is also speaking this month, and we also believe that the Beldoni Method will be speaking for us also this month. So we have a great lineup of speakers in our webinar series as well. Webinars are open to everyone to attend. aaosh members get credit. So if you are not attending our webinar series, please come join us for those. They are so great. Dr. Katie Lee's done a webinar for us before, so we are always thrilled to see folks who come back and join us. So we will most certainly have a great lineup this year that we want to share with you. And we have so much great education this year. And it's one of the things that I'm so thrilled about, is that we have such a great lineup of speakers for this year. And I've already seen Carly Nelson's already said, Dr. Katie Lee is awesome. So great to see her here at aaosh. So you already have a fan club here, Dr. Lee, with you. So it's great to see that. And we're thrilled to have you. It's always a great day to see you involved in this. So let's let everybody, give them just a minute to kind of trickle in here. And I've had a request for a link. Let me grab, why did that do a thumbs down? I didn't mean to do that. We'll do that. We'll do a thumbs up. That's terrible. I don't know why it did that. I'm thumbing down myself. So please don't think that was me. I'll thumb myself down here.
I was gonna say
Um,
someone's booing me already.
no, it's me. It's me. It's my fault. So I'll do a thumbs up, and that'll take care of it. So let's see. That was me. That was my poor thumb that didn't quite get the. So let me get everybody the Belloni preceptorship. So if you go, uh, Philip, there you go. That will take you to aaosh's website, to the Belloni preceptorship, and that will lead you through to where you need to go to. And let me make sure on our page that it's taking you to Beldamine. Hopefully we got you to the right place. So Philip, I will work on that as we are. I'll make sure you get where you need to go. So we'll make sure they may be working on their website or something, but we'll make sure. So Dr. Lee, if you want to go ahead and pull up your presentation, you will present your own thing, which is great. We're always thrilled to see folks be able to do their own presentation. So, and I'll talk you through those first few slides so you don't have to do it.
Okay, can you see my screen?
Hey, Danielle, if you will, will you please give her access to be able to, um,
Yeah, sorry. Can you request it one more time? I guess I missed the dialogue.
Sure, 1 second.
There we go.
Beautiful. Looks great.
There we go.
Can I use presenter view here? Is this okay?
We see everything.
Oh, you
So,
do. Okay.
yeah, so flip it. I think you can flip yeah. Well, wait a minute. So,
Well, Katie, now that you've started your presentation, you can go in your screen share and select which view you want to share, and you can just select that, not the presenter view, but
It's okay. I
there
can
you
just
go.
use this.
That
Yeah.
works.
okay. Alrighty, so guys, we are so pleased today to present Dr. Katie Lee with Healthy Mouth, Healthy Body is the title of her presentation. So if you want to, Dr. Lee, if you'll go on and click the next slide. So we're going to go through these slides fairly quickly. This is Dr. Lee's conflict of interest statement, which you can see there. We have mitigated all financial relationships. Yep, there's the course information. Next slide. And our accreditation statement, next slide. Disclosure of unlabeled use, next slide. There's the disclaimer, next slide. Method of participation, next slide. And there's the course description. Learning objectives. Our practical applications. And now I'm going to introduce you, which I'm absolutely thrilled to do. So it is my great pleasure to introduce an inspiring leader in dentistry, Dr. Katie Lee. Dr. Lee is not only a highly accomplished dentist, speaker, author, and coach, but she is also a passionate advocate for the connection between oral health and overall well-being. Dr. Lee's journey in dentistry is both remarkable and deeply personal. As a teenager, she was involved in a serious ATV accident that left her without many teeth and a jaw that was immobile. She experienced firsthand how oral health affects systemic health and discovered the life-changing benefits of dental implants. This personal experience became the foundation of her career, driving her passion for dental implants and the mouth-body connection. After graduating from the University of Illinois at Chicago in 2010, Dr. Lee became an owner partner in over 80 DSO supported dental practices across the United States, serving as a clinical partner overseeing 5 states. Today, she continues to make an impact by consulting for health technology companies, providing impact education for general dentists, and treating patients through telehealth. Her passion is twofold: advancing the field of dentistry and helping other dentists succeed. Dr. Lee is also a published author, having written Saved by the Mouth, a book dedicated to educating both patients and clinicians on the critical role of oral health. Her expertise has been recognized with numerous accolades, including being named one of America's top 40 under 40 dentists and International Woman of the Year in Dentistry. She has even been featured on Fox and NBC News, sharing the importance of oral health with a broader audience. Dr. Lee's mission is clear: to advance dentistry, empower her peers, and transform lives through better oral health. So please join me in welcoming the incredible Dr. Katie Lee.
Thank you so much for that introduction. I don't know if I deserve all those words. That was really nice of you. I also have to say, after hearing all of the amazing speakers that have really been pioneers in this field of oral systemic health, I feel totally honored and humbled and a bit nervous to be on this webinar this morning. And
Don't be nervous.
hopefully I can just share some really practical tips about oral systemic health, how to communicate it to your patients, and how to implement it into your practice. Because at the end of the day, we can all be the best clinicians and know all of the science, but if we can't translate that to our actual practices and make our patients healthier, then it's really all for nothing. So I'm known for keeping things super simple and very practical. So I'm really excited to be here. Thank you very much for having me. I know it's really early for some of you. I know it's 7:30 right now where I'm at. So thank you guys all for getting up early and listening to what I have to say. So as Violet mentioned, because of my past, I definitely have a personal tie to oral systemic health. You know, when I was in the ATV accident, I broke every bone in my face from my eyebrows down. I had my jaw wired shut for 8 weeks. And, I couldn't eat any nutritious food. And so I survived off of box mashed potatoes, ice cream, jello, pudding, all the things that you should never eat anyway, let alone when you can't, take care of your mouth. But when I got my wires off, what had happened was my jaw joint actually fused shut. And so I had lockjaw for the next 4 years. And so it took 4 years and 9 reconstructive surgeries for me to be able to open my mouth wide enough to get a toothbrush in and to get my teeth fixed from my dentist, let alone replacing my smile with dental implants. And so during that time, I became very malnourished, and my liver enzyme spiked, my kidneys started shutting down, and then all the mental health issues that come from a teenage girl in high school not being able to smile or talk with her peers or eat lunch in the cafeteria because I had a flipper. It really affected how I view dentistry, and it got me into dentistry, but then it also kind of propelled me into this practice of oral systemic health. Because I've lived the mouth body connection, right? I know what oral systemic health can do to a person if we're not optimally well. And so I've really kind of targeted and grown my practice and my career because of what happened to me in the past. And actually, when I was going through this journey, I started practicing in 2010, as Violet mentioned, and I read Bradley Bale and Amy Doneen's book, Beat the Heart Attack Gene. I want to say it was around 2012, and they had a whole chapter dedicated to oral health. So this was a bit of a full circle moment for me getting on here and then hearing you guys talk about the Bale Doneen preceptorship. So that was really cool. But it really just kind of solidified that, yes, I'm doing the right thing and I need to go down this path. And so I always like to look back at my history and where I've been and my life journeys to help propel me and guide me where to go in the future. And so this reminds me of one of my favorite quotes that I carry with me throughout my life. And that quote is by the beautiful and infamous Maya Angelou. You can't really know where you're going until you know where you've been. So I encourage all of you to rely on your life experiences to help shape your future careers. And when I think about where dentistry is going, I'm getting really excited because, when I started in 2010, right when I was graduating, I remember a study coming out saying that there was a correlation between gum disease and heart disease, just a correlation. It was more of like a, hey, let's pay attention to this. We're not really sure kind of where this is going, but it's something that we should be looking at. And when I first started practicing, patients always came in with bleeding gums. That was quite normal. But they would say, my gums have always bled. And that's just how I am. And my previous dentists have never said anything was wrong. So therefore, I think I am healthy. And to now, when people are actually coming to you and coming to dentists and saying, hey, something is wrong, I'm noticing my gums are bleeding. So we've seen this kind of complete shift to where patients are really now aware that their mouth is affecting the rest of their body. And so when I think about where the future is going in dentistry, I'm getting really excited. But I always like to think about, well, how did we kind of get to where we are going, right? Where did we start and how was that shaping to where we're going? And so I kind of did a little dive into the history of dentistry, and I found this quite fascinating. So dentistry was first recorded in dentistry back in the Sumerian text in 5000 BC. And what they had recorded was that dental disease was caused by tooth worms. And so they kind of had this concept of some sort of parasite or microbe causing dental disease. And then we jump forward to Hippocrates and Aristotle in 500 to 300 BC, where they started talking about the importance of oral health. And Hippocrates is actually the father of medicine. And he is quoted as saying that many diseases start in the mouth, and that actually, I just learned this. He said that if you pull a tooth, it can actually cure arthritis. So the father of modern medicine before Christ actually realized the importance of oral health. But then we see at about 1210 AD, this is when we start to really mess things up. So in France, there was a decision that was made to actually divide dentists or dental practitioners into two groups. And so one group said, okay, we're going to be dental surgeons. We are highly trained. We study dentistry and the oral cavity and try and optimize the types of procedures we perform. And then there was another group of barbers who said, hey, look, we have super sharp tools that we use to cut people's hair. And so therefore we can use those tools to also do dentistry. So you could go see your barber, you could get a haircut, you could get your teeth cleaned, and then get your teeth extracted. And of course, back then they weren't using any anesthetics. And so that's kind of where this idea of dentists doing barbaric, painful procedures really came into. And so you see that as a profession, they started dividing themselves back in 1210 AD. Then we move forward, we see Pierre Fauchard. He is known for being the father of modern dentistry. He wrote a textbook called The Surgeon Dentist, and this was really the first time that someone really documented the oral anatomy and talked about different procedures and different techniques for restorative dentistry and oral surgery. John Baker moved to the US from England to be the first US dentist. And then actually Paul Revere is quite famous in dentistry. So not only was he a very infamous soldier in the Revolutionary War, but he was also a silversmith. And so naturally, being a silversmith, that makes you a great dentist. So he actually advertised his services in the local newspapers to provide dental services during the war. And he's actually credited with being the first person to invent, come up with, and use the idea of using dental records to identify bodies post-mortem. So that was from our good friend, Paul Revere. I think he was also George Washington's dentist, if I'm not mistaken. But then you see in 1840, we divided ourselves again. So before 1840, even though we had kind of barber surgeons and dental surgeons, we were still really considered part of medicine. But in 1840, we said, nope, we want to do our own thing. And so we formed our own College of Dentistry in Baltimore, Maryland. And that was the complete separation of dentistry from medicine. So now that's when people started considering dentists no longer, physicians of the mouth, but kind of more of a trade. Then we see the Krakow brothers invented amalgam and started the amalgam wars. We see the first female dentist and the first African-American dentist. And then we have kind of a breakthrough. So in 1890, Dr. Willoughby Miller actually published a book called The Microorganisms of the Mouth. And this was really important because this is the first time that dentists and professionals really started to say, hey, look, we think dental disease has a microbial component. So this was a really revolutionary text all the way back in 1890. Where we started looking at the microbiome or getting the concept that the mouth has a oral microbiome. But you can see even in 2025, it's still not widely spread information just yet. But this really sparked people to start paying attention to their oral hygiene, right? We have bugs in the mouth. We need to take care of those bugs. And so we need to start thinking about how we're caring for our mouth. And so actually the first toothbrush was invented or advertised, first commercial toothbrush in 1938. And the advertisement was for a nylon toothbrush. And it actually said, stop chewing on pig hair. Use this nylon toothbrush instead. And so before that, people were used to chewing on sticks, chewing on pig hair, or even ground up oyster shells to help clean their teeth. But now we actually have a toothbrush that people can use. And so we also see implants start to come onto the market. Then we force fluoridation on people in 1945. And then we see lasers and composites and, of course, Brandemark introduction of single tooth dental implants. And so when we think about that, dentistry as a profession, we are really responsible for separating ourselves from medicine. You saw this division between dental surgeons and barber dentists. Then we said, let's do our own dental school and let's take it out of medicine. And that's where we slowly started to shift to becoming more of a trade profession or tooth mechanics. That's what a lot of patients would refer or would say when they would come into my practice, oh, you're just a tooth mechanic. Why are you talking to me about my blood pressure or sleep apnea? You're not my doctor, right? We've all heard that. And so when I'm looking at where is dentistry going, I'm actually really, really excited because all signs are pointing to dentistry being reintegrated into medicine. Couple of things that I'm doing right now that I'm really excited about is I serve as the Chief Clinical Advisor for Dental Innovation Alliance, which is a venture capital group. And the only reason I bring that up is because we actually look at and vet dental technology companies to invest in them, but then we also help mentor and grow them. And the whole idea is, how do we improve healthcare? And many of the companies that we are looking at, we've looked at over 1,000 companies, I believe. Many of those companies are all about oral systemic health and using technologies, diagnostics, AI to help put the mouth back into the body. And so technology is really driving a lot of this reintegration of dentistry into medicine. And so I really see dentists becoming oral medicine specialists in the future. This makes sense, right? And in healthcare or in medicine, we have neurologists, we have cardiologists, we have diabetologists or endocrinologists. And so why can't dentists be specialists of the mouth? We are oral healthcare specialists. And so I'm really excited. And as Violet mentioned, there's tons of incredible pioneers in this space that are really leading the charge and have been leading the charge for decades. And so it's really cool to see all their hard work starting to pay off. And so in the technology space, we're seeing AI coming in, helping us see disease sooner, helping patients see that disease. We're seeing salivary diagnostics coming in, or already in the market, but getting more popular. The ability to diagnose airway disorders is becoming easier and easier. And then we have advanced imaging technologies and software that are helping us catch disease before it causes major issues. And so this whole thing is leading to medical dental integration, which I'm really excited about, and actually get to be a part of. And I'll share this in a bit. So really excited for where dentistry is going. And so this whole idea that the mouth belongs in the body makes sense, right? The mouth is the first and largest entry point into the body. So the fact that we have decided as a group of professionals to take it out and just work on it by itself doesn't make any sense. And when we think about the mouth not only is the entryway into the body, but it is also the beginning of our digestive system. And so the mouth, if you think about it, if the digestive system is just one big long tube and we have gut health, which everyone is really, interested in, it's really in vogue right now. The mouth is the beginning to that system, and it's just a different stop on the same bus route. I read a book called Heal Your Oral Microbiome by Cass Donnelly Nelson. And that's what she says. The mouth is just a different stop on the bus route. So I really like that. That's a good way to explain it to patients. And we know that the mouth is directly connected to our circulatory system and our nervous system through our teeth. And so it only makes sense that what happens to our teeth and in our mouth affect all of the distant organ systems in our body. So I'm really excited that people are starting to recognize this, and that we're putting all the parts back together, because you can't have a healthy body without a healthy mouth. It just doesn't happen. So a lot of docs will say, okay, I understand that the mouth affects the rest of the body, right? But what is the actual mechanism that this takes place? When we think about it, we have over 750 different species in the mouth, and we're swallowing way more than 1 billion bacteria a day, 1 billion, way more than that. And yes, those bacteria that we are swallowing are really important to our overall health. But most of them are actually going to get eradicated in the stomach and the small intestine because of the acidity. The part that really affects our systemic health is bacteria getting into the bloodstream. So how does that actually happen? So what happens is we have a microbiome in our mouth, which all of you know, and that microbiome should be in balance. But when it gets out of balance, the body signals that something is wrong and it's under attack. And so in a very simplistic way of explaining this, the body is going to release white blood cells, and one of them being neutrophils, and they need to get from the bloodstream to the source of infection to eradicate any sort of invader that shouldn't be there. So what happens is, in order for those white blood cells to get to the source of infection, they need to release an enzyme ahead of time to kind of cut through the tissues and pave the way for those white blood cells to get to the bacteria. That enzyme is called MMP8. MMP8 is a collagenase enzyme, which just means that it goes and it cuts through collagen to open up the tissues to allow those white blood cells to get to the source of infection. So even though it's trying to do a good thing by allowing our white blood cells to attack the infection, it actually destroys our tissues. And so when the gum tissue breaks down, that's when the bacteria from the mouth go through the gum tissue, get into the bloodstream, and can circulate the rest of the body. And so I always tell patients, if your gums are bleeding, that is an indicator, could be an indicator that you have what we call leaky gums. So a lot of people are very familiar with the concept leaky gut, right? Everyone loves the gut microbiome right now. Well, there's so many similarities to the mouth here, and I'll get into that in just a minute, but we can have leaky gums just as much as we can have leaky gut. And oftentimes they go together. This is why we see a lot of digestive issues such as Crohn's disease show up first in the mouth. So if we have leaky gut, we oftentimes have leaky gums and vice versa. So oral inflammation via MMP8 is the link between oral systemic health. And so many diseases of the body, anything that is an inflammatory based type of disease is going to be connected to the health of your mouth. And all of these diseases that I've listed here are actually just off of the aaosh website. So these are very readily available for you and your patients to have a look at. But as I said, any inflammatory disease is going to be affected by the mouth. And then there's other things on here like cancer. We have pancreatic cancer and colon cancer. Those are directly affected by oral bacteria. We have fertility issues, which I'm going to spend some time on today. And then even COVID-19, we saw that during the pandemic, patients that had periodontal disease that acquire COVID were 9 times more likely to die because it's all inflammation, right? And so what we're doing as oral healthcare professionals is critical to keeping our patients alive and well. So if we look at the leading causes of death in the US, we see we have heart attack, cancer, respiratory issues, accidents, strokes, Alzheimer's, diabetes, and influenza and pneumonia. And what we know is that, the US, we're one of the wealthiest countries in the world, one of the wealthiest. We also spend the most dollars on healthcare, the most. We spend more on healthcare than anyone else, yet we are one of the sickest countries. We're actually in the bottom. I mean, we're way worse than a lot of third world countries, even that don't even have access to healthcare. So we know that our healthcare system is really designed, it's a prescriptive system, right? It's really designed to take medications to cover up symptoms or make symptoms manageable. It's not designed to help us live a high quality life or get to the root cause of disease. And so I always ask myself, during COVID, our life expectancy actually declined. So despite spending the most on healthcare, our life expectancy has declined, and we don't even have the longest life expectancy in the world. So clearly we are not doing something right. So when we look at the leading causes of death and we say, what do these diseases have in common? Well, most are linked to inflammation. Most are directly linked to bacteria in the mouth. And this is good news because this means that if we can treat bacteria, if we can reduce systemic inflammation, then these diseases should be preventable. The only one that isn't directly linked to this, but I would argue kind of is going to be the airway issues and the accidents, because 25% of accidents are actually caused by airway issues. And so I think we can make that link back to oral health there too. So let's talk about heart disease. I'm going to kind of go very quickly over this because a lot of my information is from Vail and Doneen. And so I know they are much more adept to talk about this than I am. So I'm going to keep it super, super simple here. Heart disease is just going to be any disease or any condition of the heart that affects the heart's functionality. The most common, as you all know, is coronary artery disease that's caused by atherosclerosis or plaque buildup. And the problem with this is that it's inflammatory and we have a chronic process going on. This process typically has no symptoms, very much like periodontal disease. And so what happens is we keep going and going and going. And patients really aren't aware that something is going on until they have an acute event, like a heart attack, AFib, or some sort of heart failure. And what we know is that these acute events are directly caused by high bouts of acute inflammation. So atherosclerosis, I'm going to go real quick here. So we have cholesterol that's floating around in our blood. What's really important to note is that our LDL cholesterol, everyone thinks like, oh, don't eat eggs, don't eat red meat. For cholesterol purposes, there's other reasons why people choose to eat or to not eat those. But what we know is that 80% of our cholesterol is made in our liver. It's actually not real from our food. Only 20% is what we get from our food. And so our body is making LDL cholesterol in response to the inflammation that we have. So we're only making enough cholesterol that the body needs. But if we're chronically inflamed, we're going to have more LDL cholesterol. The macrophages circulating around in our blood system are going to digest that LDL cholesterol and make a foam cell. The foam cells are going to combine with our triglycerides and stick to the inside of our blood vessel, and that's going to cause plaque. Now, what happens is that the oral bacteria, when it's in the bloodstream, there's certain bacteria from the mouth, AAPG, FN, that actually cause the endothelium of the blood vessel to be stickier. And so that increases the ability and the amount of plaque to actually stick to the vessel wall. Now, when we get a plaque that is attaching to the vessel wall, we actually get that vessel wall becomes weakened. And I kind of chuckle about this, but the best way that I explain this to patients is I have this condition that I say of when I am driving my car, curbs always tend to jump out in front of me on my passenger front tire, right? And so I go home, I'm always hitting curbs. My husband looks at my tires and I have these like little bubbles kind of blown out in the sidewall of my tire. I'm not sure if that happens to anyone else, but I'm told that it's typically a female condition that it only affects us females. And so it makes my tire weak. And so if I were to hit a pothole or an obstruction in the road, my tire is going to pop, right? So similar kind of concept. We get a plaque that attaches to the vessel wall. It's going to weaken that vessel wall. We throw inflammation on it, which is like fire. That's going to cause that vessel to rip or that plaque to dislodge. When the body then reclots that, that's when we get a heart attack and stroke. And so if we can prevent not only the attachment of the plaque to the vessel, but if we can prevent that acute bout of inflammation, that's what's going to save our patients from having heart attacks and strokes. Bale and Doneen can say this much more eloquently than I can, so take their preceptorship there. But as dentists, we can lower the bacterial load and we can lower the amount of inflammation coming from the mouth. So we have a direct effect in this. So in summary, how does the mouth affect this process? Well, we know bacteria in the mouth don't stay in the mouth. And we know that the bacteria in the mouth directly increase the stickiness of our blood vessels. And we know that the bacteria cause increased inflammation or acute bouts of inflammation that can cause those clots to dislodge or the vessels to tear. So lower inflammation, lower bacteria, you will help prevent heart attacks and strokes. So if we think about, okay, well, if we can prevent inflammation, then we can prevent a lot of these diseases, especially help prevent a lot of these conditions like heart disease. So let's take a step back further and look at what is actually causing inflammation. Because if some of these have dental components, we can directly go in and affect these and lower systemic loads of inflammation. And so this is straight from one of their papers. And notice that there are so many things that directly cause inflammation that are from the mouth. So we look at karyogenic bacteria. A lot of people say, oh, well, I knew that periodontal disease causes inflammation, but I was unsure about karyogenic bacteria. Well, we know that 50% of infective endocarditis cases actually come from the strep bacteria from the mouth. So yes, karyogenic bacteria do cause systemic inflammation. Endoabscesses. The correlation between endoabscesses and heart attacks and strokes is actually stronger than the correlation between gum inflammation bacteria. And so this is why it is so critical as dentists that we use technologies like CBCT to identify endoabscesses sooner and treat them. So when I went through school, the old adage was, we were only using panos and PAs. We see a lesion, the tooth had a root canal, patient's asymptomatic, maybe it's a scar, right? Maybe it's still healing. Let's measure it in a year and see where we're at. We know that is no longer okay. We need to use higher resolution imaging so that we can actually see these abscesses and get in and treat them, because they are causing a significant amount of systemic burden for our patients. Our patients can have inflammatory marker mutations such as IL-6. I actually have this mutation. This is important to know because that means that my immune system is already primed for inflammation. So any sort of insult that may not affect someone else is going to turn on my immune system. So knowing that for me gives me power to take control of my health and be extra careful about what I'm putting into my body. Insulin resistance is a huge one, and we'll talk about this in a little bit. And this problem is getting worse. I think I read over 40% of Americans are obese now. Childhood obesity is on the rise, which is even more significant and sadder, because these patients are going to get disease a lot sooner than adults who have insulin resistance or diabetes. Obstructive sleep apnea is a big one that's going to cause systemic inflammation, and it's also really hard on the heart and the brain. And then another one that I want to point out is periodontal disease and periodontal pathogens. So a lot of people will say, okay, doc, I know that periodontal disease causes all of these systemic issues, but why is periodontal disease and pathogens separated? And this is because we need to stop thinking about the oral systemic connection in relation to just bone loss, right? Bone loss and periodontal disease is a result of periodontal pathogens causing a disease process. So as clinicians, we typically only treat periodontal pathogens once we see disease, once we see bone loss, tissue loss, attachment loss. Then we say, oh, we need to do something. But what I really want to make sure that everyone gets from this presentation today is it does not matter the amount of bone loss. What matters is that if the microbiome is not in balance, it's causing a systemic immune response, the gums break down, we get leaky gums, the bacteria are now into the bloodstream and causing systemic issues. So the degree of bone loss or the presence of bone loss does not matter in terms of, are these bacteria or bugs affecting the rest of the body? So the presence of periodontal pathogens alone or microbiome dysbiosis is enough to cause systemic issues. Another really big one to point out is alcohol. I think it was Surgeon General came out recently, really putting a major warning on alcohol. And Andrew Huberman has done a whole podcast on this. This is kind of all over right now. Mark Hyman is talking about this. Alcohol, what we know, is really damaging to the microbiome. So we always say, we should avoid mouthwashes that have alcohol in it. Why? Because alcohol is drying to the mouth and it kills 99.9% of bacteria or whatever the claims are. But a lot of people have disassociated alcohol mouthwash with alcohol that we drink. But guess what? It's all the same thing. And so if you are regularly drinking alcohol and consuming, moderate to heavy amounts of it, you're wiping out your microbiome every time you do that. And so be very, very careful about the amount and frequency of alcohol that you drink. And so we used to say, oh, a glass of wine at night is really good at preventing heart disease. Well, number one, we know that that's not true anymore, but we also know that alcohol every night is killing the microbiome. And so as a previous lover of wine and still lover of wine, we need to recognize that we're actually not doing the best for our health there. So just be careful with alcohol. It's my little PSA statement. Everything in light, not even moderation, light use is okay. You still have to live your life. And so some more information here about heart disease. So we know patients who have gum disease are about 30% more likely to develop plaques, but this is key. Poor oral hygiene alone in absence of gum disease is associated with higher levels of cardiovascular disease risk because of that systemic inflammatory burden. And poor oral hygiene, meaning patients that brush less than twice a day, are at much higher risk of suffering a cardiac episode. The other thing that I always tell patients is you have 5 surfaces to your teeth, 5. And the 2 that are most important, or the 2 that are most intimately connected to your blood system, are in between your teeth. So if you are not flossing at least twice a day, so every time you brush, you should floss. If you're not flossing twice a day, you're leaving bacteria present and primed to enter the bloodstream. And so when you brush, you're only hitting 3 of the 5 surfaces, and you're missing the 2 most important ones that are closest to the bloodstream. So make sure that you're flossing also twice a day. Another thing that is really important to note about the importance of our oral microbiome is that it has a critical role in creating nitric oxide. And so the oral microbiome is actually responsible for 25% production of the body's needs of nitric oxide. Now, nitric oxide is really important because it causes vasodilation. And so if you have a patient that has high blood pressure, or anything else that's related to blood flow, you want to make sure that they are getting optimum amounts of nitric oxide to help dilate those blood vessels. So it's really even more important for those patients to have a really well-balanced microbiome so that they can get that nitric oxide production. The correlation between gum disease and stroke is even greater than that of periodontal disease and heart attacks. We know if someone has gum disease, they're 4.5 times more likely to suffer a stroke. And this is because of the restriction of blood flow, right? So when we have inflammation in our blood vessels, that's going to reduce blood flow to the brain. We also know that when we have plaques in our arteries, that reduces blood flow to the brain. And so the greater the disease, the greater the gum disease, the greater the risk for cerebral ischemia. We're looking at diabetes. Diabetes is a massively growing problem in the United States. And what I want to point out here is that when we have gum infection in our mouth, that's an inflammatory condition of the mouth. Diabetes, think of it as just a systemic inflammatory condition of our blood vessels, right? And so if patients have gum disease, they're more likely to have diabetes. And even if they don't have gum disease and they just have gingivitis, because again, the point is it's not about the amount of bone loss, it's about the degree of microbiome dysbiosis and the amount of systemic inflammation that it's causing. And we also know that if patients don't have any teeth, they're still at risk for having diabetes. And this is because our teeth, as I found out, are really critical for digesting nutritious foods. And so when we can't eat properly, our teeth, we're missing several teeth, or maybe we just have dentures that aren't anchored down by implants. We're going to be eating those softer, more processed foods that tend to spike our blood sugar. And so a lot of docs will say, okay, what is the actual mechanism that our oral health is affecting chronic inflammation and diabetes? So I mentioned before that bacteria from the mouth actually increase the stickiness of the inside of the blood vessel, and that's going to cause the plaque to build up. And when plaque builds up, blood can't freely flow through that vessel anymore. This is also part of the reason why a lot of diabetics have problems healing, right? If you don't have blood flow is how we heal. We need our cells to get to the wound to help stimulate healing. And when we don't have that blood flow, we can't heal. We also know that when we don't have blood flow, we can't heal. That's when a lot of diabetics start to have issues in their extremities. And so sometimes they can end up needing an amputation. We know that the bacteria in the mouth directly destroy the beta islet cells of the pancreas, which will stop insulin production. And when we don't have insulin production, we're going to see more blood glucose in our bloodstream. And glucose in our bloodstream, it shouldn't be there. And so what ends up happening is as it's going through our blood vessels, it acts like shards of glass running through our bloodstream, causing mechanical damage. Now, when we have that mechanical damage, of course, that's going to create an inflammatory response there. And how this relates to the mouth is that our teeth are actually organs. I know that I'm preaching to the choir here. You guys all know this, but our teeth are living, vital organs, and we need to take as best care of them as possible. And so in our pulp is where we have our blood vessel. So if we have chronic inflammation in our blood vessels from diabetes and we have restriction of blood flow, that means that the immune system of the tooth and the ability of the tooth to repair itself is actually compromised. And so the teeth in our mouth can no longer fight away attacks from caries causing bacteria, from periodontal causing bacteria. And so this is why we actually see diabetic patients have more tooth decay, more periodontal disease, more endo abscesses, is because that tooth has really lost its ability to, or lost its immune system. We also know that the chronic inflammation of blood vessels will impede saliva production. We must have saliva to help keep our oral microbiome and our teeth healthy. But then also, if we have increased glucose in our bloodstream, we'll actually see increased glucose in the mouth. And if you just have sugar laying around the mouth, especially at the gum line, that's where we're going to see a lot of those cavities pop up along the gum line. That's very typical of diabetic patients. Okay, we know the link between gum disease and Alzheimer's dementia is very, very strong. And this is by PG and FN. So overly simplistic way to look at it, PG gets into the brain, PG and FN get into the brain. The brain knows these bacteria should not be here. This is not okay. And so the brain starts laying down beta amyloid plaques to help protect its neurons. But in essence, it's going to starve those neurons from vital nutrients and they're going to die and shrink off. We know that FN actually accelerates this process by throwing fire or increasing the amount of inflammation in the brain. And so this is really important because if we know that someone has a family history of Alzheimer's or dementia, or maybe they're starting to experience some cognitive decline, we can take a saliva test on that patient and try and help reduce that bacterial load. The problem with these patients is that by the time that it is noticeable clinically, this whole process has really been happening for about 10 years. That's how long most disease processes, besides cancer, most disease processes take to cause enough significant damage to get a diagnosis. And so oftentimes by the time these patients do have a diagnosis, they're already kind of pretty far down the spectrum of Alzheimer's and dementia. And we know that as their cognitive decline increases, their memory to even remember to take care of their teeth or their ability to take care of their teeth significantly goes down. So this is a very fast kind of flywheel here that once patients get on cognitive decline, we see their oral health go down drastically. So I always like to talk about periodontal disease and erectile dysfunction. I think it's critically important because a lot of men will pay attention when you talk about this. And so we know that the bacteria in the mouth directly affect the male reproductive system. And the inflammation caused from bacteria in the mouth will cause restriction in blood flow. We need to have very open patent blood vessels in order for men to achieve erection. So if they have issues with blood flow because of inflammation, they can suffer impotence. How the mouth directly affects this is that oral PG, impairs the production of arginine. Arginine is a precursor to nitric oxide. And I mentioned nitric oxide earlier in the mouth. So if we don't have nitric oxide, we're not going to get dilation of our blood vessels, and then therefore an inability to achieve an erection. Cancer, this is a big one that a lot of people are talking about right now. So we know that if patients have gum disease, they have a 62% increased risk for developing pancreatic cancer. And pancreatic cancer is a nasty, nasty cancer because the pancreas is really hidden behind all of the organs in the abdomen, and the symptoms often radiate to other places. And so oftentimes this disease is not caught until later stages. And so the 5-year survival rate is only 8%. The new kind of research that's coming out is showing that oral FN is present in nearly all of colon cancers. What happens is when FN from the mouth gets to the colon, which again, it should not be, it will actually burrow inside polyps and get to the center of those polyps. Once it's there, it makes it very, very hard for treatments such as chemotherapy to reach the FN to kill it and kill the cancer cells. So if someone has FN associated colon cancer, they're actually going to be associated with worsened outcomes and worsened prognosis and significant metastasis. So not only does FN contribute to colon cancer, but it also makes it harder to treat and increases mortality rates. So speaking of the gut, let's do a little dive here into the oral health and gut health. And so we know that 70% of our overall immune system resides in our gut. This is why everyone is so focused on making sure our gut microbiome is healthy, but they need to take a step back and think about, well, how did the bacteria get to the gut? What is seeding that gut microbiome? And what we know is that the mouth is what's seeding it. Whether we're swallowing over 1 billion bacteria a day or the bacteria from the mouth is getting to the gut via the bloodstream, we have about a 45 to 50% overlap in the microbiome between the mouth and the gut. And what's really critical to understand is that the mucosal epithelium of the gut is the same that's in the mouth. It's the same tissue, right? Different bus or different stop on the same bus route. And the difference is in the mouth, we kind of have the stratified epithelium where we have many layers of epithelium. In the gut, we only have a single cell layer, but the process that breaks down the gut and causes leaky gut is the same process that's breaking down the gum tissue and causing leaky gums. And that's the MMP8 enzyme. And so when we think about our oral tissue is actually supposed to be a physical barrier that is semi-permeable. That's why we have many layers, right? Because the mouth is the first opening and largest opening to get into the body. And so we need to have this semi-permeable protective layer, but we also need to make sure that what stays in the mouth or what's in the mouth kind of stays there that's harmful and doesn't get into the body. And so that tissue that I'm talking about is our gum tissue. Our gum tissue acts as a physical barrier. It's like our skin. So our skin's job is to keep the environment in the environment and our insides in our insides. Our gut's job is to keep all the toxins and everything that we're digesting inside the gut and not into the bloodstream. Our gum's job is to keep whatever is in the mouth and not getting into our bloodstream. Now, the problem that we have with our gums is that our gums are actually penetrated by our teeth, right? Our teeth come up and penetrate this physical barrier, but then we have connections between the gum and the teeth to try and wall off the mouth from the rest of the body. But when these connections get broken down via MMP8 as a result of oral microbiome dysbiosis, that's when we start to have a really, really big problem and how our mouth can adversely affect the overall health of our body. So it's really important that we protect our mouth because our mouth is seeding our gut microbiome. Our mouth is also causing or potentially causing the systemic inflammation that is harming the rest of our body. And we need to make sure that we have significant amounts of commensal bacteria because the commensal bacteria are making necessary vitamins that we need. It's regulating our immune response. So it's telling our body, hey, pay attention to this microbe or virus or fungi that's coming in. We don't like it. It's turning up and down our immune system, and it's really helping with our metabolism. We know that dysbiosis in the mouth can be caused by a lot of things. It can actually be caused by the medicines we take, right? If we're taking antibiotics on a frequent basis, if we have different diseases, if we're eating poorly, we need a lot of probiotics and prebiotics and fiber to help really support our microbiome. And it can also be caused by low pH. So if you have someone that is chronically sipping on sodas or carbonated water or caffeine, that's going to lower the pH in the mouth and disrupt our microbiome. And then what we know also is H. pylori. This is a big thing. So H. pylori, not too long ago in the early 2000s, it was discovered that H. pylori causes a significant amount of stomach ulcers. What we also know is that if someone has stomach ulcers and H. pylori in their stomach, that we also find H. pylori in the mouth around the teeth. So super critical connection between the mouth and the gut microbiome. And so let's talk about one of my favorite topics, which is infertility. I'm going to blow through this. I know we're kind of running out of time here, but I have a whole course on fertility as well, if anyone is interested. Fertility is important to me because I was a fertility patient. And so I've gone through 6 rounds of fertility over 6 years. And so I started diving into this because I was really appalled at the lack of comprehensive care that fertility patients receive, and really appalled by not only how much this fertility treatment cost, but how low the success rates are, and really starting to look at, why are success rates so low? And what we see is that infertility in the United States and across the world is really on the rise. And some of this is because women and families are waiting longer to have babies because women are getting advanced and men are getting advanced degrees. And so we're starting families later. But even if you take a healthy older person that's still fertile, why are treatments not really being successful? And so a lot of this, I believe, is because we're not taking a holistic approach to health. We do know that fertility is the result of 50% on the women's side and 50% of the men's side, which a lot of people don't realize. And so when we look at fertility treatments, as I mentioned, they are widely unsuccessful. If you look at IVF, if you're over 40 years old, you have a 5% chance of a live birth, 5%, and only 20% chance if you're under 35. Natural conception, you have about a 25% each cycle if you're under 30. And then by the time you get to 40, you have a 5% chance. So you have the same chance of getting pregnant naturally over 40 as you do if you do IVF. But a lot of us, myself included, don't like to wait. And so oftentimes we seek medical care for that. And so how does oral health affect fertility? Again, it's the same as all other diseases. The microbiome directly affects infertility, and so does the amount of inflammation caused by the microbiome. So if we look at the microbiome, FN, or Fusobacterium nucleatum, when someone has this bacteria present, we know that this is going to be associated with adverse pregnancy outcomes. So I want you to think miscarriages. I want you to think stillbirths. The metabolites of FN are actually toxic to the fetus and will cause a stillbirth. and preterm birth. So miscarriages, preterm labor, and stillbirth. TF is another bacteria that we look at with infertility. TF is a precursor to PG. So PG is another major player, but PG is going to rely on TF in order for it to attach to the biofilm. And then if someone has PG, I want you to start thinking that PG is going to be associated with difficulty getting pregnant. So if someone's having a big or hard time achieving conception, this is going to be most likely if it has an oral component from PG. So again, we need PG to make nitric oxide on the male side. We know that PG is going to affect the blood vessels of the woman and in the fetal unit. So it can reduce blood flow to the baby. We will see PG found in the umbilical cord. PG is related to preeclampsia, gestational diabetes. And when PG is present, as I mentioned, it makes the blood vessel stickier, reduces blood flow. And so oftentimes we'll see it reduce blood flow, reduce growth factors, and hypoxia. So this is a little schematic here. I'll give you guys just a second to take a photo of the screen if you'd like, or a screenshot, just because we're running out of time. And so oral health and fertility, the whole concept is leaky gum. So we see that when we have a dysbiosis in our microbiome, those tissues are going to break down. And we can actually see the antibodies being produced in the uterus or getting to the uterus. We see that FN, PG, TF, AA, PI, CR, and TD all cross the placenta. So any of my patients that are seeking fertility treatment or who are already pregnant, or who have had an adverse outcome, we are always doing saliva tests on them to try and get their microbiome as healthy as possible. And what we know is that traditionally, most patients, 56%, I think, or even 60% of pregnant patients or patients trying to conceive actually avoid the dentist because they have been told somewhere along their journey, don't go to the dentist because their treatment can actually cause miscarriage. It's actually the opposite. We actually also know that most pregnant patients also have gingival disease. I'm going to jump ahead here. We see pregnancy complications, preeclampsia, gestational diabetes, increased risk of C-section, all from oral microbiome issues. Adverse pregnancy outcomes, I mentioned this, increased risk of stillbirth, preterm delivery. This is because MMP8 will actually go in and break down the amniotic membranes and trigger a preterm delivery. And why is that important? It's because oftentimes preterm delivery leads to a low birth weight baby. And low birth weight babies have a host of issues that they have, not just in infancy, but it carries them throughout their lifetime. And you can see most of the time, if a new baby does pass away, it's often because of low birth weight. We talked about gestational diabetes. It's the most common pregnancy complication. And the issue with getting gestational diabetes is that it severely increases your risk of type 2 diabetes within 5 years of getting postpartum. This is critically important. So this is where I started to really dive into fertility, is because, why is it that when I go to my reproductive endocrinologist, I'm spending, hundreds of thousands of dollars with them, why are they not actually making sure that the rest of me is healthy first before I start this? Because we know that the oral microbiome dysbiosis severely negatively affects the outcome on fertility treatments that are wildly unsuccessful anyway. And so we know that fertility medications are going to increase the inflammation that we have in the mouth. And the more inflammation we have, the greater the bacteria from the mouth are getting into the bloodstream and affecting our chances of successful conception, implantation, and chances of having a healthy baby. So we can treat pregnant patients. So please do this. I mentioned earlier, most people are avoiding the dentist while they're pregnant, and most of them still have gingival disease. And this is because, as a couple reasons, right? When you're pregnant, you're probably not eating the way that you typically eat. You're probably not feeling great. You might be vomiting more than normal. And so oral hygiene is going to go down. We also know that we double our blood flow or blood volume when we're pregnant because we need to grow another human. And the hormones in our placenta actually increase systemic inflammation. This is why pregnant women feel so bloated and they have a lot of edema. And the more that process goes on, the further along they get in pregnancy, the more hormones they have and the leakier that they become. And so the ADA does say that it is safe and we should be treating pregnant patients, which I was actually surprised about because the ADA tends to be very conservative in their statements, but they are a fan of dentists treating pregnant patients. And so what does this actually look like in our practices? And so people say, okay, I understand oral systemic health. I understand the importance, but how does this actually translate to my practice? Whoops, sorry about that. And the biggest way that I can say is start by looking at all of the bloody prophies that come into your practice. And so we see, oh, I have a video here and it's not showing up. But anyway, so we see this patient all the time, right? They're in their 20s, they come to see you and they have bleeding gums. You do their clinical exam, you're not seeing attachment loss, right? So maybe they have 2s and 3s on their probing exam, not really any recession, but just they're bleeding like a stuck pig. And typically what we say as clinicians is, we want you to go home. We want you to brush and floss more. That's all you need to do. And we'll see you in 6 months. And when they come back in 6 months, they're going to present the same way because number one, they're not changing their diet. We didn't talk to them about that. We didn't figure out what was causing the gums to bleed in the first place. And then lastly, we know that no one's going to really improve their oral hygiene, right? And so we're going to continually neglect, in my opinion, this patient until we start to see bone loss. And then we're going to jump in and say, oh, now we need to do a super expensive periodontal cleaning and put you in our perio program. When that entire time, those were warning signs that we could have jumped in as a clinician, done a saliva test, figured out what was going on, corrected the microbiome, and prevented this patient from having disease. If we can prevent oral disease, then we can significantly reduce the chances of having systemic disease. So when you see your bloody prophies, start to intervene. Another thing is looking at a patient like this, right? This patient comes into your practice and you're looking around and you're like, okay, this patient has caries, right? We would say that there's caries on all these teeth or all these 3 different patients. And if we were just to treat the caries, what would happen? Patient would come back in about a year, maybe 2, and all of our restorations would be failed. And insurance isn't going to, if you take insurance, they're not going to pay for you to redo these restorations. And the patient's going to say, you did bad dentistry. You need to redo this for free because I'm not paying for it. And if you don't, I'm going to go to the board or I'm going to blow you up online, right? That's what happens these days, unfortunately. And in part, it kind of is our fault because we treated the symptom, which was decay, and we didn't figure out what was going on. So if we look at the picture with all the erosion, we know that that's erosion. But how did this erosion get there? Was it bulimia? Maybe. Was it acid reflux? Could be, probably. And if it's acid reflux, if we go back even further, we know a lot of acid reflux comes from sleep apnea. So this patient potentially has an untreated airway issue. We need to treat the airway issue to prevent this from happening again. If we look at the top photo on the right, this patient actually was chewing tobacco. That's what caused all these lesions. So unless we stop or convince the patient to stop chewing tobacco, or even if they move their snuff pouch to the other side of the mouth, we're gonna keep seeing these lesions. And then on the bottom, this is actually a combination. This is a patient who has a bad airway issue. They have a big tongue. They're breathing through their mouth, big adenoids. And then we have a hygiene issue where they're forgetting to brush their front teeth. So we got to fix the airway, could get the ENT involved, and then we need to help them with their hygiene. So if you don't fix the underlying issue that caused the disease, everything that you do is likely going to fail. So how do we find the mouth-body connection link? One big thing that you can do that I would encourage you to incorporate into your office right away is salivary testing. There's many different companies on the market. And it doesn't matter what company you use, just make sure you're doing salivary testing. If you don't test your patients, you don't know what you're dealing with. Half of all oral bacteria are actually resistant to cleaning alone. So if you're going in and doing mechanical cleaning, you're missing half of the pathogens that are causing disease. That's why when your patients come back, they continue to present the same. They continue to have bleeding gums. Their disease is getting worse over time. And they're saying, I don't know what else I can do. I'm doing everything that I can. So unless you know what you're dealing with through a saliva test, you could be rendering ineffective treatment for your patients. These are just some examples of patients that I have in my practice. This patient came in, this is a fertility patient, and they'd been having some gut issues. They have some arthritis issues and they were having some issues getting pregnant. We did a salivary test. We figured out that they had the interleukin 6 gene mutation, which means that her immune system was primed and ready for inflammation. So she's going to overreact to anything that is in her mouth. We also see FN is sky high, right? FN is really important in fertility. So we got to get FN down. And then we also see the presence of TF. Remember, TF is a precursor to PG when it comes to fertility. And then if we look at the end, we see the low risk pathogens, EC and CS. These pathogens form first in the biofilm. So we know if we can prevent these from attaching to the biofilm, we'll prevent a lot of the other bugs from coming unseen. So how I would treat this patient is aggressively. I would do some treatments to lower TF and FN in addition to cleaning, such as ozone or laser. And then I'd really encourage oral hygiene or train on oral hygiene because we need to lower the low risk pathogens. This was one of my friends who came to me and said, hey, can I do a saliva test? He had a lot of concussions as a kid playing in sports. I think it was rugby. Rugby, I think, is a super violent sport that you don't wear helmets, or maybe, I don't know. Anyway, he had lots of concussions. He was having a lot of mental clarity, brain fog, memory issues. He was having a lot of shaking issues. And he was actually flying to Colorado to California to see Amen, Dr. Amen, going to the world-renowned Amen clinics. He paid tens of thousands of dollars, did all of this treatment, including hyperbaric oxygen, and his symptoms weren't getting better. I gave him a copy of my book, Say by the Mouth, and he said, I want to do a saliva test. Mind you, he'd been going to his dentist. He said he never had an issue with his gums. No one has ever said anything. He's very regular. We do a saliva test. Look what we find. And I hear this day in and day out. I see and I had my own patients that looked clinically fine, but then we do a test and the test helps us see what we can't see. So testing improves our patient management. It tells us how aggressive to be with our treatments. It tells me what type of treatment to do. If you go to your doctor with a sore throat, or you say you're having difficulty swallowing, they're not just going to give you a prescription for amoxicillin and assume you have strep. They're going to culture the bacteria, figure out what it is, try and give you the appropriate antibiotic. Or if it's not a bacterial thing, maybe they're concerned that you have a thyroid issue or a thyroid tumor. They're going to ultrasound your thyroid. If you're still having issues, and I'm talking about a current recent thing that happened with me, once the thyroid test was negative, we did an ENT scope to see if there was any lumps or bumps or acid reflux. Once that was negative, we did a barium swallow test, right? These are all tests that your physician does to figure out what is going on in places they can't see. Yet as dentists, for decades and hundreds of years, we've been trying to treat an invisible problem based off of what we can see. That is incorrect. We need to switch to let's do testing. Let's figure out what's there so we can appropriately treat it. You can always tie it to the patient's family and medical history. And then most importantly, you can track and you can show these results to the patient over time. So it really takes the burden from you as a clinician to putting it onto the patient. So now it's not you trying to sell the patient on oral systemic health and that they have an issue and they need to pay for a $1,500 cleaning or whatever your price is. Now the responsibility is to the patient. Here are your test results. This is your body. This is what what you're presenting me with. Here's the treatment I can offer you to get you healthier. That's why salivary testing is important. I know I'm out of time, so I'm going to blow through real quick. Another big thing that affects the oral microbiome is actually airway. Our jaws are getting smaller and smaller. A lot of orthodontists in the past have been reducing our tongue space even more by extracting 4 bicuspids and shrinking everything in. We're retroclining teeth instead of moving the mandible forward. This is creating a significant amount of airway issues for our patients. When you breathe through your mouth, you're not getting nitric oxide. You're breathing in all the pollutants and you're not filtering it through our nose, which is what we're supposed to do. It's drying out our tissues, lowering the pH in our mouth, and creating airway issues. Airway issues contribute to not only inflammation in the mouth, but inflammation in the body, and also puts a significant strain on our cardiovascular system and our brain. So things that you can do in your office, there's many tests that you can now send your patients home to do a sleep study. They no longer need to wait 4 to 6 months to go into a hospital and be monitored all night to see if they have a sleep issue. And this is really big because a lot of airway issues have a dental component. So if you see a patient that has severe bruxism or GERD or bad breath that can't be attributed to their oral microbiome, or you're giving them a night guard and every 6 months they're chewing through it, That is not a grinding problem. That's an airway problem. So test your patients. When you're looking in their mouth, if you cannot see the back of their throat and their uvula, test them for sleep apnea. 80% of people who have sleep apnea are undiagnosed. So this is a really big opportunity that we have in dentistry. And a lot of the interventions for sleep apnea are dental related. We can use our CBCT machine to scan for airway volume to see if our patients are at risk for apnea. We can do things like aligners to move our teeth, and we can do palatal expansion to help broaden our maxillary or our palate, but also broaden and flatten our maxillary sinuses so we can breathe. Power of CT, I talked about this earlier. We need to no longer be using two-dimensional x-rays to diagnose a three-dimensional condition. So CBCTs can help us see those endo abscesses that we thought were healing or had a scar, right? It doesn't look so bad on the PA, but you put it on a CBCT and you see that it actually has turned into a cystic lesion. I actually had one of my teeth that was affected during my accident. I had a root canal done on it. A recurrent abscess was never visible on a PA. And it wasn't until I went to dental school in 2010 and they had just gotten a CBCT machine and they took a CBCT and found out not only did I have a recurrent lesion there, but it was cystic and it had actually spread over my adjacent implant. And so we had to do some pretty major surgery to get that cleaned up. So the power of CBCT, our two-dimensional x-rays are only showing us about half of what we need to see. And we need to have significant amount of demineralization before we can actually see it on an x-ray. So again, dentists have been much too reactive. We wait for disease to be visible before we jump in and treat. And when you use CBCT and 3D imaging, it's going to allow us to see things much faster. The other thing that is allowing us to see things much faster is AI. So if you can put AI on your x-rays, even though we have to wait until 30 to 50% of destruction on x-ray before we can see it, AI can see it much sooner. And AI can also allow your patients to see it, which is really important. I know we're super out of time here. Financial impact to the office. So another important reason to do this is unless we have well-run businesses, we don't have the opportunity to improve the health of our patients. So I always look at, if I'm bringing salivary testing into my practice, is it going to better my patients and is it going to allow me to see more patients or treat patients better? And the answer is yes. By doing salivary diagnostics, you're going to diagnose more dentistry. You're going to diagnose more perio, you're going to treat more perio, and you're going to get patients into your perio program. An average office only has about 10% of their patients in the perio program, which doesn't make any statistical sense when you think about half of Americans have periodontal disease. And hygienists, rightfully so, are demanding a higher salary these days, and their role is critical. And in order to provide or be able to pay those hygienists to do what they're doing, we need to make sure that we're supporting them in their production so that the business can keep surviving and thriving. And most hygienists are getting anywhere between 50 to 60 bucks an hour, which means that they need to be producing anywhere from $1,300 to about $1,800 a day in order to sustain a hygiene cost of less than 30%. Most hygiene costs and practices that I analyze are 40% or more, which means that you're paying your hygienist as a specialist, which they kind of are, they're oral health specialists. But most dentists or most associates only make 30% of production. So we are paying hygienists as what we would pay a periodontist or an oral surgeon coming into our office, and they're actually making a higher percent of their production as compared to general dentists. So I'm going to slide through this. If anyone wants the rest of these slides, please let me know. I just want to be respectful of all the other speakers. I have a whole workflow on how to integrate this into your practice. I have tips for communication, tips for implementing the workflow, and then example integration plans, how to actually start doing this in the office. So shoot me an email. I'll give you all of these. I'm just going to go through here. And then in summary, the biggest thing that I want you guys to take away is don't wait for disease. Pathogens are still causing damage and inflammation before we can see disease actually happening in the mouth. So use technology, get in there sooner, diagnose the disease, correct microbiome issues so that you can lessen the systemic inflammatory burden. Look at the airway. We're already right there. And let's begin practicing as oral medicine specialists. And then thank you guys for having me very much. Here's the code. And then I do have a new clinic opening up in less than 60 days. I'm so excited. It's a fully integrated functional dental and medical clinic. So if you want to learn more or take any of my other courses, please scan the QR code.
Thank you so much, Dr. Lee. That was incredible. I am going to take a few minutes because I'm going to be presenting for Stella Life here in just a minute, their products and things. We've got Liz Landry with us, but she's going to be doing her presentation. Then I'm at first going to be introducing and talking about Stella Life. So we've got a few minutes. I want to ask, there's a few questions in here. I want to say, there's a few comments too. One of the comments from Cheryl Scott was health starts in the gut and gut starts in the mouth, and we all know that's an absolute truth. Ranty also, and if I pronounced your name wrong, please forgive me. The East Tennessean in me doesn't always make pronunciation the easiest thing in the world for me, so I apologize in advance. But said there are two types of saliva tests: the targeted high risk bacteria and the whole panels of oral microbiome. Which, in your opinion, what is your opinion on the differences of these tests?
Yeah, I think every saliva test has a place in the office. There's the MMP8 test too, so that is a different test by Dentignostics. So how I use it in my office is I start with the pathogens. I want to know the bad bacteria in the mouth because that's what I want to target and treat. And depending on the bacteria present is how I dictate or create my treatment plans. So I'm going to start with a pathogen test to figure out what is going on in the mouth. I actually just used this yesterday with a fertility patient from Canada. Horrible fertility outcomes so far. She's now seeing functional fertility people. We did microbiome tests. I used the oral DNA test on her and her husband through the roof, FN, PG, even AA for her husband, who has a family history of cardiac issues. And then we got those down. And then what I did is I went to the bristle test after that, because now I want to know, okay, we've gotten rid of or lowered the pathogens, but we're still not where we want to be. So now I want to look at commensal bacteria. Do we have a robust and diverse enough microbiome to support health? She had low nitric oxide levels and low levels of commensal bacteria. So now we've gotten rid of the pathogens. Now we need to boost up the good bacteria to help with nitric oxide. So I put her on nitric oxide supplements, put her on probiotics. We're rebuilding the microbiome. But then another test I love is the Dentignostics MMP8, because that is going to measure the rate of breakdown, periodontal breakdown, and it's going to measure the rate of bacteria getting from the mouth to the body, because you could have a microbiome issue, but if your immune system is doing okay, then the microbiome issue is only affecting the mouth and not the systemic. So I use all three of those tests just depending on the issue.
Gotcha. So that's a great answer. Thank you. So another question we had is how to prevent bacterium in pregnant ladies who have to have periotherapy.
Great question. I love this. Number one is we know that bacteremia is happening all the time anyway, right? When we're brushing our teeth, eating, grinding, all that stuff. What I like to do is I like to have my patients do an ozone rinse before I start doing my periodontal therapy to help lessen the amount of bacteria in the mouth before rendering the actual scaling and treatment. So have them do a little ozone rinse that they can do before doing treatment. That's really good for cardiac patients too. If you have someone that has had a history of heart attacks and strokes, have them do a little ozone rinse ahead of time.
Gotcha. So someone asked about the name of your book. I added that in there. A lot of people are asking about your slides. We can definitely, if you're interested, we'll be glad to send those out. We can add, what we can do is upload those to our aaosh body of material, and then what we can do is put a link in there. If you're okay with that, if you're good with it, we'll do that. And then Danielle, what we can do is provide a link out for those slides so that everybody can have access to them. If they are actually the folks are actually asking for the QR code too for your promo slide. So we'll be sure, guys, to get that. That'll be a part of the information that we send out when we send out all of the info on the programming today, that will have like the link to go download, go view the videos again, and do all that good stuff too.
I'll copy and paste the link here too. If people just want to click on it,
great,
it has my book and the new practice. Sorry I went late. I'm so passionate about this topic. I just
Well,
get
we
wrapped
love
up
it.
in what I'm
We
doing.
love your
So
passion. We love it. So if you'll put that link in there for us in the chat, I think everybody would love that too. So everyone, again, thank you, Katie, so much. You always do such a great job, Dr. Lee. We're always so thrilled to have you as a part of our Speakers Bureau, and always just you always bring such great information, and we want to bring you back. Please don't be a stranger to aaosh. We always love to have you here, and we're always so grateful for you for you when you come. There's so much information that you add. I would love to have you just to do a women and children's seminar with you, and bring you back for that, because you've got so much great information on infertility, and I know so many women struggle, and they are looking, in family struggle, and they're looking for what are the answers, and they don't even think about what's going on in here and the effect that it can have. So we would absolutely love to have you back again, so please come back and see us. So I'm going to real quickly, guys, let me get some sharing up here with everybody, and get some things going here. Give me just a second, and I'm going to share a screen with you. So I'm going to talk about Stella Life for a few minutes. Play from the start. Let me see. Hopefully, you guys see the screen that I hope you're seeing. I'm going to move our speakers over here so that everybody can see what's going on. So I'm going to talk about Stella Life for a few minutes with you guys. So our former president of our board of directors, Dr. Gennady Sororda, is the one who actually introduced me to Stella Life. Now, you can, let's see if you can swap my display. Dad blast it. That happened to me the last time, and I didn't want it to do that. So now here we go. So Danielle, do you see it right now? Are we good?
Yep, looks great.
Okay, great. Okay, thank you very much. So this did this to me the last time. So my little friends over at PowerPoint today are really giving me fits. So we're gonna have to have a conversation with them. So our president, Gennady Stewart, is the one that introduced me to Cell Life, and I absolutely love the products. And if you've never used Cell Life products, let me kind of give you a primer on some of these products. So you guys know that you can find temporary pain relief over the counter whenever you have any type of dental work done. Now, I'm not gonna lie to you, I've had a mouthful of work done. Just Danielle and I talked about this just in the past 90 days. I've had 6 crowns, a bridge, and the setup to start a dental implant, and then and probably 60 days prior to that, I'd had 3 more crowns. I've had a ton of problems with my teeth. Growing up in rural Appalachia, really poor, had a lot to do with that. I know I've got some folks in here today from rural Appalachia who can attest to, I'm sure they've seen a lot of things in the mouth of a lot of patients who grew up just as poor as I did. So even you might even be able to find, some mouthwashes out there that'll help with pain, but it's very hard to find a product that can actually accelerate healing, can help and almost eliminate pain, and that doesn't require a prescription for opioids, which have their own dangers and side effects. That's what you get with Stella Life. Like I literally, I can tell you my house, and I know I'm going to have to probably hold these up to my body so that you can see them because of the background. I have a house full of Stella Life products, and this is all that I could bring down with me downstairs because I've got so many that I was afraid the dogs were going to kill me trying to walk down the stairs with all of them in my arms. We have so many members that have testimonials about Stella Life products, including me, that can tell you how that these products have literally changed their lives, and how that's helped them overcome the side effects of oral cancer treatments, oral surgeries, implants, and so much more. I'm a huge fan of the mouth rinses, the pre and postbiotics, the multivitamin supplements, the gel for pain relief and swelling. I'm telling you, I couldn't have made it through a lot of the implant work that I've had done without that gel. That gel it is not this over the counter stuff that you get that lasts for like 10 minutes in your back trying to get it and do something because you're in so much pain you don't know what to do. It's really effective, and it really does help. And I'm going to share a few of Stella Life's products with you and talk a little bit about some of the some of the effects that you can see in some of their case studies with you as well. And this is just one example. This is a pre, post, and probiotics kit that they have available. I have used this and it's made a huge difference in my periodontitis. I was in very late stages of periodontitis, lost a lot of teeth. I won't lie about it. There's no reason for me to, and I'm not ashamed of it. It's just a part of my growing up. But when we were so poor that going to the doctor, you went to the doctor when you were dying. You only went when everything over the counter quit, and you were full of disease, and this was the last hope, was to go to the emergency room and hope that someone could help you there, because that was the only option you had. Whenever I met Gennady and I started talking to him about the struggles that I have with my teeth, and the fact that I finally had reached a point in my adult life where I could, one, afford to start having things done, and two, actually could, have dental work done, and could have the bone build up and could start treating the periodontal disease. And he introduced me to Cell Life. One of the first things that I started on, and in talking to my dentist, was this pre, post, and probiotics kit to try to start treating some of the inflammation in my mouth. And I had very similar results to this. So as you can see in this patient, before treatment, 6 weeks after initial treatment, and then 4 months after the initial treatment, look at the actual benefits that this patient saw. This was a 29-year-old female that was not periodontally stable, that had that severe inflammation. And you can see that after 4 months of treatment, and then stopping the aligner treatment and removing the clear retainer buttons with SRP, that she had a plaque reduction from 50% to 4%. Her probing depths had a 35% reduction, and bleeding on probing was reduced from 90% to 7%. I can testify to this as well. My gums, since I started using this product, my gums, when I brush, when you see pink in the sink, that's your health going down the drain. And I don't see that pink in the sink anymore. I'll tell you another thing too, is this Stella Life rinse, which, like I said, I'm gonna have to hold in my body and it's almost empty. I'm gonna have to talk to Gennady and get some more. But this Stella Life rinse, between that and this pre, post, and probiotic kit, has made a huge difference, so that when I brush, I'm not spitting out a mouthful of blood every time I brush my teeth. So it's made a huge difference in my life. And this is just one of the many examples. And we've talked to many other members of aaosh who've actually started using this before prescribing it to their patients, and it's made a huge difference in their life, and even in their dental health. So we know the efficacy and the effect that this product has had. And one of the first things that I noticed was when I started going back to my dentist, because I was on a 3-month regimen of the root planing and the scaling, because my teeth were in such bad shape in my gums. The first thing that he was asking me was like, are you doing are you flossing, or is it that you're doing the water pick? And I was like, no, I'm doing Stella Life. That's what I'm doing. Do you want to know about it? So it was a total change in their attitude. And you could see the smile on my RDH's face and on my dentist's face, because they could see an actual difference in my overall health. And that's great. And that's what we want. Because remember, we're in the business of saving lives. That's what we're here to do. So if this is a part of help changing someone's overall oral health, we're all for it. And we're so glad to have Still Life as one of our partners. And for some reason, my slide doesn't want to change. So here's another example. Now, I'm not going to lie, I'm 47 years old. This is, I can relate to this as well. So this is a palliative care example for a patient, where you can see the use of the Stella Life Recovery Kit for 1 month, and what it was able to do before a non-surgical periodontal treatment with scaling and root planning, with strict 3 months maintenance recall, with daily use of the Stella Life mouth rinse. The mouth rinses are not, this is not your list. No, I'm not going to name other brands. I'm not going to name the big box store brands, because that probably will get me in trouble. But this is not the stuff that when you put it in your mouth, you feel like your mouth is about to explode because it's on fire and you're going to die, because any minute, if you don't spit it out, you hope nobody sets a match on around you, because the alcohol in it is literally going to set you on fire. Stella Life's mouth rinses are beautifully flavored. There's a coconut rinse, which I really like, and I love the peppermint as well. They both have a great flavor, and they're really, really effective. You feel good after you use them. Your mouth just feels very, very soft inside, for lack of a better way to say it. It's got just a very refreshing flavor to it. But you can see from using this therapy just the difference in the improvement observed in the pocket probing depths, the plaque scores, the bleeding on probing, clinical appearance, surrounding tissues, and the mucosal lesions. The patient reported reduced discomfort, that lack of a burning sensation, and easier patient implementation of home care. So much of getting a patient to do this is, can they do it at home? If they can't do it at home, then they're not going to do it. And then you're going to have a patient that comes back every 3 months that's just going to be right back in the same shape they were before because they can't do it at home. All of Stella Life's products have very easy to read labels. They make it very clear what you need to do, how often you need to do it, and there's no guesswork in it. That was one of the greatest things that I found, even in things like this multivitamin, which I really love and I use every day now. It's actually intended for dental procedures. It's a supplement for dental procedures, but I actually use it now as my regular multivitamin on a daily basis. It tells you very plainly how you need to use it. There's no guesswork in it. And you can also consult with your dental professional as well to help you figure out how best to use all of their supplements in your everyday life. So it's not just simply sending you home and saying, here, best of luck. You've got full guidance on how to use their products. They give you the full guidance and the full ability on how to use it. So now for aaosh members, I'm telling you folks, if you're not an aaosh member, we have so many great benefits to being an aaosh member, and Stella Life has given us one of those benefits. So if you join a Stella Life Live Learning, they are offering you, if you are an aaosh member, the ability to get the Stella Life, a complimentary Stella Life pre, post, and probiotics kit, plus the Vega Oral Care Peppermint Gel if you are an aaosh member. If you mention when you sign up for the live learning that you are an aaosh member, you put aaosh member offer, and they'll send you the peppermint gel. I would have brought down my peppermint gel, but I've used all of it. I actually didn't think about it when I threw my little container away, and I've ordered more. I actually threw the container away, or I would have it. It's about this big. It's a great little gel. A lot goes a long way. It is so effective. I'm telling you, for oral pain, it is one of the best gels out there to actually calm, settle, and just make everything feel so much better. You won't find anything over the counter remotely close to it. It is a beautiful, beautiful gel. I would go so far as to say it is effective enough that once you put it on there, that pain will be gone in probably 20 to 30 seconds, and it stays gone for a long period of time. So it's one of those things I do encourage you. If you are interested in learning more about Stella Life, please sign up today for this offer. This is a great, great benefit for our aaosh members, and we truly hope that you'll take advantage of this offer and that you will join Stella Life in their mission to save lives, just as aaosh has our mission. They're a part of that mission as well, and we are so glad to have them as a sustaining partner for the entire year. They'll be with us at annual sessions. Liz is going to present for us more than once this year. This is part one of a two-part series that she's going to offer for us this year. She's also going to be a webinar speaker for us, so what you learned today will have a continuation over to our webinar series, which we're excited about as well. But there are so many great products with Stella Life that we would love for you to learn more about. As you can see, the two rinses, the coconut rinse, the peppermint rinse, there's the oral gel I was talking about, there's the recovery kit, which is great as well. There's also the pre and pro and the postbiotics as well, and then the multivitamin. There are so many great products. I've used this product for dry mouth, my dental procedures. It's great for canker sores. That's a given. I don't know if when you guys go to the dentist and you're having to have a lot of procedures done, they put so many things in your mouth that you end up with sores on your mouth. You can't help it. It's just natural. If they're going to When a dentist goes into my mouth, they're in there for a while. Trust me, they're in there for an hour, two, three, sometimes 4 hours, and I always end up with sores. Their products are so great to help with those sores. They're in my mouth for a long time because they got a lot to fix. So those canker sores and things come up in the rub, you can't help it. Things rub and you get sore. These products are perfect to help with that. And another thing I noticed that's not on there, they have a great hand sanitizer too, which I know it's fading in the background. But this hand sanitizer has the world's best smell to it. I've never had a hand sanitizer that smelled as good as Stella Life's hand sanitizer. I absolutely love it. We are blessed as AOSH internal staff. Danielle, you can attest to this as well. Um, we are we are just we're blessed because we have access to all this stuff, so we are so grateful for it. But Liz, if you will go ahead, I'm going to stop sharing. If you will go ahead and start your presentation up, and go ahead and get that started, and Danielle, if you'll give her permission to share her screen so that she can get that going.
Yeah, we should be good to go. Looks good on this end.
Okay.
And you can hear me now?
Yes, ma'am, we can.
Thank you so much, Violet. Thank you for all that information about Stella Life. And I'm very excited to be here. So I'll let you carry on and advance the slides for you. Just let me know what to do here.
Yep. So hold on just a sec. There we go. So Liz, if you will go ahead, we're going to talk about zero bleeding gums concepts part 1. So if you'll advance to the next slide.
Okay, here we go.
And Liz is a member, or is a team member of Stella Life, and over at the JP Institute, we've medicated everything. If you'll go on to the next slide. And the next one. 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 And this is Liz's course description. And the next one. And this is her learning objectives. And the next one. And here's 3 ways that you can apply this into your practice tomorrow. And here's the next one. And I'm going to introduce Liz Landry to you. So it is my absolute pleasure to introduce my friend, a true expert educator in the field of dental hygiene, Liz Landry. Liz has been a practicing dental hygienist since 1979, bringing over 4 decades of experience and expertise to the profession. Her passion for advancing dental care and education has made her a trusted clinician, trainer, consultant, and speaker. Since 1998, Liz has been an in-office trainer working directly with dental teams to enhance their skills in patient care. She earned her laser certification in 2000, and as a consultant with the JP Institute, has traveled across North America providing hands-on training in lasers, air polishers, ultrasonics, and nutrition integration. She is a published author, a respected speaker at international seminars and national study clubs, and a dedicated educator who continues to shape the future of dental hygiene. Today, Liz serves as a senior product specialist and clinical educator for Stella Life, where she helps dental professionals integrate innovative solutions to improve patient outcomes. Her dedication to education, cutting edge technology, and patient care has made a lasting impact on the dental industry. Please join me in welcoming the incredible Liz Landry.
Thank you so much. I just feel so much love right now, and I thank you for all this information. And thank you, aaosh, for inviting me to participate in this. I'm very excited to be here. Thank everybody who's out there listening for joining today, and want to settle out a warm welcome to some new aaosh members. We have a lot of our Stella Life team joining us today, and a lot of them are non-clinicians. So thank you, and enjoy the learning that we're all doing. I really was excited in hearing what Dr. Lee was saying as I got on the call, because we're really all on the same page for what we're trying to communicate here today. And my title, Zero Bleeding Concepts, was inspired by Dr. Tomas Linkovicius's book, Zero Bone Loss Concept. So it really kind of sums up what we all want to do as a longtime hygienist and clinician, all of us in dentistry. We know that we're going to talk, of course, about periodontal disease today and give you some practical applications. But we just see bleeding so much, for those of you non-clinicians, it can be kind of like a horror show sometimes. And so our goal is to stop this endless cycle. And so what I'll be talking about today is about the protocol that was developed by the JP Institute. And this is what I've been teaching for over 30 years. Again, as Violet said, traveling all over North America. And what we have developed with this program is a practical way, a step-by-step protocol that we can use for all of our patients so that we can really enable them to have that opportunity. And our goal is zero bleeding. It can be done. As I started doing this protocol myself as a longtime hygienist, at that point I've been a practicing hygienist for 10 years, and I felt like I was on that hamster wheel, like day in and day out. I remember driving to the office and thinking, what horrors await me today? Because there's just so much bleeding, and I felt like I was hurting my patients. And then I had the wonderful fortune to be hired by a practice who had the JP protocol and had gone through that training. So I also received that training, and it was a life changer for me as a clinician. But most importantly, I was really able to help my patients change my relationship with them and get them excited, about what we could do for them and about how much control and power they had over their own health. And, again, really give them this step-by-step protocol that they would use at home. But this is a process that as a clinician, I had to really kind of let go of what I learned, open up my mind and my heart to new information, but I was ready for it. And with that, what the JP Institute does is we go into practices. We also work with organizations providing this protocol and training everybody, workshops and seminars as well. But um, it is very individualized, depending on what the offices want to do. And I just want to really acknowledge our founder, Jan Lazarus, again, a longtime hygienist. She was a genius who really developed this protocol and applied it in her own practice and then shared it with the world. So she is one of my best friend, basically, and my mentor for so many years. She is a co-founder of aaosh and again, the founder of the JP Institute, and she was a recipient of the aaosh Lifetime Achievement Award. So thank you, Jan, for all that you have done and contributed to dentistry. And again, we're all on this mission of improving and saving people's lives. So as the JP Institute, we've worked with many aaosh practices, including Dr. Mike Supiak. So he has been a JP practice for so many years. And so we're just happy to be able to share this with everybody else, and we're here to help you. So as we're talking about periodontal disease and the whole concept of disease and bleeding, these statistics you see there from the past, the silent epidemic by a previous Surgeon General, but whatever year we're looking at, when we look at the statistics, they're pretty much the same. So we're talking about really whatever percentage you see here, how many patients do you see every day that have no bleeding, that have zero bleeding? This is the question I ask at all my lectures, and when I'm doing the training as with the JB protocol, I ask this with to the clinicians and the administrators, the whole team, and I get a bunch of rolling eyes, and people say, well, not too many. I'll ask the doctors, how many patients do you see where you can do a crown prep and no bleeding? Or a hygienist, how many patients can you do a prophy on and there's no bleeding? And they'll say, oh, maybe like 1 or 2 a week. So this is what we see. I know with you aaosh practices, you're applying so many of these concepts that you've learned, and I'm sure you're doing better than the average dental practice with that. But here we do see it so commonly, and it's such an ongoing battle, the battle against the biofilm. So we typically will see different types of disease processes going on. This particular patient, doesn't look like they're in such bad shape. When we look at their periodontal pockets, this patient had basically a 2 and 3 millimeter pocket. You can see some inflammation right here. This is actually a 4 millimeter pocket, but not looking too bad. Patient really didn't have any complaints. But as we took the periodontal probe and just gently moved it in the sulcus underneath the gum line, this was the level of bleeding that we saw. So, is this patient healthy? Absolutely not. And for those of you who are non-clinicians, we see this kind of thing all the time. So there is a problem here. There's an active infection. And every time I see this slide, which I've seen for years, thanks to Dr. Nagelberg, who's a great speaker. If you have a chance to hear him speak, he's terrific. He's a periodontist. And this is P. gingivalis, which is a keystone pathogen. Most people that have periodontal disease, as you aaosh members know, you clinicians know, do have P. gingivalis present within their mouth. And here it's actually being incorporated into the tissue by the body. And as these bacteria get into the tissue, of course, they get into our bloodstream, and then they take a ride through our system, through our circulatory system. And so, as you clinicians know, we have a localized bacteremia, as you saw with the patient with the bleeding tissue, but we really are most concerned with what happens with this presence of this bacteria with the rest of our body. So we know that it actually causes what we call a cytokine storm. And we basically have systemic inflammation that is triggered by the presence of these bacteria. So with that, we have a huge impact on the immune system. And no matter what level of bleeding we see, I know in the past, we would look and compare one patient to another. Like, this patient looks really bad. They have a whole lot of bleeding. This patient, not so much, So we'll just like tell them to floss more. I did this for years. It doesn't work, right? So, but at any level, and as we know now, which I'll share with you in a bit, even before we see bleeding, we have these pathogens present. So we can test for those now. And I'm going to be talking a lot about salivary diagnostics. So with the presence of these, we see that this bacteria and this disease, which is an epidemic globally, not just in the US, is going to affect the patient's health because we're going to see a decrease in their immune support. Again, we've got this increase in the inflammatory burden, and it causes irreversible damage to the immune system. So, I love that phrase that Violet talked about, pink in the sink, there goes your life down the drain. This is really what's happening. So we all have to take this very seriously. So we're talking about distribution of pathogens throughout the body, even with gingivitis. And again, it's going to impact that patient, and it's linked with so many diseases of the body. So as we know, periodontal disease is a systemic disease and needs to be treated as such. So this is from aaosh. When we look at the statistics of the different types of diseases that are associated with periodontal disease, and basically over 80% of our patients do have some form of periodontal disease. So we're talking about the increase in heart attack risk and strokes by 50%, premature death by 12%. The link between dementia with Alzheimer's, cognitive decline. We know P. gingivalis is a key player as it's crossed the blood-brain barrier. It stimulates the deposition of the amyloid proteins, which become the brain tangles. So there is that direct relationship with P. gingivalis. So again, we can test for it. We need to treat it and treat as early as possible. There's a risk with cancer. It increases your cancer risk by 50%. And we're also impacting, as Dr. Lee was talking about, infertility, but even during pregnancy, we have low birth weight babies in premature birth because of some of these pathogens. And diabetics, are more likely to develop periodontal disease. And if you have periodontal disease, if you have this in your genetics, you're more likely to develop diabetes. So, and then even erectile dysfunction, is linked with periodontal disease, and nobody wants that, right? So when we look at the diseases, we know that P. gingivalis, for example, is linked with 57 diseases of the body, and it controls the genetic expression of other bacteria as well. But look at all of these diseases. So this is something that we see every day, and we have some control so we can really help our patients live longer and healthier lives. So again, this patient, when we look at the periodontal probe, 2 millimeter pocket, not too bad. As we probe and sweep that probe subgingivally, we see that bleeding. So again, we see it so commonly. What we've been doing hasn't been working. what we have to do is redefine our role. We have to change that conversation at the JP Institute. And when I go over part 2 of this presentation, going to be sharing the verbiage and the systems, that we need to use to be able to make that impact on the patient. Every time we see them, we need to educate them. And we can't just do it all at once. We can't just vomit it all out there. When we see them once every few months, we do need to go through a process to help them learn. They can only absorb so much. It's like watering a plant. You got to give it a little bit at a time for it all to sink in. So every time we see them, we need to give them some education, and we need to detect disease early and treat it early. So we have to do things that we haven't been doing before and expand what we do. So when we look at the disease itself, we want to have affordable, safe therapy that is based on the oral inflammatory load, based on the composition. We need to know what pathogens are present and target those pathogens, and use whatever means we have available to be effective with what we do hands-on with our technology, with our instrumentation, and also other adjuncts to really help create a healthy oral microbiome. And again, with that communication from the last World Workshop from the American Academy of Periodontology, they were talking about the collaboration we need to have with between ourselves and our patients, because for too long we are like telling them this and that, and they kind of tune out after a while. We need to involve them in this conversation, to empower them, to let them understand that they really can do something, and we're here to support them. So with our protocol, as we do case presentation, we want to involve the patient, and I'll talk about that in just a bit. But the principles of care with the JP protocol involve looking at the risk factors and trying to modify them as much as we can, those over which we have control. So like their nutrition, lifestyle choices, really having them understand that and go through those details as best we can and refer them out if we need more assistance for these things. What we want to do is help with their lifestyle, with their nutrition, with other aspects of their life to reduce that inflammation. We're going to remove all of the deposits of the bacteria site by site, and we want to treat to completion. In the past, I know I did before I was trained to do this, have patients come in for 4 appointments of scaling and root planing. We would call it a deep cleaning, which completely kind of reduces the value in the patient's mind of what we do. So using verbiage is really important, but it's really impossible to remove all these deposits to really deal effectively with the bacteria if we're trying to do it in 4 appointments, because that's what insurance allows, right? Or a lot of offices do half mouth and half mouth, regardless of the case type. So again, it's not possible for us to be effective if we don't have the time in that patient's mouth. We also need to give them time to heal. So, with Jan Lazarus was talking about the host modulated response back in the 1980s. So the JP Institute has been teaching the oral systemic link for over 30 years. And we have to appreciate that individualized approach, and also how the healing progresses, and have the timing right to maximize the effect of what we do with our patients. We have to reduce that bacterial load. And once we provide the active treatment, we want to keep them in remission for as long as possible. So we're going to be doing screenings every time that we see them as they're coming back for their maintenance appointments, checking for the pathogen's presence by using salivary diagnostics on a regular basis. We have this technology. It is so affordable. Why aren't we doing this with all of our patients all the time? So with the 5 points of the JP Institute philosophy of personalized treatment, our programs and our treatment plans are individualized. They're open-ended, and they are repetitive treatments. They are all-encompassing, and once we go through the treatment, we have to keep our patient in a closely monitored system. So with the individualized treatment planning, we're going to be doing a detailed risk assessment with our patients. With the open-ended treatment planning, we're going to give them an estimate of how many appointments they need, because we cannot predict how somebody is going to heal. We can't say, I can do you in 4. we don't know how that patient's body is going to heal. So we want to give them a range of appointments. We want to get them again into disease remission and sustain that as long as possible. And again, with repetitive treatment, we can really have a better chance of, winning that battle against the biofilm, controlling those pathogens. And then with the repetitive therapy that we do, again, looking at how long it takes for healing to take place, we're going to be getting better wound healing. And again, with retreatment of areas that we treated previously, which as we go through step by step, the protocol for the individualized periodontal therapy appointments, we provide that treatment, and the goal, of course, is disease remission. So with all-encompassing therapy, we're going to use whatever we have at our disposal, dependent, of course, in which state we live. Maybe in some states we can't use lasers. We can do whatever we can with the technology that we have. And when I started doing this protocol, the only technology we had really were our curettes, because in those years, we didn't have slimlines. So with our ultrasonics, we really couldn't go subgingivally with them. But with this protocol, with the repetitive therapy, we were able to get zero bleeding on a lot of patients just using our curettes. So again, the program is incredible. The protocol really works very, very effectively. And, we've been doing this again for thousands of practices for many, many years. But we want to use whatever we have, and we all have access to salivary diagnostics now. Also, as we're doing all-encompassing therapy, we need to look at the restorative, because, as clinicians, you can work on a patient's mouth and they look great everywhere except where they have dentistry that's just breaking down. And these are great places that trap biofilm. So we'll use whatever technology we have available. We need to talk to them about their airway. So if they're not breathing, then nothing else we do matters, right? So they have to be breathing properly, making sure that they have the, nitric oxide production, all of that. If they're having sleep issues, their immune system is going to be affected. There is a best-selling book by Dr. Michael Walker about sleep. And he talks about that if you go 5 days in a row with 5 hours of sleep, your immune system is 50% less effective. So we really need to talk to our patients about that, because it is about helping them with their lifestyle so they can have the best possible strong immune system, through nutrition, stress management, and sleep. So we do all of that as coaches when we see our patients every day. With our closely monitored system, we're going to have customized intervals. Again, everybody has their own set of risk factors, and we're going to get that interval dependent on those risk factors, and also give them products which are going to help support their healthy microbiome. And got a bit of a preview about that from Violet. So we want to sustain that remission and continue to use salivary diagnostics to retest, because without testing, we don't know what's going on there. So with individualized treatment planning, we're going to do a risk assessment as we see our patients in hygiene. And when we do that, we're going to go over their health history, but we're going to go over it in more detail. We do recommend that a blood pressure screening is done with every hygiene maintenance and prophy appointment. We're going to do a head and neck screening, the intraoral cancer screening, and check their airway. So we'll be doing a restorative screening, and all of these are done with the patient's involvement and observing, and a conversation is going on while we do the screening, so they can see what we see, especially when we're doing the periodontal screening, but definitely with the restorative. So again, taking patients' blood pressure, we're doing a screening. It's a service we can provide for them. It doesn't take very long to do. We've got easy ways of doing it these days, so we really should be doing that with our patients every time we see them for their maintenance. With the head and neck exam, checking the lymph nodes, the musculature, as well as the intraoral cancer screening, critically important, and it should be done at every hygiene appointment. Not if you're seeing them every 2 weeks, of course, for periodontal therapies, but as they come back for their maintenance, we need to do that every time. And there's a presentation later today from Dr. Parul Makar. She's amazing, and I actually had the opportunity to hear her speak at UOP last weekend, and she talks about oral cancer, and really is a wonderful, very moving and very informative presentation. So you have that to look forward to today. So we will do that at each of our hygiene appointments, as well as use the camera if you have it, pull that out, use that with every appointment so your patients can see what's happening with their restorative as well as with their tissue. It's a great tool, and sometimes it's just not used, maybe it's in another room. So if you have the opportunity to have your own camera, please utilize that. It makes a huge impact. And then when we do the periodontal screening, we want to make sure the patient hears those numbers out loud. And when there's any bleeding, we need to show them with a mirror right away so they can see what we see. So at that initial appointment, if we see that there's a disease process, it becomes an initial diagnostic therapy appointment by category. We're going to do these screenings. We do that at the beginning of the appointment. After we get that information, as hygienists, we're going to be sharing that information with the patient, and we're going to tell them what the treatment plan is. Like in cases like yours, the doctor usually recommends, and then you tell them what the treatment plan would be based on that. And we talk to them about the need for testing the bacteria that's causing their infection. So through the years, when I tell people that they have an active infection, they'll say, well, can't you just give me antibiotics? Well, we need to know what bacteria is causing this infection. So next time that you come in for your first periodontal therapy appointment, we're going to take a sample of your saliva, send it to a lab so we can figure out what is causing this infection. And that then we'll see if antibiotics are the best choice for you. So again, very personalized. The patients understand that. They're used to having blood work done. They're used to having tests done. So it's very logical for them. The acceptance is really good. And you just factor the cost of that into the fee for the treatment. So again, this are the things I'll talk about more about in part 2 when we do that presentation. So the doctor will come in for an exam, and you're also going to give the patient some home care instructions. I have started calling, and here's a tip you can take back to your offices on Monday, call home care instructions physical therapy. So if you want them to get a water pick, or you want to get them to get a sonic brush and make that investment, you have to explain the benefits of that. How it massages the tissue, how it enhances healing. They're going to be coming in for some therapy, and they need to do physical therapy at home. They get the concept. It's not like, yeah, they're telling me the floss again. I heard that over and over, right? And it hasn't worked. We have to make that different impact. So the verbiage we use is important. So then we're going to clean their teeth, but we're not going to do any subgingival scaling at this time. We don't want to hurt the patient, and we want to stimulate this immune response to start the initial healing, but not cause tightening around the neck of the tooth. So we're going to remove all the supragingival deposits, the stain, the calculus. We want to polish their teeth, make sure that they feel nice and clean when they run their tongue over their teeth, as well as start that initial biofilm disruption with an ultrasonic turn down low, just to go through the subgingival areas and start that initial disruption, but not removing any calcified deposits. So patients have their genetic risk factors with which they're born. That's how their immune system functions. But then through life, we pick up some bad habits, maybe smoking, heart disease, diabetes. In most cases are completely preventable. These are lifestyle choices based on poor diet and sedentary lifestyle. We look at their stress levels, their lack of sleep, as I mentioned earlier, and the issues that they have with their diet. So when we look at the family indicators, the genetics, when we ask our patients about their health history, you go through that every time you see your patients, but we also need to ask them about the health history of their parents and grandparents. So direct genetic line. Is there a history of diabetes in your family, heart disease, stroke, high blood pressure, any autoimmune diseases, any inflammatory disorders? So when you know that, maybe the patient isn't diabetic today. We don't know that, but they have that possibility because of their genetics. So that's going to put them in a different category with risk factors as we're trying to develop how many appointments they need to be treated for their infection, and then how often we need to see them to keep them as healthy as possible. So with the other issues that we have to deal with, and again, we have this opportunity if we're seeing patients over a series of appointments to incorporate this information about nutrition. So important, right? So most of our patients are on the American diet, which I call the death diet, right? So we're not eating the right foods. We're eating foods that actually are destroying our gut microbiome. And so we need to have that as part of the risk factors as we talk to our patients and learn more about them. What medications are they taking? Do they have any occlusal trauma? So we can see that. We test for the musculature when we do that head and neck exam and look at the failing dentistry. Again, these areas are trapping biofilm. They're trapping these deadly pathogens. No matter what we do with the rest of the mouth, if we still leave these there, again, part of all-encompassing treatment is all the restorative is done as well. And we want to do behavior modification. And that takes repetition, just like treating the tissue needs repetitive therapy. Seeing the patient also, we need to repetitively give them information for them to own it and to understand it. So with open-ended treatment planning, again, since we can't predict how somebody is going to heal, we're going to give them a range. So kind of a guideline. How many appointments do you think just to remove the deposits? That's one way to look at it, and then add a couple more. But we really want to look at, not so much the calculus, but the risk factors. So based on that, how much inflammation, how much bleeding there is, how much attachment loss and bone loss there's been. This is what we're going to use to just determine how many appointments we're going to tell the patients they're going to need. And again, there's going to be a range. So if it's early disease, we're talking about gingivitis where there's no bone loss, no recession. If there's recession, root exposure, that is no longer gingivitis. There's some attachment loss. So we're talking basically about bleeding with shallow pocketing. So a very common treatment plan with this JP protocol would be 2 to 4 appointments, maybe a half mouth of 1 appointment. When they come back for the second appointment, you treat the second half, but we're going to retreat the first half again to see what is happening with that healing. Is there still any bleeding? And if there is, we need probably we'll need more than 2 appointments. So we're going to assess the areas we've treated every time, and we'll be doing some retreatment with just ultrasonics, or whatever else we need to do. So again, as the case types, as you can see here, become more advanced, we're going to give them a range again of maybe 4 to 6 appointments. And you can use odd numbers depending on the patient, the risk factors, 3 to 5 appointments, but we give them that range. And then 6 weeks after they have that last treatment, they're going to come back for what we call the 6-week therapy appointment. So let's talk about bleeding, right? We want to get 0 bleeding, and sometimes we'll see a patient like this. So this patient had basically 2 to 3 millimeter pockets. You can see there's a lot of attachment loss. There are a couple of 4 millimeter pockets here and there, but there was no bleeding, no plaque. Patient looked very clean, and this patient is me. So this is me a few years back. Since this time, I have had ortho. I've had a lot of grafting with root coverage. I've gone through myofunctional therapy. I've had a frenuloplasty. My motto is, it's never too late to renovate, So I've done so much in my own mouth, but this experience was really, really eye-opening to me, because this is in the early days of salivary diagnostics. In fact, the JP Institute was really jumped on that, and we're very happy to help spread the word once oral DNA labs opened here in the US. So with that, when the first time I had testing, you can see I had 0 bleeding, but look at what I had above threshold. I had Tannerella above threshold, a deadly pathogen linked with so many diseases. And with that, again, as a hygienist, I floss every day. I've been using a sonic brush forever. I've been using the water pick. Everything is super clean. There's no bleeding. And yet here I had these pathogens above threshold. So we don't know what's going on in a patient's mouth without testing. And now that we have this, I almost feel like if we're not testing, it's kind of irresponsible, because we need to find out what's there. Otherwise, we are just guessing. And I found that out with myself. So when you have a patient and they have pathogens above threshold, because this is a transmissible disease, it's a great idea to get the rest of their family to come in and get them tested, because we pass it back and forth. That's just what happens as human beings. So of course, I had my husband come in, and guess what showed up with his test? Nothing. He looked great. It was amazing. So again, it all depends on the patient's own immune system. and their own oral microbiome, quite obviously. So I really believe that I got my periodontal disease from my ex-husband, but as you can see, this time I married well, and I got the lab results to prove it. But again, we don't know what we don't know, what we can't see. So I'm kind of happy that I'm not dating anymore because, knowing what I know, it's like you kind of like somebody and I feel like I want to say, hey, I really like you. Would you mind like spitting in this tube and I'll call you back in a few days, So anyway, that's how it is. That's how life is. And we do have this issue with transmissibility to those that we love, quite literally, right? So updated my own test results. This was through Direct Diagnostics. And this was actually a sample taken at the Collaborative Cures 2022. And as you can see here, I have no more Tenorella present. I just have fusonucleatum bacterium. However, when you don't have any of the other pathogens present, fusonucleatum at that point becomes the commensal bacteria. So it's a friendly bacteria that is really, in our best interest to have that part of that nice oral microbiome. And I just recently had another test just a few weeks ago, and this is my current status. This is done by Oral DNA Labs. So I've been able to maintain this level of health. Now, I did have periodontal therapy. I had bone grafting. I see my hygienist at my perio office every 12 weeks. But I also, since that first test that you saw was taken, have been using Stella Life Rinse for daily oral hygiene. I use it generally twice a day. So with that, I'm able to help sustain overall health because all of these pathogens are being targeted, and now all I have are nice friendly commensal bacteria. So again, getting back to the JP protocol, with repetitive therapy, we want to really harness these 4 phases of wound healing. So when we have our patient come in for the therapeutic appointments, these appointments should be 10 to 14 days apart. So it takes about 10 to 14 days for the initial epithelial healing to take place. And with repetitive therapy, we're going to begin the treatment in the area that is most infected. When the patient comes back for the second therapy appointment, should be at least 10 days after that first one. We're going to assess which area needs to be treated, but we're going to retreat the area treated before with ultrasonics. At the appropriate level, we're going to go through these pocket areas through the sulcus and again remove the biofilm that's accumulated in that time. But if we do it too soon, like back in the day, I used to see people every 7 days, like I'll see you every Monday at 3 o'clock for your deep cleaning. That was the conversation in those days. There hasn't been enough healing to be able to see what's going on with that patient, and they're still in that process. There's still a wound site there. So we need at least 10 days between appointments to truly assess the healing process with that individual. So again, our goal is disease remission. So treating to completion means that we focus on the areas based on need. If there's a restorative priority, then we may choose to treat those areas first to get the tissue healthy so that we can get that going as soon as possible. Maybe even having patients come in for a periodontal therapy and a restorative procedure on the same day, if that works with your schedule. But we're going to, again, the first therapy appointment, when we see them for that hygiene appointment where they first come in, whether it's a perio maintenance or a regular prophy appointment, and we're only just going to be doing a screening because we need to have time for communication with our patients. So we're just going to do a screening because we're going to do the complete comprehensive periodontal charting at the first periodontal therapy appointment. At that time, we're only going to be working on one part of the mouth. So we'll have more time then in that appointment so we can do a comprehensive periodontal charting. Based on what we see when we do the screening at the beginning of that appointment, we'll choose where we're going to be treating that patient. We're going to anesthetize those areas, do the charting, and then treat that area. When the patient comes back for the second therapy appointment in 10 to 14 days, we're going to assess where the areas are involved on that day because we can't make assumptions. We need to actually do, we call it a tissue response with a probe to see what's happening with the bleeding. or if the patient has an area that's sensitive, we'll focus on that area. So we'll go ahead and treat that area, but we're going to retreat the area treated before. And we'll do the same thing at each successive periodontal therapy appointment until we work through the entire mouth. So again, with a more advanced case, we may be talking about 4 to 6 appointments where we're working in sextants. It can be different areas of the mouth. As long as we're working on contiguous teeth in one area, it works really, really well. And this is really the only way we're going to be able to treat to completion, not only having the time to deal with the biofilm, exposing it to our ultrasonics, our lasers, our air polishers, but also to do that behavior modification. If we cannot change their behavior, they are not going to stay in remission, and that's going to impact their health and shorten their lives. So when the patient comes back 6 weeks after they do have their last periodontal therapy appointment, we're going to do another comprehensive periodontal charting, see how they have resolved. We're going to do a full mouth repetitive therapy. Generally, this point is just with the ultrasonics, again, going through the entire mouth, removing that biofilm that's accumulated. That's also going to show you how they've healed. Are they bleeding when we do that? If so, what do we do next? You know, we may need to refer them out. We may need to do more therapy. So we won't know until we see them at this time. We will do a full cosmetic polish, and the doctor will come in because we need the doctor's diagnosis. You know, can we go ahead and put this patient on maintenance? Is there still some infection present? And what would be the next step for that? So, of course, we have the doctor involved with that decision. And if all is well, we're going to go ahead and schedule the next hygiene appointment. So the next maintenance appointment. If there's any restorative needed, then that needs to be scheduled and get that going as well. So the patient's tissue is healthy. We can have them do whatever crowns or veneers they may be interested in. Now they have really healthy tissue. We can do the restorative that's needed as well. So when should the patient come back for their first maintenance appointment? It's a really great question. So with that, when we have patients coming back, if they are here for the 6-week therapy and there's no bleeding, they look really great, they don't have any risk factors, then we recommend they come back in 12 weeks. We want to track them and talk about weeks rather than months. Throughout the whole history of my career, and I still see this everywhere, people talk about a 3-month, 4-month, or a 6-month. Okay, 6 months doesn't work because that has no scientific basis. And we know that the bacteria begins to be active much sooner than that. So rather than jumping from 3 months to 4 months, because a lot of biofilm, a lot of pathogens can grow within 4 weeks, we're going to go week to week. So we're going to start at 12 weeks. And as they come back, we're going to evaluate how they're doing at that 12-week mark. If they're doing well, we can extend it by another week, but we're going to find what's going to work best for that patient. And remember, until the restorative is done, the periodontal therapy is not complete. So we're going to use all the technology that we have available to get the best results with our patients. And we want to also use non-toxic products for safe disinfection. And we want to make sure it's non-irritating. So I loved hearing Violet's experience as this is the feedback we get from everybody using Stella Life, is we have a very pleasant experience using it. It tastes really great. But again, our goal is to create a balanced and healthy oral microbiome. So with the Stella Life products, we're able to really disinfect safely without any staining or burning. This does replace chlorhexidine when we're doing any type of, surgical procedure or with our hygiene patients. But it does eliminate the pathogens that we really need to manage. With P. gingivalis, it's effective against that. Also with strep mutans, with patients that have a high caries risk. And again, it has so many other applications, as Violet shared, with xerostomia, with any type of mucositis, your cancer patients. But in perio, we're able to really be very effective to help keep our patients in remission longer. So as far as how non-toxic the Stella Life is compared to, in this study, it was compared to Listerine as well as compared to saline and chlorhexidine. And if you look at the samples here from the scratch wound assay, you can see the Stella Life sample and you see the fibroblasts growing there because it's not going to be killing them as chlorhexidine does. The chlorhexidine also kills the osteoblasts, the cells that grow bone, the fibroblasts grow collagen. So we want those to be reproducing and growing. And this is how we get this accelerated healing. Here's the control, normal fibroblast activity, but we can see how many more fibroblasts are growing with a Stella Life sample. So it is non-toxic to those bacteria. So as far as also how effective is it, to sustain and have a bacteriostatic activity against these bacteria. So it kills them, it's bactericidal, but also keeps them in check for varying lengths of time depending on what the pathogen is. So with Fusonucleatum bacterium, after exposure to Stella Life rinse, this one is kept in check for 12 hours. So again, used as a daily rinse, we're able to keep this under control. But look at this, P. gingivalis. Okay, so as a JP trainer, we're always talking about this keystone pathogen and how it literally is a deadly pathogen. So what we see is after exposure, it's actually inactivated for 96 hours. So think about that. After all that we do, if our patients can use a product like this that's going to keep these bacteria in check, we can not only help them have a healthier mouth, but also a healthier body. And that's what we're here to do, to save people's lives and to improve their lives as well, of course. So what we also found in the study done at Rutgers is that the Stella Life rinse is kinder and less toxic to the commensal bacteria. In fact, some of the ingredients actually help to promote the growth of the commensal bacteria. And as you all know, these bacteria are critically important. So they have very important functions. And this is an emerging field. We're learning more about these incredible bacteria, these amazing microbes, every day with the ongoing research, how important they are to our mouth as well as to our gut. We have these friendly bacteria all over our bodies. There are, prebiotic skincare products that I'm using, and you see all sorts of products these days that include that because we're now understanding that we need to have that nice balance. So with this study, the Dr. Scott from a periodontist did, he looked at the nitric oxide being produced in the mouth. So when he used test strips that you can get at a drugstore, you can put in the mouth to find out if you are producing nitric oxide. So when he had patients that used oxystoma peroxide-based rinse or chlorhexidine, when they used the test strip, they had no nitric oxide being produced. And the nitric oxide keeps our blood vessels dilated. Without that, people's blood pressure goes up, which it does when they use chlorhexidine twice in one day. Blood pressure can go up to 2.5 points. So we want to keep those dilated. We need that nitric oxide. So when patients use the Stella Life, they were producing nitric oxide. Now, you all know they also need to be doing nasal breathing, so they may need to do lip taping. This is where the myofunctional therapy comes in, but we can really, truly help them and not really kill these bacteria. So with all-encompassing therapy, we're going to be providing that behavior modification, educating that patient. If they need myofunctional therapy, if you provide it, of course, you're going to put them into that program. If not, we need to refer them out. And sometimes we need to refer them to a physician. So if they're not healing, then we know that there's something else going on. It's beyond the scope of our care. So we need to get somebody else involved, hopefully a functional medicine doctor, if they have access to one. However, we've had hygienists and doctors, hygienists who've been doing periodontal treatments and doing the repetitive therapy over, a number of weeks with patients. And if they're still not responding after all of that, there's something else going wrong. There's something else going on there. And as they've referred them out, we have patients been diagnosed with leukemia, with anemia, with many other disorders. So again, if they're not healing, this is a sign to you that this patient needs some other help. There's something going on with their immune system, with their bodies. So, if we give them the opportunity to heal by doing all this, using this all-encompassing approach, and they're still not healing, this is where we're really, again, saving people's lives, getting them the help that they need. If we're expecting they're always going to be bleeding, we are never going to see, if there could be an indication of some other problem. So once, again, we put them in treatment, as I've mentioned before, we're going to establish a closely monitored system. They come back 12 weeks if they look really great. And if they come back with some bleeding, then you decide the next step. Are we going to shorten that interval? Are we going to do more therapy? Do we need to refer them to a specialist or a physician? So again, very, very customized, but again, working in terms of weeks. If they look great in 12 weeks, then maybe we'll try 13 weeks. And if they still look good at 13 weeks, we push it out to 14 weeks. So we're looking at a very, very customized, individualized plan. And again, if we can do the salivary diagnostics at these appointments, which you would do, we recommend doing it at the first periodontal maintenance appointment. So they have X number of periodontal therapy appointments. They come back 6 weeks later for that 6-week assessment, or it's called the 6-week therapy appointment. And then as they come back for their first maintenance appointment, which may be 12 weeks after that 6 weeks, that's when we recommend you do their next test to test the saliva, because we've now had a time for that oral microbiome to be reestablished, because there's going to be a time when the bacteria are duking it out, to see who's going to be where. And so we need to let that oral microbiome establish itself, and then we can evaluate it. So again, that's when we should do the first testing, and then do testing as needed. If patients are looking good, again, because we don't know what we can't see, I think it's a great idea. We do recommend having them tested at least once a year so we can really see what's going on in their mouth. So we're going to be seeing them do the clinical procedure, and again, push that interval out by 1 week if they're looking good, and continue to do that. And what we find if we do that is that we're going to find the balance point for that patient. So maybe for some people it's 12 weeks, others it could be 10 weeks, maybe it's 14. So we're going to find what's going to be working best for that patient to truly keep them healthy. So once we've dealt with that biofilm, it grows back. If we use a nice disinfected rinse, that's really helpful, but it's really all about getting that healthy oral microbiome. So as Violet mentioned, the Stellalife pre and postbiotics kit, you just saw this image earlier. I think we're the only company I know that has an oral and a gut probiotic in one box. And with that, we're able to, help their gut as well as their mouth. And with that, the species that we have included have been, studied very, very carefully, and have been carefully selected to give the patients many, many benefits so we can sustain good health in the long term. And with the case that was shared by Violet, this patient had pocketing. You can see the pocketing. You can go to stellalife.com to the research tab, which is under the professionals tab. So you can see all of the research and studies in depth. And you can see the probing, the periodontal charting with this patient. So she had 4 to 6 millimeter pocketing with generalized bleeding. After having just SRP and the probiotics, no other Stellalife products were used with this particular case. The tissue looked a lot better, reduction of probing, deaths, and bleeding. And I know people say, well, yeah, after I do SRP, yeah, of course it looks better. That's what I get too. But look at what happens after 4 months. So this is what really we're talking about, is being able to keep our patients stable, to keep them in remission, and keep them healthy for the long term. So they can use these if we're giving them antibiotics, if that's indicated in their salivary diagnostics assessment, then we need to give them something to help with their gut microbiome as well. So with that, if we can use these products, if we can help our patients treat them to completion, then we can achieve zero bleeding. It's not mission impossible. So with that, I want to thank you again, for your long attention. This is my direct email. You can contact me if you want to learn about Stellalife, the JP Institute, or have any questions for me that we don't have time to go through today. So Violet, I'll hand it off to you and see if there are any questions for me today.
Well, Liz, everybody thought that your comment about who you are, who you are kissing was very funny. That was great. I had a lot of folks, especially Camille, said, "Oh my God, that's too funny," and it is. It is. It's very funny, and it is important, that we who we're who are
Well,
who are
It's life. I mean, that's what I was saying. Like, if you live, I live with my mom who's 89 with my husband, and, my children are adults, but this bacteria, we share it no matter how careful you are. And I can tell you, I use that hand sanitizer, the Stella hand sanitizer all the time. And still, we come into that contact. I mean, one of our JP trainers in the past used to say her daughter was 4 years old at the time, and she said, I'm never going to let Claire kiss any boys ever. Well, good luck on that one,
Yeah,
It
that's
was
never going to happen, but good luck.
right.
Never
Well,
gonna
to be
get started.
happy, you want to be happy, right? So
Yeah,
part of that is, having these relationships. That's natural, but we just need to take care of our own immune systems and be aware of that, So
absolutely. So one of the questions we had is how would you code that cleaning before SRP? Do you have trouble getting patients back after the super cleaning?
So this is something that has always been a question. I can tell you with insurance, you never know. Okay, they're going to do what they're going to do. As we've all seen, they're giving less benefits to things that we know our patients qualify for because they meet the criteria, and they still, kick it out because they're hoping you're not going to resubmit. We have never had a problem. I know that that's been something that has been stopping us and having us hesitate with our patients because we feel, or we have learned, or we believe that we can't use another code because so then we tell them they're coming in for a cleaning, and now you're telling them, well, you know what, you got this going on, so what we have to do today is a deep cleaning. And so to the patient's perspective, that's like, whoa, I wasn't expecting this. They were expecting another procedure. They're ready to pay for this other procedure. Maybe they have insurance benefits for that. So we are going to use whatever code they came in on. So if it's a patient that's there for a prophy, it'd be 1110. If it's a perio maintenance patient, it would be 4910. We would submit that, and we're going to be doing that procedure because they're maintenance. So we're talking about removing the deposits from the teeth, the supragingival calcified deposits. We're going to be dealing with the subgingival bacteria during that JP, what we call it, the DT, initial diagnostic therapy. That's what that 1110 or 4910 will become as we categorize it in our notes, because that's part of that treatment plan. But we're going to submit that to the insurance company. We've never had anybody say, well, you can't do the scale and group planning because you sent that code. That's never happened. So again, what they may do in the future, we can't predict, but that hasn't been a problem that I've ever seen in over 30 years of teaching that protocol. So I hope that answers that question.
Gotcha. So the next question we had is how does using Stella Life's mouth rinse every day not disrupt the microbiome?
As we saw with that Rutgers study, we're finding that it doesn't. One of the ingredients in the Stella Life rinses is propolis. And I didn't cite it in my presentation, but there was a British study that showed that propolis, which comes from beehives, it's very soothing, has great antifungal properties, but it also helps to enhance the growth of the commensal bacteria that control our blood pressure. So this is a finding. So it's kinder to these commensals. So this is why it's such a great product, because it's not going to harm that, because as we know, no commensals, no nitric oxide, and that increases people's heart attack risk. So that's why those other products that do that are quite deadly, and we're confident that Stella Life doesn't do that.
Absolutely. So, what about 1 to 3 millimeter pockets with barely or no box? Recession is present and bleeding when scaling. What could that be? Does not sound like gingivitis therapy or SRP.
So again, if there's any bleeding, we know there's an infection going on there, if I'm understanding the question correctly. So again, no pocketing, no bone loss. We will call that a gingivitis therapy. You're not going to get any insurance benefits for that whatsoever, but you're going to inform the patient that there's an infection and the bacteria is getting into their bloodstream. So this is why we need to treat it. We show them the bleeding, and they understand that because we have that time to discuss this with them, because we're not trying to put the pedal to the metal and get them out before we have to turn the room around for the next patient. So we're going to take a moment, sit them up eye to eye, knee to knee. I'll talk about this in part 2, because if we can't get them in the chair, doesn't matter what we can do for them, right? We got to get them there so that they can be treated. So we're going to give them this information. So again, the treatment plan would depend on risk factors, level of bleeding, are they mouth breathers? You got to look at all of that as well. But that's how you would actually have the treatment plan. Again, if they don't have any bone loss, then you're not going to be getting any benefits from insurance. It's just a matter of giving that case to the patient, and then they make the decision based on their own health and their own,
So,
go ahead.
yeah, no, go ahead. I'm sorry, Liz. I didn't mean to cut you off.
No, I was just going to say that we always, this is where it's a matter of having that conversation with that patient so that we're able to enhance their understanding, give them that education, and leave it up to them to make the choice. So, this is your health, this is your body, this is what you need, and we're happy to provide this for you. If they don't want to do it, then part of the protocol is to ask them, what's stopping you from having this treatment?
Yeah.
Let's
So,
find out what their barriers are.
yeah, absolutely. A lot of times, people, I know with me, it was always financial, but then the reality of life started to set in that there was a lot of things going wrong with my health, and it had a lot to do with what was going on in my mouth. So the health costs were exorbitant. So suddenly the mouth cost didn't seem so exorbitant anymore compared to the health cost. So, it's a trade-off, and it's hard to get patients sometimes to understand that. I was one of those patients. So the more that I learned, the better off I was, and the easier it was for me to accept care. So another question we had was, what does RDHMP stand for?
So that's a great question, but I just want to go back one thing when you're talking about, learning about what you need and the education you've gone through your own experience. This is also where salivary diagnostics, with that patient who you don't know what they have, it's gingivitis, whatever, you need to find out what bacteria is causing that bleeding, regardless of their pocket depths. And again, they can be asymptomatic. This is why we should test everybody, and with a lot of offices that are doing this, aaosh practices in particular, they're going to have, when a new patient comes in, do a whole profile on that patient, which would include getting a saliva sample and finding out what they have going on in their mouth. So, just to get back to that question. So RDHMP, this is a mastership program. It's kind of like the fellowship program with aaosh that the JP Institute provides. It's an intense workshop with a lot of CE, where we train the clinicians, the hygienists, about the protocol, how to apply it, and then they go back and actually apply it in their practices, and they have to provide some case studies. And we give them the guidelines of what they have to do, and then they return for the second phase of that training and actually share their case studies. And we all have a discussion about that, and we're collaboratively together. But this is how we get mastership, where you do this with a number of patients over a period of time using whatever technology you have, and then you can have that certification of mastership with the JP protocol.
As a backup to the question about the 1 to 3 millimeter pockets, it said, but if recession is there and no bone loss, that is the confusing part.
Right. So recession, again, can be there for a number of reasons, but what I'm concerned about, because with the JP protocol, we recommend the gingivitis therapy. Again, a lot of times we're talking about kids. So we're talking about youngsters that have no bone loss. They just have bleeding. Think about the kids in ortho and all of those patients. So again, this is impacting their health. I learned recently that the process of dementia, when that starts? When you're in your 20s. So it doesn't begin when you're in your 40s or 50s. It starts when you're in your 20s. So we've got these bacteria circulating in these kids' mouths. It's not resolved. And then, so gingivitis or whatever, there is the disease process that's happening there that's going to lead to these other diseases. So with that, if they have some recession, some people believe it could be from aggressive brushing. A lot of times it's because of occlusion, as you saw with my own mouth. A lot of the recession I had, the attachment loss, was because of my the traumatic occlusion that I had since ortho in the 70s, I had to have it redone and went through that fairly recently. That's why I say it's never too late to renovate. But when we have the gingivitis therapy protocol, because there's no insurance benefits for it, the fee that we recommend the doctors charge for that is less than it would be for a periodontal therapy, which would be your 49 4341 4342 type of billing to insurance, and the fee would be greater. So what I was seeing is that because we we have this tendency to try to, they don't have so much money. Oh, let's just call it a gingivitis therapy. And these patients may be whatever age they are, but they've got recession. They have all this stuff going on, and we're just really calling it gingivitis therapy because we want to save them some money. So we are really making the decision for them, and we're making the wrong treatment plan decision. So again, when you look at each patient, just look at them, not comparing them to anybody else, get the salivary diagnostics done, and then be really honest with yourself. What is this recession? What does it really mean? Is it traumatic occlusion? Is it overzealous brushing with a hard brush? Or has there become a recession because of inflammation? Because then after you have the inflammatory process and the tissue is swollen and bloody, as it heals, you always lose a bit over time. It's not going to generally come back to that CEJ if you don't catch it early enough. It's actually going to cause some recession over time. So this is again why we need to treat early so we can retain the beautiful architecture of our gum tissue.
Yeah. You would be surprised how many people I just came from a hosted buyers event, trying to go out and get all us aaosh members good hotels and convention centers for 2026, 2027, and 2028 for annual sessions. And just talking in general with people, how folks still believe they need a medium or a hard brush to brush their teeth, and you're just sitting there with your eyes, wide open, like, what? No, no, you don't need to do that. That is not necessary. You can get your teeth clean without taking a brush and literally, sawing off all your gum and everything else along with it. It's okay. You don't have to brush them till they bleed. It's okay. You don't need to do that. So you would be surprised at how shocked when people
I'm not I'm not surprised, and not to interrupt you, but I mean it goes the same way with using products that we don't want to mention their names, but you know what products we're talking about. People say, "Oh, that stuff burns." I know it really works,
Yeah,
because
that was another one. Yeah, there was a young man who sat down to talk to me that was like, "Yeah, man, I've got my breath is so fresh every day," and he was carrying around a small bottle, travel size bottle
yeah.
of the stuff that burns like you're drinking moonshine from the mountains of East Tennessee. It's what it tastes like, that you're putting in your mouth. You might as well be. There's not a whole lot of difference in the two. You might as well use gasoline too while you're at it. But it's the same kind of thing. And he was bragging about it. And I'm sitting there going, no, please don't do this to yourself. No, don't do that. And then when you tell people that your organization is the mouth body connection, that your blood doesn't stop at your jawline, that it's the same blood that runs through the rest of your body, the look on people's face is amazing. But it's always the education that we provide here is so great, and we're always so grateful for our RDHs, Liz, that come in, because you guys are the front lines. You
Well,
guys
we
truly
see our patients more often than they see the doctor, and our patients, as you all know, see the dental office more often than they see their physician, unless they're being treated for some kind of a chronic disease. So a lot of our patients have chronic diseases they don't even know they have. We're on the front lines of that. And this, again, if all of these people today still don't know about this, we're not doing a good job. So we have to change what we're doing.
Yeah, absolutely. Absolutely. So there was also some discussion about between Beth and Heather, they were talking about D4346 is the gingivitis code that insurance companies are paying for D4346 all the way. So folks, that's some good information that they shared with everyone, and that may be something that may be helpful
It gives
to,
them they get one appointment with
yeah,
that code. So we know we can't treat periodontal disease or
in one
of
code.
any with just one appointment. So
Yeah.
They're going to need multiple appointments. If they're not going to get benefits, it's going to be fee for service. Again, we're going to leave it up to the patient to make the decision. We're not going to not offer it because we know the insurance isn't going to give it to them. So we just have to be really honest with our patients about that.
Liz, do you have at the end of your slide presentation the QR code for your CV? Is
Oh,
this your
yes.
last slide? Yeah,
Yes,
there we
sir.
go. So
Yes.
I wanted to put this up for everybody so that everybody has it. So this, folks, is how you, again, this is the same for every presentation, but we want you to be able to have it so that you can claim your credits for this. We are we are so grateful, Liz, for part one of your presentation. There is a part two. If you want to know when that part two is, you can visit aaosh.org and look for our webinars page. It's really easy to find. It's under our events page. She will be presenting a part two to this later on in the year to talk more about all the great work that she's doing about bleeding gums and things that we can do to help stop the bleed in the mouth, and what all the great work that she does every day in her practice of the JPI Institute, and other, and with Stella Life, and some of the other things that she does every day as well. So one of the things that I will say, I am so grateful to Stella Life. Stella Life was one of the first organizations who believed in this idea, that this crazy idea that I had, that our exhibiting partners, our friends, our sustaining partners should be with us all year long. And we are so grateful to the folks at Stella Life. We love you all. We thank you for your
Thank
willingness to
you.
step
If you
out.
have any questions about Still Life or JP, you can email me at lizlundry@gmail.com, and I'm happy to help connect you. And when you're talking about also toothbrushes, I have a wonderful new power brush that I've been introduced to recently that is the softest brush ever. So that's been a game changer for me and anybody that has any attachment losses. You saw I did, you know? So
Yeah.
I'm happy to help. So thank you all so much. And thank you, Violet. Thank you, Aosh.
Yeah, absolutely. So we absolutely love you, Liz. Thank you so much.
Thank you.
Guys, again, this is how you get your credit, guys and gals, for Liz's presentation. Be sure you scan that. I am trying to encourage everybody, please submit your CE credit as soon as you can. It just makes your life so much easier when you do, because we can't backdate your credit, so we can give you 90 days, but we love for you to submit it early so we can get it over to AGD PACE and over to our accrediting bodies. So, Liz, thank you so much. What we're going to do, ladies and gentlemen, is we are going to go on a lunch break so that everybody can get up, stretch your legs, grab a bite to eat, spend some time just doing things like I need to do, like answering emails because my inbox is full, trying to spend a few minutes catching up on things you need to get done. So let's take some time. We will come back at 12, well, at 12:45 Eastern time, 11:45 Central. We'll come back together here in 30 minutes. Go enjoy some lunch, get up, move around, stretch your legs. We've got a lot to cover when we come back from our lunch break. And when we come back, we will be joined by the folks at Supermouth. So if you have never heard Dr. Cami Haas, you are in for a treat with Dr. Haas. He is fantastic, and so are the folks at Supermouth. So we look forward to seeing you back here in about 30 minutes. Have a great lunch, guys. Thanks again, Liz. We appreciate you.
Thank you. We appreciate you as well. You're the best. Thanks, everybody.
Thanks. Hi, everyone. I just want to start getting everybody settled as we start coming back from the break. So we've got about 2 minutes before everybody will be back from the break, but I wanted to kind of give everybody a chance to kind of say, hey, it's time to come back from lunch and give you a chance to get settled in while we're waiting, just to have a little time of getting yourself settled back into learning and ready to go. So we'll start here in about another a minute or two with Dr. Haas, and I'm going to grab my AirPods because I'm sure my dogs are going to make a racket here in just a minute because we're expecting the delivery, and it'll be much easier if you all can hear me without hearing a beagle and a Havapoo. So hold on just a second. Let's do a little change out here.
I've told my dog not to knock on the door, so hopefully he'll listen.
I have notes like everywhere on my door that's like, please don't knock on my door. I beg of you. I work from home. Please don't knock on my door. They never listen. They
Me too.
knock
We
anyways.
literally have construction next door, so I had to walk over and say, please, can you just no banging on the door or anything for like just 2 hours? And they're like, okay, sounds
Yeah,
good.
just give me a little. We put instructions. We've actually stopped food delivery here because getting anything delivered because norovirus is going around so
Yeah.
bad, and it's so easily transferred. It takes
Yeah.
nothing to get it. My husband and I've ended up with it twice
Oof.
in the past 2 months, and I've just
Mhm.
stopped all deliveries to the house. Period that's coming from food or anything like that. We've tried to just limit the number of deliveries, which has been hard because my husband and I both have an addiction to Amazon, and we have an addiction to, and I know there's people on here who can relate to that.
I
So I
can.
know that, yeah, everybody go ahead and raise your hand and tell me that you're addicted to it. So we've kind of had to stop deliveries because we're just sick of being sick, and it takes nothing to get it. So we just stopped it and said forget it. So we've given up. But it's really rough here right now. So it's flu A is going around really bad here right now. I had that myself. It's no joy, thank heavens for the flu shot, or I'm sure it probably would have been far worse. But I pray for everybody, and I know illnesses are rampant right now. So yeah, between the stuff delivered at the door and the knocking and all the noise up and down the street because a lot of kids are out of school. I think they even let school out the rest of the week because of the flu and all the
Wow.
stuff that's going around. Yeah, it's pretty rough right now. So, Dr. Haas, I know you're going to talk to us about Supermouth, and I'm super, super thrilled for you to go ahead and get started with that. Folks, you are in for a treat right now. You're going to get to learn about some new innovations at Supermouth that shows a full picture of full family dentistry. And I'm really excited for Dr. Haas to share those with you today. So, Dr. Haas, Danielle, if you will make sure that Dr. Haas has sharing permissions, are you able to share your screen with us? There we
Um,
go.
is it good?
Yeah. Yep,
Okay.
you're good.
Well,
You're rocking and
I
rolling.
never know on this side what people see, so that's good that you confirm it, please. Thank you very much.
Yeah,
Well,
absolutely.
well, thank you. That was a wonderful introduction. I really appreciate it. I hope you guys go through the virus season very quickly and everybody comes out safe. I know those viruses, none of these viruses are good. You just like out for a couple of days, even the flu and the cold, what a waste of time. Like every couple of years, you're out for a few days and anyways, back to normal. So anyways, thanks so much for having me. I'm really excited to discuss Supermath, but more importantly to even on the CE course to really get into the details of oral care products. Because as you probably know, I'm an orthodontist. My wife is a pediatric dentist. In dental school, I went to UCLA 30 years ago and USC for my residency. But it doesn't matter where you went to school for hygiene or school, dental school or your specialty. We get little to no education about oral care products in school. And no wonder the number one disease in the world today is still dental disease, which is really crazy because 95% of that should be fairly easily preventable. But because the whole world, the only thing they talk about is fluoride versus non-fluoride, which always bothers me because it's like just one ingredient and it actually blinds us to the other ingredients. And we get so passionate either for it or against it that we forget that there are ingredients so much more toxic and anyway, so I'll get to that into fluoride specifically versus hydroxyapatite in my next lecture. But we launched a company a few years ago really to revolutionize oral care. And I know this word is used, this word of revolution a lot, but really truly, again, I've been in this field for 30 years. All of my colleagues, we gathered other world-class dentists, pediatric dentists, orthodontists, physicians, children's experts. And we said, hey, how do we fix this? How do we fix this problem of the number one disease being the disease that we're supposed to take care of? And so we decided, hey, we need to have products that are customized based on age and stage and risk factors. So a 1-year-old with no cavities and a 10-year-old with a ton of cavities and a teenager with braces and a pregnant mother each get the right oral care products that are specifically for them. And not just, again, the same even 10-year-olds, one is a high risk person, but the other one is low risk. But if you just go to online stores or a grocery store, you just pick up an average toothpaste. If you're in the fluoride camp, you get a fluoride toothpaste. If you're an anti-fluoride camp, you get a fluoride free, whatever that means, because anything other than fluoride is fluoride free. And then hope for the best. Or you go for the natural thing on the packaging because it just sounds good. I always joke around that cocaine is natural, tobacco is natural, sugar is natural, alcohol is natural. I could go on. They're not just everything that natural we should be putting it in our mouths, the mouths of our kids and families and patients, but truly look for, yes, we do want no artificial ingredients. We want natural ingredients, but that's just one of 10, 15 things that we need to check. So hopefully I'll cover a lot of it in the CE course. But so anyway, so what we did, we basically spent many years and we launched with over 200 products. Why? It's very unusual. Usually companies have a toothpaste because we don't want to be a toothpaste selling company. We don't want to sell just toothbrushes. We truly want to revolutionize oral care. And this is how once we spent a lot of time, resources, brain power on this, figure out we need to do. We need to provide all the products that 6 ages and stages require, from infancy to adulthood, and then specialized care like orthodontics and pregnancy, which I'll discuss in just a second. And then so that required a lot of products. And then we really didn't want to just have another fluoride or a non-fluoride product. We innovated and reinvented every product category. We grouped them into 7. We really reinvented the toothbrush from ground up for kids and adults. I'll kind of quickly go over that. Toothpaste, from safety, efficacy, and not just enamel, but the oral microbiome. And then, of course, everybody on aaosh, we understand the absolute critical importance of oral health, systemic health. So whatever we do in Supermouth, we consider not just enamel, but first of all, the mouth is more than that. The whole oral microbiome and gingival tissues and pH of the mouth and all of that. But also what happens when these ingredients you swallow it, it gets gets to the soft tissues of the mouth. What does that effect is on the body? So as a testament to our innovation, we have nearly 300 patents with formulations and designs. This is just unheard of in the oral care. The manufacturers on the conventional side or the natural side, they've been mixing the same stuff and with 0 results. Again, the number one disease being our disease, the dental disease. So it's just whatever everybody else is doing is not working. So the reason we have 300 patents, we've really from ground up on the toothbrush, toothpaste, mouthwash, floss, tongue scrapers, mouth sprays, and accessories. Those are our 7 category of products that we truly have revolutionized every category. And I can go over that just a little bit. This is just one example, and I'll go over like the 6 stages in just a second. We've reinvented the electric toothbrush for the adults. Well, you may ask, why do we need to reinvent it? Doesn't like Sonicare or Oral-B or whatever else, all these manufacturers already invented a really good one? Well, I'll tell you why. There are 3 primary reasons. Right now, toothbrushes are not effective. And don't take my word for it. We just decided, and it's not WHO, World Health Organization, says dental disease is the number 1 disease. These bristles on a toothbrush, like little oval rectangles, were invented in 1938, before World War II. And no anatomy of teeth, and they don't really follow the anatomy of teeth. There is no tooth structure that I've ever seen that's like a little oval or rectangle. They have these very unique anatomies, right? So the way we did it on the efficacy side of it, we went out and scanned. It took us 4 years of R&D, research and development. We scanned thousands of adult teeth. Then we scanned thousands of primary teeth. And then we scanned thousands of teeth with braces. And then for the first time in history, we actually contoured and engineered bristles to wrap around the teeth perfectly. And that has resulted this was done in an independent ISO laboratory study that our toothbrushes, our bristles clean teeth up to 40 times, not percent, 40 times better than a manual toothbrush, which is usually the standard what everybody compares to. You guys can look up the other toothbrushes and how effective they are, but there's nothing on the market that comes even close. The second problem was safety. According to CDC, 3/4 of the US population, 75%, we have dental sensitivity. And the number one reason is, there are several reasons, but the number one is we use an electric toothbrush, very abrasive bristles, even the ones that say soft, and we're causing enamel erosion, gum recession, and dental exposure, and we get dental sensitivity. 3/4, we're causing damage. So we use this incredibly soft material called PBT, and we were not only be able to provide the safest experience, but we were able to pack 3 times more bristles than your standard bristles. And that also increased our efficacy, and why we have 40 times a better efficacy. By the way, if you have braces, we just pop the top one and we put one specifically for braces. It cleans up to 60 times better around for teeth for braces to reduce decalcifications and cavities. And then the last thing is toothbrushes are just disgusting. Again, there's been studies to show that you have more microbes, including feces, E. coli, fungi, everything on your toothbrush than you have it in your toilet or in a public restroom floor. So this next unit that you see next to the toothbrush, you put the toothbrush upside down, it stores the toothbrush, it charges it, it has a UV sanitizer, and it dries the toothbrush. We have the same thing in a travel case, which is really cool because when I travel, you can have the tooth, you have a charger and a UV sanitizer, and even custom spaces for toothpaste and floss. So again, this is just an example of how we re-innovated one product out of the 200 products that we have, and why we have so many patents, because we truly wanted to do something different than everybody else, and from ground up to make sure that from an infant to a pregnant mother to someone with braces has the best products from safety, efficacy, innovation, how beautiful they are, how fun they are, etc. So like this toothbrush has all these features, has revolutionary bristles, is fully waterproof, so you can take a shower with it. It, dries the toothbrush in the hub. It sanitizes it. It's got smart features. It's got a pressure sensor to make sure that customers and patients don't overbrush and cause damage. These are the 6 categories of how we do it in Supermouth. So we think they're very, very unique. We have pregnancy, as you probably know. Again, according to CDC, 74% of pregnant women get gingivitis. They have a lot more other pregnancy-related oral health issues, which I'll go over a little bit in the actual lecture. Then we have the teething stage, which they require very, very unique things. The first 2 to 3 years of the life, oral microbiome is evolving, maturing, so it's really important that we don't kill the microbes with antibiotics. Or, by the way, when I say antibiotics, doesn't mean amoxicillin. Means anything that has antimicrobial effect that indiscriminately kills your oral microbes. And then we have primary dentition. Again, those are very unique needs. Mixed dentition, which is the 6 to 12, teens and adults, which is me and my teenage son, and elderlies, everybody, which is a really, really important one because this is the last set of teeth we're going to have. And of course, orthodontics. We have a full line of orthodontic products. Like our flosses have threaders built into them. They remove 40% more plaque. We put all of our toothpaste ingredients in all of our flosses. What's across the board, though, it's like the safety. There's no artificial ingredients. We also use a third-party verification of safety called EWG, Environmental Working Group. So every ingredient we have is a 1, and etc. From efficacy, again, we have hundreds of doctors across the country and offices that use saliva testing, and they've got unbelievable results, and on and on and on. Again, we have thousands of dentists and hygienists. On the dental side, we usually have dentists, hygienists, pediatric dentists, and orthodontists. So general dentists, pediatrics, ortho, and usually these are the typical ones. Perio, some. On the medical side, we have oncologists, pediatricians, and obstetricians, OBGYNs that use our products or recommend it to their patients because of the benefits that I briefly mentioned. So to you, the benefits are, I'll go over it, but to your patients, they're going to get, remember, your patients are already buying their oral care products. They're just already using a toothpaste and floss. So by recommending the products, you're actually providing a great service to your patients so that you actually take care of them every day of the year, not just the 2 days that they come and see you. So to onboard with us as partners, it's the easiest one. There's no other market. We also looked at this business model very careful about how the other companies do it. Like they would ask me to sell like one of these popular toothbrushes, and then as I was telling my patient, they would buy it on Amazon. But we don't do that. We make sure that our dentists always have the best deals. We actually give our affiliates or ambassadors who join us about $2,000 worth of products and services when they join us. We give them about $400 worth of products so they can test it and use them as samples in their offices. We provide a complimentary CE course online. We actually give them a custom website on Supermount so they can have their dental services website and the Supermount business, and they link it to their website if they want, and on and on and on. Just a lot of services with marketing and business stuff. As aaosh members, if you want to check out our products, you just go to supermount.com and put any product you want or products in the cart and use aaosh20 as your discount code to get 20% off, or just join us at Supermount Pro. Contact us at support@supermount.com and we can quickly enroll you. And then you have access to all of our products at 40% off. And then you can start recommending it to your patients as well for the retail profit, or you can have inventory. So both options, either you order online, we ship it to you, or you buy it in your office and you sell it. We're very, very flexible. Thank you. I think you're muted. At least
Yep, there we go. That explained it. I have a reason. I had to pick up a unruly dog. That was great, Dr. Haas. So, I mean, guys, if you are an aaosh member and you want to take advantage today of the savings, I know that you will love Supermouth products. I have them here myself. I want the new toothbrush. I've just got to find a time to pick it up. I was going to buy it at Collaboration Cures, and everything kind of went sideways for me because suddenly I became the leader of the organization overnight. So we were going to pick one up. So we're going to do that. We're going to do that the next couple of days. So we are absolutely so grateful for you sharing that information, guys. If you have any questions, please direct those to Dr. Haas, and you can actually do that either now or during his presentation he's about to give. So if you will, Dr. Haas, I will go ahead and I will do a full introduction for you this time as we go around. So if you want to go ahead and pop up your presentation, I'll let you go ahead and get that started.
Of course. Let's see. You see it?
Yes, I can. Are you okay with where you're at? Can you see everything? Are you okay? Okay. So Dr. Haas is going to present to us today your complete guide to oral care products, 10 myths that can be holding you and your patients back. So if you'll go to the next slide for me.
Of course.
So this is his financial interest as founder and CEO of Supermouth. So we've resolved that conflict of interest. Here's the course information. Next slide. The accreditation statement. Next slide. We've already gone over that one. There's the disclosure of use and the disclaimer. You can go to the next one. And our method, we've done that one. So there's a course description. And you can go on to the next one. There's our learning objectives today. And to our next one. Alrighty, and I want to introduce Dr. Haas to you. So it is my absolute honor today to introduce a true innovator and leader in oral health, Dr. Cami Haas. Dr. Haas is not just an orthodontist and a dentofacial orthopedist. He is a visionary, educator, author, and entrepreneur on a mission to transform oral health care as we know it. As the founder and CEO of Supermouth, he has revolutionized oral care by creating innovative, cutting-edge products designed for every stage of life, ensuring healthier mouths from infancy through adulthood. Beyond his work in product innovation, Dr. Haas has made a profound impact on clinical dentistry and education. He is a co-founder of one of Southern California's largest dental group practices, serves on the board of counselors at UCLA School of Dentistry, and even founded a nationally accredited dental assisting school, shaping the next generation of dental professionals. As a best-selling author, Dr. Haas wrote If Your Mouth Could Talk, a book that has helped countless people understand the critical connection between oral health and overall well-being. His expertise has been featured on major media outlets, and he is a sought-after speaker at top dental conferences worldwide. Dr. Haas is reshaping the future of dentistry, and we are privileged to hear from him today. Please join me in welcoming Dr. Cami Haas.
Thank you. That was such a wonderful introduction. I should take you with me wherever I go for to talk. I really
I'd be glad to do it. You let me know where you need me, and I've got you covered.
Hey, what do you think of my beard? I was just looking at my photos, and I noticed, my God, I look so much older with my gray beard. But my son likes.
It's okay. I've gone to gray hair. It just looks, it's my wife that makes it look blonde, but I am totally if white out gray, and I've given up, and it's okay. We're all allowed to be a little gray. It's
I
okay.
love it. That's wonderful. Okay, wonderful. Thank you again for that beautiful introduction. By the way, I don't see any what do you call it? Text or like messages or chats. So if there's anything that comes up, feel free to interrupt me or something. So I'm happy to answer it because I know there's a lot of
Absolutely.
questions. I try to cover it because I've done, but of course I'm really more. I'm love to happen, and I know we're gonna have a little extra time at the end if I'm not mistaken, right? At the top of.
Yes, you're going to have time for questions, so no worries at all.
Okay.
Going into the next speaker, you're fine. You rock and roll.
Okay, so we're gonna be, of course, some of these myths. I'm gonna talk about oral care products. What the education that we all should have had in dental school or hygiene school and we didn't. And so the next time when you have a patient or a family member or yourself, we can confidently and expertly recommend what oral care products they should use or they should avoid, and not just about fluoride and non-fluoride. I left the fluoride discussion towards the end because I want to make sure that we all understand the world of oral care should be much more than fluoride or an anti-fluoride. And so we really need to get into all, unfortunately, for the last 2 or 3 decades that I've been practicing, that's the only focus. And so while they're focusing on this one ingredient, we've kind of missed out on so many other ingredients that are either good for us or we should have avoided, which is so much more toxic than fluoride. But so I hope I really cover all of that. I also try to be very objective and try to provide facts and not my opinions. If it's something I'm going to say that I think is more of a opinion, I always tell my son, he's 12, trying to teach him the difference between facts and opinions. I try to say it, but you guys always, ask me if you think that something I said that, is this a fact based on studies or is this my personal opinion? And my opinions are, of course, based on 30 years of doing this. Okay, we're gonna go through this today, and I thought just to make it a little bit fun, we're gonna use myths. These are myths that maybe you don't think, maybe you do some of them, but usually patients have these myths. And by going, some of these myths may sound very simple, but trust me, it'll get a little bit more complex, not complicated, just more fun and something, hopefully a lot of new things today. Poor oral health would be bad enough if it was linked to our oral health, but being aaosh members, you all know how important oral health is to systemic health. And so I'll go over that a little bit, but I'm not going to take up a lot of time. I know there's a lot of other great speakers who do a great job connecting oral health to systemic health. By the way, that was part of my book, was really discussing how oral health is linked to everything from pregnancy health, airway, sleep, mental health, systemic health, etc. Okay. These are really scary numbers. Half of the population over age 30, age 30, very young people, have gum disease, periodontal disease, and more than 70% of them that are age 65. This is crazy. Half of the kids and 90% of kids have some kind of a root or tooth decay. Again, these are some statistics. So cavities is a really big deal. I mean, two things that always bothered me when I was seeing patients. I'm usually a very fun going, easy going thing, but the two things that would wanted to bite my lip is one, when parents or patients would say, "Doctor, isn't that just a cavity?" Meaning, what's the big deal? Just fill it. The other one is, "Isn't that just a baby tooth?" Because baby teeth are so important. My wife is a pediatric dentist, so I had to always make sure that I really valued a lot of the baby teeth. But kidding aside, we all know how important primary teeth are. We'll discuss that in just a little bit. But so as we discussed earlier, half of the world's population suffers from dental diseases. According to WHO, is the #1 disease in the world, #1 non-communicable disease. So again, these are AAPD statistics. Dental caries is the most common chronic disease of kids as well as adults, by the way. It's 4 times more common than childhood obesity, 5 times more common than asthma, and 20 times more common than diabetes. And it's also linked to everything. How? Again, this is not an oral health, systemic health specific lecture, but I'm going to spend a couple slides discussing it. I'm probably preaching to the choir, but I'll go over it nonetheless. So there's basically 3 to 4 ways that how our oral health impacts our physical health. One is the direct way. We have bleeding gums, or we have an open root canal, and the microbes in the mouth enter the bloodstream. And because the blood goes everywhere, it can cause can travel everywhere. It can cause a local infection or inflammation. Okay, so you can go to the heart, cause a local infection there. It can go to an unborn baby, cause problems there, etc. It goes to the joints and GI tract, everything. Or the inflammation in the mouth can cause systemic inflammation, and that could also be very, very detrimental to the overall health. And the other way is, another connection is our oral health, the surfaces of our mouth and the trachea and the lower airway are just one contiguous, pipe. And so, of course, whatever happens in this segment impacts the other side. And this is one of the reasons why during COVID, for example, there was a study that showed that people with periodontal disease were 9 times more likely to die from COVID complication. And but we've known that for decades, that oral health and respiratory diseases are linked. And of course, the mouth is also opening to a longer tube called the GI tract. So of course, whatever happens in the mouth, I sit on panels many times and they're talking about the gut microbiome and they very much ignore the oral microbiome. I always have to joke or remind everybody, like, I'm like, where do you guys think the gut microbes come from? It's not like they're gonna go into your belly through your belly button. You swallow those. So let's make sure that we start from the beginning and make sure that we really value how oral health is such an important thing, especially the oral microbiome, in not just oral health, but the gut microbes and overall health in many, 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 many ways. Okay, these are a few ways. Again, because of the sake of time, I'll just go through a quick life cycle of a person, again, just to set the stage. So when we talk about all these other ingredients and the pH, why this stuff matters. We just discussed poor oral health on a mom-to-be prevents pregnancy. P. gingivalis, for example, is 3 times more prevalent in mothers or in women who don't get pregnant than it is to, basically it's linked to infertility. For men as well, it impacts sperm quality, motility, count. During pregnancy, poor oral health on a mother. And by the way, when I say poor oral health, it has 2 meanings. One is bacterial, but also airway, but mostly bacterial. But anyways, poor oral health in a pregnant mother can lead to gestational diabetes, preeclampsia, which is a fairly dangerous complication. It can cause preterm birth. It can lead to low birth weight. And then the baby's oral development obviously impacts from everything from breastfeeding and the airway. It can increase the risk of SIDS, all those things if the mouth is not growing correctly. Obviously later speech, swallowing, everything, oral development, the way the face is going to grow and looks. And these are every one of these, we could talk about it for hours and how critical it is. That then when you add them together, you just realize how absolutely critical oral health is. Then as the kids go to school, it impacts their education in a dramatic way. During COVID, I was being interviewed many times why many states, including California, where I am, still during COVID required the dental screening before kids could enter school. And it was because it impacts their education. 51 hours, again, these numbers may be off a little bit, but 51 million hours of school is missed every year due to dental problems. Kids with dental problems are 3 times more likely to miss school, 4 times likely to get below average GPA. Again, if you have a toothache, you can't sleep, you can't pay attention to class, etc. You can't have good nutrition. There's just so many factors. It impacts, as we get older, confidence, self-esteem, which is critical. Again, this is such an important thing. As an orthodontist, I've seen the devastating effect of poor self-esteem and mental health on kids. Now, the seeds usually gets planted earlier, but during the teenage years is when, full-blown, anxiety and depression is shown, but usually these seeds are planted many years earlier. And then physical health. Again, being at aaosh, we all know how critical oral health to systemic health is. It's literally linked to almost every disease. This has gone through a cycle, through early 20th century. The pendulum was one extreme that we thought every disease was linked to poor oral health. Back then even they thought stupidity, which was an actual diagnosis disease, it was linked to poor oral health. And then the pendulum, like everything does in our country, goes to the other side for a few decades, and we ignored that the mouth was part of the body. And now, thankfully, we're coming back to a normal, reasonable middle of really based on science and facts, what diseases, from Alzheimer's to cardiovascular disease to diabetes. Some of them have unidirectional links, some of them have bidirectional links. So, and then of course, because of all of this impacts longevity. So this is why our lecture, we're going to be talking about oral care products, not because we want to prevent cavity, although that's a side effect of it. And so this is why. All right. Myth number 2, all oral bacteria are bad and should be killed. When I speak at conferences, it's a little bit easier because I can ask questions, but I just tell you what happens. When I ask this question, I'd say, who thinks we should kill all the microbes in the mouth on a daily basis? Nobody raises their hand. But yet, many of these dentists and hygienists, including my own team, including me in the past, we would give oral care products, mouthwashes, toothpaste that literally says on the bottle it kills 99% of the germs. Just like we wouldn't, it doesn't have to say amoxicillin on the bottle. If it kills all the microbes, it could be natural, it could be essential oils. Again, antibiotics have a place. If you have an acute bacterial infection, by all means, of course, that's what antibacterial is for, but not on an ongoing basis twice a day. Just like you wouldn't take antibiotics twice a day to stay healthy, you take it for a few days, you get all sorts of side effects. You should never take antibiotics or antimicrobials or antiseptics or antibacterial, whatever it's called, doesn't matter. If it's chemical or if it's herbal, doesn't matter. As long as it kills all the microbes indiscriminately, it's terrible. You should never put in your mouth of your kids, your patients. It'll be a disaster. Again, don't take my word for it. You can, I know you know this, but in the last maybe 6 months even, there's been 3 studies that link these oral over-the-counter mouthwashes that kill all the microbes indiscriminately to various things. Diabetes. The other one was increased hypertension and cardiovascular and heart attacks and strokes. For example, the reason behind that is your oral microbes, one of the many things they do is they help reduce food into these molecules called nitric oxide. Nitric oxide is helpful in vasodilation, and we don't have enough nitric oxide, then we get blood pressure and we get heart disease, or we get a clot in the blood, we get heart attacks, and in the brain we get a stroke. So that's just one. The other one was, it was linked to many types of cancer, including colon cancer. Again, as an example, when you kill all the microbes in the mouth, 99% of them, the 1% that thrive are the superbugs. So the mouth starts getting overpopulated by really harmful microbes now, called like FN is one of them. And FN specifically has been linked to 50% of colon cancer. So as you can see, just like if you had a garden, you don't just go and kill all the beautiful plants and flowers if you just have a few weeds. You take the weeds out, and you actually promote more, flowers, and to keep the weeds in check. So that's really how we've been dealing with our oral care. Just wipe them out, and it's been a disaster, unfortunately. Again, our oral microbes are essential to our health. We couldn't live without them. As you probably know, we have more microbes in and our body than we have human cells. And again, the numbers may vary between studies and the latest reports, but let's just say, about 30 trillion human cells, and we have about 100 trillion microbes either living in our mouth, gut, or our skin, elsewhere. And we can't survive without these. We've only been around, our species, Homo sapiens, maybe a couple 100,000 years, but these microbes have been around for billions of years, and they have a lot of genetic information, and they teach our immune system, and they do so many things, like we discussed just a few examples. And so we should really promote healthy microbes, and we shouldn't be killing them on a, twice a day basis. Again, just a quick summary of what the oral microbiome is it's the population of all the microbes in our mouths. It's bacteria, fungi, viruses, many other things. There are billions of microbes, somewhere around 5 to 100 billion microbes at any time, depending on factors like oral hygiene. There are about 1,000 species of these microbes. Again, some of the studies go back and forth on this. And so we really need to promote them, and different parts of the mouth have different types of species. So if we don't want to kill the microbes, what should we do? Well, one of the things that's happened in my life as I've gotten older is I've become a little bit more humble and I give more respect to nature. So when I was a little bit younger, I was a little bit cockier and a little bit more, I thought, I was a really good student at UCLA, then USC, then I was really, doing well as a business owner. And so I was starting to get a little cocky the first few years of my life. And so I thought I could circumvent nature and I feel like I could, outsmart the way nature has done it for millions and billions of years. But I've learned that over time that maybe I should be a little bit more humble and actually look at the way nature's evolved over the last, millions of years, and maybe learn from it before I try to shortcut it with my own tiny little brain. And so prebiotics is a perfect example. Why do I love prebiotics in your toothpaste and mouthwash and floss, and not antibiotics or even probiotics, which I'll discuss in a minute? Prebiotics are great because arguably the most perfect food ever created is breast milk. Now, this is not a breastfeeding or breast milk lecture. So obviously there are times that you can't breast milk. So I don't want to put those discussions, I want to put them away. But just as a general, I don't think there's anybody argues that for a baby, the best food. And by the way, before I had a baby, I didn't even know my wife had the baby. I didn't even know that breast milk is the only thing a baby consumes. I thought, well, sure, they're gonna have water. But no, that's the only thing. So it has every single nutrient a baby needs, at least for the first 6 months, maybe up to a year, even longer. So arguably it's the perfect food, and it's just the right nutrients for that baby. And so other than lactose and fats, the third most common ingredient in breast milk, you know what it is? It's prebiotics, a group of complex sugars called HMOs. And so nature from day one, and by the way, we knew that these HMOs were in breast milk, but scientists didn't know what it was. They were like, we don't understand that with this evolution, we have this prominent ingredient where the baby cannot consume it. We knew that it wasn't for the baby. The baby couldn't digest it. And then we realized not for the baby, it's for the microbes of the baby. So from the moment the baby is born, nature provides nutrients as the cells of the babies are growing, but also for the microbes that are sitting in the mouth and in the gut and everywhere else on the baby. So what do we learn from that? So that's what I love. I love to use prebiotics because prebiotics promote your own particular oral microbiome environment, which is different. Our oral microbe mix is like our fingerprints. They are varies between person and person. The only difference is fingerprints don't change as you get older, but your oral microbiome can get worse or better depending on what you do and what products you use, what you eat, how you take care of your oral health and physical health. So two of my favorite ingredients in oral care that are prebiotics is inulin. Inulin is like a fiber. It's a dietary fiber. These are, again, I like natural ingredients, but I like natural ones that are safe and effective. So this is one of those ingredients that I love. It also reduces bad breath because it reduces the microbes that cause bad breath, sulfur producing ones, and it promotes healthy microbes. That's the definition of a prebiotics, by the way, that feeds healthy microbes while it's selectively reducing the harmful ones. Like perfect. That's exactly what we want. There are another group of products called sugar alcohols, which I hate the name. Whoever came up with it had a terrible marketing background because it has no sugar, no alcohol. But xylitol and erythritol are two examples that I really, really like in oral care products. A little note, because this comes up all the time. Yes, xylitol is not good for dogs. Everything we talk about is for humans. Obviously, different species have different needs. The other one is xylitol does cause irritation in the stomach for like a 20% of population, including me, by the way. But that's only like in chewing gum or in cakes or anything that I eat a lot of it. Xylitol, the amount of xylitol, which by the way should be at 10% or more in oral care products for maximum efficacy and therapeutic effectiveness, has no effect, no detrimental effect on the stomach or any problem. So xylitol again needs to be at 10%, but because it's a fairly expensive ingredient, many manufacturers they try to cut down on it, and so you want to make sure that you keep them honest, and it should be at least 10%. There's hundreds of studies on xylitol, maybe less on erythritol. This study, this is the title of that study, if you guys want to look it up. It's a great study. It looked at over 200 xylitol studies and maybe a handful of erythritol ones, and he found out that xylitol has a prebiotic effect. It's not by FDA regulation, it's not categorized as a prebiotic, but it has a prebiotic effect. So I kind of lump it up with the prebiotics. What about probiotics? Yeah, I think probiotics have a good future, and maybe even today, if you do saliva testing, if there's a specific need that you require to provide live microbes. By the way, that's what probiotics are, live microbes that you introduce to our environment. But I don't like it as part of the oral care products that we use on it twice in toothpaste and mouthwash. And I don't see them in, which is good, because that's not where they belong. They're a very specialized product. And because again, my oral microbiome is different than my sons and my wife's and yours, everybody on the call today. So probiotics have we really studied and used in a very unique ways for individual needs and not in oral care products. So that's why I don't use them in oral care products, and you shouldn't on a daily basis, and you should use them when necessary. And you have to make sure you test it to make sure it's specific for that individual. Okay. Well, this is something that I hear all the time from patients. I tell them, why do you get cavities? Like, I don't brush my teeth enough, or I'm eating too much sugar. Or if it was that easy and that simple, cavities wouldn't be the #1 disease in the world. So it's not that simple. You can actually, in fact, have no sugar, don't eat any sugar and still have a mouthful of cavities. Okay, so let's talk about how we get cavities. Now, I know I'm probably preaching to the choir, and a lot of you may say, well, this guy, does he know I'm talking that he's talking to like dental professionals? Yeah, I know, but there are all these nuances. Sometimes we also forget, it's been so long from our dental school or hygiene school. So let me just kind of set this stage and then we'll get into more interesting things. So how do we get cavities? So our mouth saliva is usually about the pH of it, which is just a measurement of a solution. So just like we have Fahrenheit and Celsius for temperature, and we have yards and meters for lengths, we have a thing called pH for measuring the alkalinity or acidity of a solution. So it goes from 1 to 14, 1 being very acidic, 14 being very alkaline, pH 7 is neutral. Or saliva pH is neutral. In fact, if you can go to Amazon or anywhere and buy these strips, these pH strips. I'm trying to see if I have them here, but anyways, they're cheap, like $5 for like, I don't know, 100 of them probably. And you just dip it, you spit somewhere and you dip it, you can see if your saliva is. Every time we eat or drink, almost everything, our pH drops and becomes acidic. And once it passes 5.5 pH, some of the hydroxyapatite, which is a calcium phosphate mineral in a very unique structure called hydroxyapatite, which makes up 97% of enamel, almost all of the enamel, and 70% of dentin, almost all of dentin. That starts dissolving into that acidic environment. And by the way, this is why you should never brush your teeth after breakfast. This is, again, a question I always ask. I was just at Yankee dental conference in Boston, and I asked about, I don't know, 200 dentists and hygienists. I say, hey, who brushes their teeth here before breakfast and who does it after breakfast? And I think half of them got it wrong. The other half didn't know why they brushed their teeth before breakfast. They said because they want the clean mouth. But just, this is one of the reasons you should never brush your teeth after breakfast or right, because you have to wait 30 to 60 minutes for that acidity to adjust back into neutral. So what happens is it becomes acidic. The hydroxyapatite gets dissolved in the process we call demineralization. And then as soon as the pH reverses the saliva's pH, the minerals in the saliva called hydroxyapatite, again, it's a calcium phosphate. Think of it as calcium blocks. They start resorbing back into enamel called remineralization. So we have demineralization and remineralization. As long as there's a balance between demineralization and remineralization, we get no cavities. But if you eat a lot of food, if you do it too frequently, or if you do other things that I'm going to go right now, then we have more demineralization and remineralization, and voila, you get a cavity. So that's how cavities are formed. Okay, well, we don't need this part because you guys know. These are like just six examples of how we could get cavities. These are risk factors. One is diet. We all know about sugar, but of course, processed foods and acidic foods and all of those can lead to cavities. The other thing is not just what's in the food that's bad, but what's missing from the food is also critical. Of course, we know our teeth, that building blocks of them is calcium phosphate, right? These two ions bond together, form hydroxyapatite. For calcium to be absorbed in your teeth or bones, but let's focus on teeth, you need several vitamins. You need vitamin A, D, and K2. Almost all of us in the US, we have enough vitamin A. We shouldn't want to overtake it to get toxicity. But 90% of US population, I'm pretty sure that's the case for majority of the world, we're deficient, highly deficient in vitamin D and vitamin K2. Vitamin D because we live indoors, vitamin K2 because of the changes in the diet over the last few decades and century, with processed foods and the way our, for example, cows used to eat grass, real grass, and then they would turn K1 into K2, and then that's changed. Everything's changing, unfortunately. And so we don't have enough of it. So I recommend having vitamin D and K2 or called D3 when you put it in stuff in your toothpaste, mouthwash, and floss, or at least you take it as a supplement on a daily basis. You can test, make sure that you take the right amount. I take 5,000 units of vitamin D and a lot of vitamin K2, but I've done blood tests to know that's the right amount for me. I encourage you to do it, but obviously the US government has their own 600 units every day or 800. Anyway, so I would recommend at least the minimum, but highly recommend that, we individualize it, let them find out what's ideal for us individuals. pH balance, we talked about it, that it needs to be alkaline or in a neutral level. So the dry mouth, we know that's a cause because it reduces saliva and it promotes unhealthy microbes to grow. So it could be caused by medications or medical issues, stress, all of those, poor diet. medical conditions, hundreds maybe of medications and systemic conditions are linked to or poor oral health and cavities. Genetics, this is only 5%, which is, so don't let your patients say, this is my mom's fault, that's fault, everybody in my family has cavities and I got cavities. No, that's just 5%, 10% at max, and 90%, 95% of oral health, or poor oral health, or oral care, oral cavities, gum disease linked to environmental and habitual things, which is great because it means it's under our control. History of antibiotics. This is really interesting. When I was in dental school, I was taught that if you have a history of antibiotics, that's a high risk for cavities. And yet we give patients toothpaste and mouthwash that have antibiotics in them, which is really go figure. Okay, poor oral health, of course, the plaque starts accumulating. We get more aggressive, anaerobic microbes and all that stuff. You guys know we get gingivitis. If you don't fix gingivitis, it leads to periodontitis, etc. And of course, harmful products, oral care products. Again, not just fluoride or anti-fluoride, all the other stuff which we're going to discuss today. Okay, my wife forced me to put this one cavities in because she's a pediatric dentist. No, I'm just kidding. So baby teeth, we all know as dental professionals, baby teeth are just as important to babies as adult teeth are important to us. And they set the stage for oral development, for speech development, for chewing, for nutrition, for confidence. Permanent teeth follow the eruption of the baby teeth. The jaw development, all of these are linked, and therefore airway and the way the face looks, all of these are related to baby teeth development. So truly baby teeth are really, really important, so we should take care of them. Okay, I just talked about this. Okay, I know I have this slides for baby teeth on how to take care of your oral health. And I know, again, I apologize if you think I'm preaching to the choir, but I just want to go over what an ideal oral care routine looks like during the day. The only difference for kids is if you're under age 6, then you don't do mouthwash. And by the way, when I talk about mouthwash, we talk about healthy ones, safe and effective, which I'll discuss later. But so under age 6, there's no mouthwash because the kids haven't developed their swallowing reflexes. And then under age 2, 18 months, before the teeth start contacting each other, they typically don't use floss. So other than that, everything is the same. So I'm going to start with the 6 and above, 6 and under to 160 years old. Okay, so this is the routine that you're supposed to do, brush your teeth and take care of your oral care. In the morning, before breakfast, in the evening, before bedtime. So BB. Before breakfast, you want to start with an alkaline, safe, and effective mouthwash to loosen the plaque and raise the pH and get the mouth ready for the rest of the product. So you start with that. And then you do floss, again, with a safe and effective floss. I prefer regular floss, if not a flosser, if not a water flosser, in that order, because we can really remove more plaque and use a cleaner product. And I like a floss that has all of the toothpaste ingredients in it, at least, or most of it, because you get most of the cavities between teeth. So just like you wouldn't brush without toothpaste, what would you floss without it? So either have it in the floss or at least dip it in the floss. It's not exactly the same, but it's better than nothing. So you do mouthwash, then floss. Then you clean your tongue with a tongue cleaner. Again, it's really hard. I can't see anybody, so I can't ask you. But if you're going to take a few things away from this lecture, please, if you're not using a tongue cleaner, especially a tongue cleaner, don't just brush your teeth with a toothbrush. Remember, toothbrush was meant for teeth, which is the hardest, smoothest surface in the mouth. Your tongue is anything but. It's literally the opposite of teeth. It's got all these soft tissues, deep crevices, like a rug that you're just cleaning on the surface with a toothbrush. A tongue scraper is better because it gets deeper. But again, a tongue scraper covers the top part of the rug. It can't get into the deep crevices. I like to use a dual version, which is a tongue brush that goes into deep crevices of the tongue to cleanse out the tongue. Is, by the way, very, very gentle and clean. And then you use the scooper to scoop it out. So again, a tongue cleaner, and then you use a toothbrush, a safe and effective toothbrush we'll discuss later, and a really safe and effective toothpaste. And hopefully that has nanohydroxyapatite because that buffers the enamel against acidic attacks that will come during breakfast, which I'll go over with you in just a minute. So that's the morning routine. Mouthwash, floss, and or tongue scraper. By the way, the tongue cleaner, and the floss, you can do it either one or the other, morning or evening. So you don't have to do it twice. So I usually do flossing in the evening, do the tongue cleaning in the morning. That's my routine. So let's just say my routine is mouthwash, tongue cleaning, and then toothbrushing. And then I have my breakfast. And then after breakfast, I understand why people want to brush their teeth because they want to get the coffee breath out and everything else. But that's when a really great, safe, and effective mouth spray comes in handy. You put it in your pocket, in your purse, wherever you go. You spray it, raises the pH. Hopefully, it's packed with prebiotics. Again, no artificial ingredients or alcohol or anything like that. It's really meant to raise the pH and provides prebiotics and freshen the mouth. So those are the 3 key features of a mouth spray. In the evening, before bedtime, you do everything that I said in the morning, except the mouthwash goes last for the night, overnight protection. So you do, flossing, if you've done already the tongue cleaning, and then you do the brushing of your teeth, and then you spit it out. This is something, another thing, I see it all the time. Either people say, don't rinse your mouth with water, or don't do it, or spit it out, or don't. These have to do with ingredients. And remember, we're not just trying to protect cavities. We're trying to have an oral systemic health consideration here. So I do a light rinse with my toothpaste because I don't want to be swallowing, even though our toothpaste, for example, I mean, a lot of toothpaste does not make this a business thing. It's all, a lot of toothpaste are, they say safe to eat, but they still have tooth cleaners and all sorts of foams and all sorts of things. Why do I want to swallow? I use a little light water, but the mouthwash, that's the one that I leave on my teeth because it protects my teeth overnight. And it was meant to stay in the mouth. It wasn't meant to be rinsed out. The toothpaste, that's again, these people usually put, a big coverage over everything because they understand just sometimes, many times, they're just a little piece of it. And so when people ask me, Dr. Haas, is mouthwash good for you? I'm like, what do you mean? What mouthwash? It's like asking me, is food good for you? I don't know. What are the ingredients? Some mouthwashes are great, some are terrible. Should you rinse or spit your toothpaste? Well, I don't know what's in the toothpaste. It really depends on the ingredients, not just, there's no typical answer for this because it really all depends on what's in it. And also, do we want to protect just our mouth, or we want to also protect our systemic health? Okay, so that's the daily routine. Myth number 5, bleeding gums are normal. I know that you don't think that, but again, some of our patients think, again, if you're using a terrible floss and it snaps between your teeth once in a while and causes a little bleeding, that's one thing. But if it's happening all the time, it's actually a very, very dangerous sign and it should be ignored. Because initially we have gingivitis, as you all know, which is like just the first level of periodontal disease. There's no permanent damage, but we have swollen gum, bad breath, bleeding gums, etc. But if we don't fix it, this is why patients come and see us periodically, because if there is some gingivitis, we want to get in there early and prevent it from getting to a permanent damage and loss of tissues called periodontitis, which is permanent loss of, periodontium, which is the periodontal ligament and alveolar bone and gingival tissues, etc. This is actually one of my favorite slides. This is what makes me excited to do what I do, and I know makes you excited to do what you do. We're not just fixing cavities or cleaning teeth. We're making the life better. We're reducing risk of diseases. We're adding longevity. We're adding confidence to a patient. By the way, a few things I didn't discuss, oral health makes you, they've done studies that if you have straight teeth, 2 people, one with straight teeth, one with crooked teeth, with everything else the same, someone with straight teeth makes $250,000 more in their lifetime than the other one. So we make more money if we have better teeth. It's more, your teeth are more important than what school you went to when people are hiring you. For our love life, they've done studies. I think American ADA did a study that 94% of people say your smile is one of the most important things when they meet you for the first time, which always makes me wonder, what does the other 6% think? I would think this should be a 100% thing, but apparently only 94%. So it helps our love life, it helps our careers, it helps our longevity, our confidence. Like, again, this is such an important thing. But these are some statistics. People with gingivitis are 23 times more likely to die of any disease. Periodontitis are 40-60%. I always see these studies that come out on TV and newspaper about, eating healthy, not exercising and not drinking too much alcohol and not smoking and having a good body weight, but they always ignore oral health. And there was a Harvard study that these 5 things adds 12 to 14 years to your life, and oral health potentially adds 15 years or more. And so we should always remind our colleagues and the media about the importance of oral health and our patients and ourselves and our family members. Again, these are important statistics. Someone that doesn't brush their teeth at night has a high risk of 20 to 30% high risk of dying, never flossing. increases mortality by 30%. Never seeing a dentist or hygienist over the last year increases dying by 30 to 50%. These are like crazy numbers that is neglected by our society, unfortunately. Okay, all toothpaste and mouthwash is basically the same. This is the, again, if you think, or fluoride, I was at a conference and this gentleman, this doctor came to my booth and I said, hey, what toothpaste do you use? And I'll tell you the brand just because it's kind of funny. It's not a, he said Crest. I said, okay, why don't you use Colgate? And he said, because the Crest rep is a better looking rep. That was the only reason he was recommending this toothpaste, because of the looks of the rep versus what was in it. And so when people ask me, no, every toothpaste is not the same. Every mouthwash is not the same. It's all about the ingredients. But because we don't know what those ingredients are, we just emphasize on fluoride and non-fluoride. We miss out on the both. And I'm going to, again, go over all of these things. So let's not, again, our job here is really, hopefully we learn something. So when we go back, we learn it's about the ingredients and not just about the name on it. Natural, toothpaste, mouthwash, all that stuff. Okay, I'm not going to go through all these names, so don't worry. But I will give you a summary cheat sheet that you guys can take a screenshot, or I don't know, like maybe, I'm sure if you contact me, I'll just give it to you, or I'm sure aaosh will be happy to share it with you. So this is another thing. Natural toothpaste is better than conventional one. Again, I know a majority of the natural products, I know they're terrible because they took one thing that was effective, albeit potentially risky in certain situations, which is fluoride, and they put anything else that's non-fluoride, and then they call it natural. And then again, I think a lot of natural products are worse than the conventional ones. But again, it has nothing to do with being natural or conventional. Is what are the ingredients? And are they safe, truly safe? Are they effective? And I'll go over how you can determine those right now. Again, natural toothpaste many times use herbal antimicrobials. Like peppermint oil is a really interesting one, or tea tree oil, or these are just antimicrobials, and they indiscriminately kill the microbes. Again, if you have an acute infection is one thing, but not in oral care products routinely. Peppermint oil. So if you want to know something safe, from your toothpaste to mouthwash to your shampoo, there's an unbiased organization called EWG, Environmental Working Group. So you can go to ewg.org. It's a non-profit organization out of Europe, and they have a database. You put the ingredients, and they will rank it from 1 to 10, 1 being the safest, 10 being the most toxic. They don't sell anything, so they're completely unbiased, but they have access to thousands of studies, and they'll tell you the risk based on, hey, is this cancer risks? This is developmental risk, whatever the risks are. So fluoride is a 2 out of 10. SLS is a 2 out of 10. Those are the 2 ingredients that I always hear people say it's bad for you, SLS, I agree. Fluoride, again, has pros and cons, which we'll discuss. But peppermint is a 5 out of 10 already, peppermint oil, which many companies use to mint their flavors. Spearmint is a 1. So if you want to get mint, which I love it too, we're all addicted to mint as adults, make sure that we get spearmint, because that's a 1. It actually it's like, it doesn't have that bitter taste, that, burning taste that peppermint does. That's just an example. So ewg.org, there's an app. I think the app is called Healthy Living or something. Just download it and put the ingredients. Then over time, you become so knowledgeable, because it's really the 10, 15 ingredients that we always really need to know. But this is like a little bit of a short summary of everything. That's the page that I told you that I think is important that we all spend a little bit of time in it. Again, I've left out fluoride and hydroxyapatite for a later myth. But basically, on the oral microbiome, I would avoid any antimicrobials. So, of course, any antimicrobial ingredient. Triclosan is not available anymore. At least manufacturers don't do it, but it was relatively available. Alcohol, essential oils, these are all antimicrobials. And I wouldn't use it on a daily basis. Prebiotics is what you want to use, and I'll give you some example: inulin, xylitol, erythritol. Xylitol, another benefit is it's incredibly yummy taste-wise, so you can really, really get it. Patients love it. Again, a cheap version of it is sorbitol. It's only a cost reason why a manufacturer would use sorbitol versus xylitol. It's about 1/10 in the price. So I would avoid it because it can still be fermented by microbes and potentially lead to cavities. Saccharin, aspartame, etc. Foaming agents, again, see two versions. They're foaming people that they say, oh, any foaming is good, but they're terrible because SLS is just a 2. But DEA, which is another foaming agent, or propylene glycol, DEA is a 10 out of 10 toxicity. It's literally the most toxic thing in toothpaste or mouthwash. But they're also good foaming because a little foaming actually mechanically removes, plaque. And so I like foam. I like a little foam. I don't like too much foam because I can't even see what I'm doing. But Kyoha is a great one. SMCT is another really great foam. It's a 1 from safety. They're all natural. But everything I discussed, they're natural, but they're also safe, but also effective. Flavors, yes, let's avoid artificial flavors, colors. If you look at a mouthwash and it's fluorescent or glow in the dark, it's probably not the safest thing to put in your mouth. The typical mouthwash is fluorescent, artificial dyes, artificial colors, artificial ingredients, acidic, pH is less than 5.5, alcoholic, antimicrobial, everything I just told you, you shouldn't be putting in your mouth. The opposites, should be prebiotics, no artificial ingredients, it should be alkaline, et cetera, et cetera. pH balance, again, we talked about how critical pH balance is to our oral health. Since everything we do, many things we do reduces the pH, makes it acidic. And by the way, every number in pH is 10 times more that. So a 6 pH is 10 times acidic, more acidic than a 7. A 5 is 100 times more acidic than 7, and so on. The same thing on the other side. 8 is 10 times more alkaline than 7. 9 is 10 times more alkaline than 8, but 100 times more alkaline than 7, and so on. Our job is to get neutral pH. So anything that we eat is acidic, then let's have a few alkaline pH, not extreme ones, but enough that's healthy that we try to get that back to the pH or the neutral, where healthy microbes thrive. Toothbrush is commonly ignored in the oral care business when they're discussing about what's safe and effective. So I have a few slides on that coming up. Tongue cleaner, we just talked about it. Please make sure you keep your tongue clean using a specialized tool, not a toothbrush. Toothbrush is better than nothing, but the next one is a scraper is better than a toothbrush. And then the next one is a toothbrush, tongue brush with a scraper or a cleaner. That's the ideal way. Floss. This is probably another pet peeve that I have. I just had one of my physician friends, she's my own physician, but she's also my good friend, text me yesterday that she found that an article that in her world, she's a internist, that flossing adds like 28% in your life expectancy. I don't remember what the study was. She was like, oh, look, I saw this article online. It's a newest study to tell you how great floss is. And then I said, yeah, it's really unfortunate. It's great, but it's unfortunate that most of the population uses actually flosses that have toxic ingredients like PTFE, like Teflon is a brand name, but PTFE, forever chemicals, basically. Forever chemicals are in some of the most commonly used flosses on the market. I will not name the brand, but basically the number one floss on the market right now uses forever chemicals. Forever chemicals is a 10 out of 10 toxicity. And it's called forever chemical because it remains in the body, tissues, and in the environment forever. So people, again, they try to avoid these things, other things like fluoride. Again, the reason I keep bringing fluoride is because I want us as a profession to get out of our this whole fluoride debate and learn about other ingredients, because that's one ingredient and it blinds us to really study all the other ingredients. And so, and then they use PTFE in their floss and they don't even think about it. And so please make sure that our flosses are avoiding these ingredients. Even natural flosses that I see on the market have petroleum-based waxes, like microcrystalline wax, which I would say it should go against our definition of what natural is supposed to mean. Okay, so all these ingredients are great for flosses. I like beeswax for floss because I do like a little wax, but it's perfectly healthy and it doesn't have any chemicals in it. Okay, is antiseptic mouthwash is good for you? I think we kind of like explained this a little bit. And in addition to drying your mouth and actually making your mouth worse, there's been so many studies. Again, this is not me saying, again, mouthwash is not good for you or bad for you. Is what's in the mouthwash that's either good for you or bad for you. I love mouthwash. I use it, but I use a healthy mouthwash. But these terrible mouthwashes that have artificial ingredients, they're incredibly acidic. They have alcohol. They're antiseptic. It destroys your healthy oral microbes. You create a terrible environment, has terrible oral health and systemic health. And again, this is the title of the study if you want to Google it, but just Google it, or I mean, or take my word for it. But either way, please do something about it. By the way, this is not me. I found this article online, Dr. Steve Nelson, which I don't know. I meet one day because he's done a great job. He actually went to his pharmacy or grocery store and near his office, and he bought every mouthwash, and he did a pH test. And look, I don't know if you guys can see my mouse, but basically everything below 5.5 is bad, right? That's where all diseases happen. And all of these mouthwashes, including from this one, it's called Smart Mouth, Scope, Crest, Sonicare, Colgate, Crest, Listerine, Equate, Peroxol, Tom's, whatever, Betadine, all the way. The worst one is the one that's called Natural. So I kind of like that one because it just proves the point that, hey, just because it says natural doesn't mean it's good. Anyways, these are all like, in my definition, terrible because they cause all these havocs that we just told you. Okay. Bad breath, by the way, one of the reasons that people use mouthwash for, I wouldn't say that should be the reason, but then if your patients are having bad breath, check their tongue is one of the major sources, if not the number one source for bad breath. So make sure that you recommend tongue cleaner, or if you have any family members or friends who have bad breath, buy them a tongue spray or tongue cleaner for their birthday or anniversary. I think they'll be very, or their spouses, significant others or their patients will be very appreciative of that gift. Okay, everybody's favorite topic, fluoride. So that's why I kind of did all of that first, because I want to spend some decent amount of time on fluoride. We're probably going to spend 5, 7, 8 minutes on fluoride, and then we're going to wrap it up with the toothbrushes. So let's talk about fluoride. Fluoride is an FDA regulated drug. It's been around for decades. It's actually a natural ingredient, by the way. It's a natural ingredient prevalent in seafood and in water and in tea. And so it's a natural ingredient. It's been around. It's incredibly cheap. That's how it was discovered. And so, of course, a lot of the waters have fluoride. And let me talk about, again, I want to be very scientific, not pro-fluoride or anti-fluoride, which I am not, by the way. I'm neither for fluoride or anti-fluoride. It's just, I'm not like a fluoride Nazi one or another. Fluoride is just one ingredient, and I just want to be very factual about it, and I'm happy to take any questions afterwards. So fluoride, the way it works is this. Remember how we said how cavities are formed when pH drops to 5.5? Calcium phosphate minerals dissolve away from enamel into the biofilm or the saliva. In the presence of fluoride, fluoride bonds with hydroxyapatite, forms this mineral called fluorapatite, and gets that as soon as the pH raises, it gets deposited back in the teeth. Fluorapatite is actually 10 times stronger than hydroxyapatite. So it does make the teeth stronger. There's no controversy there. And that's why FDA and ADA love fluoride and they recommend it. The controversy, and the reason there's a lot of controversy, and there's probably going to be more of it with the new government, is that, and again, this is not my opinion, there's a FDA warning on every toothpaste and mouthwash that has fluoride, that first of all, keep it away from kids age 6, means if they eat too much of it, if they swallow too much of it, it can cause toxicity. Again, this is not a controversial thing, it's absolutely fact. FDA says it. I think, and if you swallow too much of it, you need to call the poison control center. Yes, fluoride at high levels, or when it's ingested at high levels, especially when you're young, it can lead to fluorosis, toxicity. It can cause, neurotoxicity, many other things. And so fluoride at high levels, especially when you're younger, could be very bad. And that's why the controversy is. So when do we want to use potentially fluoride? And what's the alternative? There's a great alternative, which I'll go in a minute, which we should all be using in all of our toothpaste, mouthwashes, and flosses, and then decide if we want to add fluoride or not. I don't use fluoride personally. My wife doesn't use it. My son doesn't, because we don't get a lot of cavities. We don't have a high risk. I would look at fluoride if you've done everything else, which I'm going to talk to you about. If you have hydroxyapatite, which I'm going to talk to you about it in oral care products, especially in nano, and it's the right concentration, and you're doing everything else, the patient's doing everything else, and they're older, maybe they just got braces, or they just getting a lot of cavities, they have amelogenesis imperfecta, whatever, then add the fluoride. Then the value of fluoride, the benefits of it outweighs the risks. Again, it's like any other drug. I'm not anti-antibiotics. I wouldn't take it normally, but if I'm dying, I have a bacterial infection, if I want to prevent some major, if I've had mouth surgery or whatever, then I do use sometimes, I would be open to using antibiotics or chlorhexidine or whatever for a very short amount of time, but I wouldn't be wanting to use it all the time. And it's the same thing with fluoride. Fluoride is a one ingredient out of dozens, if not hundreds of ingredients that we use. So if we scientifically look at it and we're not biased, we just say, and it's the only FDA approved drug right now that is for anti-cavities. That means manufacturers, and by the way, that doesn't mean it's the right thing. FDA is behind the times with many things. I'm just providing facts, which means manufacturers can only claim anti-cavity properties with fluoride. So if they have any other ingredient, which there's a great ingredient that I go over, which I love, but we can't claim that this prevents cavities, even though many other countries can claim that. So by the way, this is AAPD says if you're going to use fluoride for kids under age 3, use a rice size amount, and hopefully they can spit it out. And from 3 to 6 pea size, and then use whatever you want. Again, CDC says 40% of kids use too much fluoride toothpaste, so you need to monitor them as parents and teach them. If they're going to use fluoride, they should use a little bit amount of it. The younger they are, the less, hopefully they should use fluoride. The older they are, the less damage they're going to cause systemically, because, you know, the teeth have formed and their, you know, cells and everything else. Okay, if you want to have fluoride or hydroxyapatite, you need to have vitamin D and K2, and we talked about the importance of them. So you should have it in your toothpaste, or you should take it, or you should take it as a supplement, because fluoride has to still bond with calcium. And again, none of these is going to work if you don't have K2 and D. This is a study that showed that, and this is the title of it, by the way, if you want to look it up, that even the fluoride manufacturers ignore basic chemistry. They put this calcium, are there any calcium, but then we just talked about the fluoride bonds with hydroxyapatite, which is a calcium. So fluoride bonds with calcium. But hydroxyapatite is perfect because it forms fluorapatite. But if fluoride bonds with any other calcium, like calcium carbonate, like calcium phosphate, then it makes the fluoride not available. It makes the bioavailability of fluoride go away. In fact, this study showed that 5 out of the 6 most common fluoride toothpaste on the market, they don't even have enough fluoride in them, because they put these other calciums. That just tells you that because we as a profession have stayed outside of the oral care product world, we don't have education, we're not participating in it. Manufacturers do whatever they want and get away with it. So they don't even have the fluoride that they advertise that they have fluoride on it. What is the alternative to fluoride? It's not non-fluoride or fluoride free, it's hydroxyapatite. So please don't just say non-fluoride or fluoride free. It's either hydroxyapatite or fluoride. And then we have different versions of hydroxyapatite. We have different versions of fluoride. So hydroxyapatite is not only 97% of your teeth and enamel and 70% of your dentin, but actually was discovered and invented as an ingredient in toothpaste. It's a biomimetic version of the hydroxyapatite by our own country, NASA, like 30, 40, early 1970s, about like 50 years now. But it was then went to Japan, they bought the rights, and then over there it became their own gold standard. Then it's been used in Europe, in Canada, many other countries have already approved it as an anti-cavity, except US. Again, we're very advanced in many areas of science and space and computers, but when it comes to our health, it's a disaster. And this is one of those examples. So I love hydroxyapatite in oral care products as an alternative to fluoride. In fact, I think you should have it in every toothpaste and mouthwash and floss, with or without fluoride, because they work very differently, and I'll explain how they work. So even if you don't use fluoride, you should have hydroxyapatite. Even if you use fluoride, you should still have hydroxyapatite. Again, this has been around for decades. This is nothing new. It's just new to America. So there's all sorts of, talks and conferences when I go. I was like, hey, this has been around for 50 years. They've been studied to death for safety and efficacy. It's like crazy safe. It's crazy effective. But they show that all the major studies show it at a 10% concentration. So just again, this one item, especially the nano version of it, which I'll explain in a second, it's expensive. So nano version is 10%, 10 times more expensive than micro hydroxyapatite. So a lot of manufacturers they put a few percentage, small percentage, but all the studies show that it has to be at 10% for it to be effective as fluoride for remineralization. So these are the two types of hydroxyapatite. Micro, developed in the early 1970s, nano in the 80s. Again, they've both been around for decades, have proven over and over and over and over for safety. They've proven to be very effective. Micro is good, but it does more surface level remineralization because it's so big, it doesn't get into the deep crevices of enamel and dentin. Nano mimics a natural enamel, so it's incredible. You know, I joke around always that if I wasn't married to a pediatric dentist, I would marry nano hydroxyapatite because it's so incredibly effective. These are the 5 benefits of nano hydroxyapatite. It does deep remineralization of enamel. It naturally whitens the teeth because it kind of resurfaces the teeth and it reflects the light evenly. For the same reason, it reduces sensitivity because, you know, the hydrogen peroxide and carbon peroxide, those bleaches, they whiten the teeth, but they damage the teeth. They actually cause sensitivity. This one reduces sensitivity while naturally whitens. It's acidic resistance, which means when I have it in my toothpaste and mouthwash and floss before my breakfast, it actually protects my enamel with the coffee and juice and bread, whatever I'm having juice, you know, afterwards. Sorry. And then the last thing on the nano size, it's so small that it sticks to microbes. It reduces plaque as effectively as chlorhexidine with 0 toxicity. So you can even give it to little babies, pregnant women. And this is one of the studies. Again, this is wonderful because we've used all the hydroxyapatites things. So if you guys want to review it, please do. There are 2 mini rumors on the internet that I always need to talk about because people bring it up in conferences. One is glycerin coats teeth and prevents remineralization of hydroxyapatite. Just doesn't happen. Glycerin is water soluble. There's been almost all the studies with hydroxyapatite have been done with glycerin in the toothpaste, and it doesn't affect it. And the other one is nano hydroxyapatite particles are so small that it goes to the blood-brain barrier, which is again is completely false. It can't even go through the epithelial layer, let alone blood-brain barrier, which is very selective. Even if it gets into the blood, which it doesn't typically, if you swallow it, it just breaks into calcium and phosphate ions, get reabsorbed, or you just excrete it. So, and by the way, remember, hydroxyapatite is a natural thing found in our body. So this is, you know, we either have a natural or biomimetic version of it. So these are the 2 types of ingredients that just on the enamel, again, your oral care product should be more than just enamel protection. But if you want enamel protection, you have to have one or both of these things in your toothpaste and mouthwash and floss. Fluoride, my favorite fluoride. I don't like stannous fluoride because it's more dangerous and it actually has antimicrobial ingredients. It has many problems. The safest and most effective fluoride ingredient I like is sodium fluoride. Now, because this is an FDA regulated drug, every manufacturer uses the same amount, 0.24% for regular toothpaste and 1.1% for prescription. But because hydroxyapatite is not regulated, it's wild, wild west. So really the best version is 10% or more nano hydroxyapatite. We talked about all the benefits. And the last myth is the toothbrushes. Again, 3 reasons why you should, as dental professionals, really think about what toothbrush you use, what you recommend to your patients. One is safety. We talked about how CDC says 75% of the US population has dental sensitivity, and the leading cause is abrasive electric toothbrushes. Effectiveness, you know, the red circle, you can see that where we get the cavities, which is the interproximal spaces, or toothbrushes, typical, they can't even reach there, so they can't clean it. So you want to make sure that you have anatomy of toothbrushes that actually clean, and make sure you you clean your teeth, brush toothbrushes with UV sanitizers, not chemicals like mouthwashes, you know, because then you're going to put those chemicals back in your mouth. So I think we made it with just 1 minute over, and I'm happy to take any questions. Since I don't see it, if you can read it for me, I would love it, if we have any.
No, you are fine. You did not go over. You are just fine. You actually are right on time, and you did a fantastic job as usual. So we did have a question about hydroxyapatite or nano toothpaste, which I think you did a great job answering it. There is tons of research out there to support that they can remineralize enamel. I think that was pretty well answered in your presentation. So that one was pretty much taken care of. We did have somebody ask if you have a cheat sheet of products with forever chemicals or healthy products. So I know that you guys have a lot of cheat sheets out there about your products. So
yes, if you contact support@supermouth.com, anything you need from clinical studies to cheat sheets to, because we're really, one of the responsibilities that I'm taking as Tommy Haas and my company is taking is educating not just the public, but the profession, because no one else has done it. Our dental schools and hygiene schools haven't done it. Manufacturers haven't done it. So that's what we, almost at every dental conference, major dental conference, we're speaking, we're providing CE courses. So we're more than happy to provide any content. So if you guys want to email support@supermod.com, just put aaosh on the subject line. Whatever you guys need, they'll forward it to me or my team members. I will be happy to provide it.
Absolutely. So a question we had, do you ship to Canada?
We are, so we're soon. So by the way, I live in San Diego, but I actually have a place. My second home is in Vancouver. So I love Canada. And we are, by the end of March, about 2/3 of our products have been approved by Health Canada already. And some dentists couldn't wait, so they're already buying products from us. They're shipping it to a US address, and then they're shipping it to their own offices because we can't directly ship to Canada yet. But by the end of March, we're hoping to be there. I just hope these tariffs between US and Canada are not going to be crazy as going to prevent us from doing
Oh,
it.
no.
But we're so excited to be in Canada. That's going to be our first outside of the US market.
Great, great. So, what is the major difference in your toothbrush, Dr. Haas? I think it's kind of important because we've got about 7 minutes. I would like you to talk about the major difference in the head of your toothbrush because I've always been fascinated with this.
Thank you. So yeah, toothbrushes. Thanks so much for asking that question. The toothbrush bristles, like mentioned before, it's been around for over nearly a century. Like the modern toothbrush was invented in 1938 before World War II, and it's almost unchanged. But if you look at it, like a little rectangle or oval, whatever the shape is, it doesn't fit the anatomy of teeth, right? We have, again, 300 patents, so we are big on R&D because we really wanted to reinvent every product category from safety, efficacy, innovation, fun factor, how beautiful they are. So these bristles is the longest thing that it took us to fix. We literally went out and scanned thousands of adult teeth, baby teeth, and braces. And then we used computer work to cut these bristles. That's why they look so unique, because these bristles are usually bristles of toothbrushes, like little, tubes coming out of them. It was so difficult to actually make these bristles. We wanted to, first of all, be soft, super soft, but also follow the anatomy of the tooth structure and the gum. So they provide incredible efficacy with zero safety concerns, right? So our bristles naturally perfectly conform to the contours of teeth. So when you put it against the teeth, it looks like, it's hard to do it in a video, but I really encourage everybody. I mean, we do have manual versions of it, that people love. I had actually, I think I can use her name. One of the doctors, she's with aaosh, which she's one of our doctors at one of our affiliates. She was at one of our conferences. She came to my booth. This is when we had our manual version. She said, "What is this, Kami?" I said, "This is what, this is the bristles that we've invented." The manual ones, independent study shows that it cleans 30 times better than a typical toothbrush. And she touched it. She's like, "Kami, there's no way this is going to clean my teeth. It's so soft." I said, "Yeah, well, why don't you try it tonight?" She's like, "Okay." The next morning, she came to the booth again. She said, "Kami, I went and tried it. I've been a dentist. She's been a dentist for 30 years. She said it was such a polished teeth. She forced her husband to use her wet toothbrush, like her used toothbrush, to brush his teeth because she couldn't wait to get a second one from me the next day. So this is I'm really, really proud. And then we, of course, put it on the electric toothbrushes. It, has all these other features with UV sanitizer and dryer, and has a pressure sensor, and on and on and on.
Yeah, so I'm excited. I just bought 2 of them, so
Oh, that's
I'm
amazing.
excited. Yeah, I did. I used the aaosh 20 and saved some money, so that's always a
Thank
great
you.
day for me. So
That's
yeah, we
wonderful. That means a
just
lot.
bought
Really,
2
that's
of them.
amazing. I appreciate
Well,
it.
I felt it. I
Yeah.
actually got an opportunity to see it at Collaboration Cures this year, and had just, how life goes. We all get busy, and
Yeah,
had just
of
not been
course.
able to. So I had 5 minutes between, trying to dig through email and do this too, and just went ahead and did it. So my husband and
You're
I
so
both will
sweet.
have
By the way,
one. And
I really appreciate it. To that point, I have one of my own employees, and she's one of my directors, and she's so wonderful with me for like 15 years. She has cancer, unfortunately. She's going through some therapy. She's doing much better. And she told me that she called me 2 days ago. She said, "Hey, call me. I wanted to tell you something. During my cancer treatment, these toothbrushes saved my life. Before these toothbrushes, when I had regular toothbrushes, it was such an excruciating pain, and I couldn't clean my teeth effectively, et cetera, et cetera." So long story short, she's like, "Call me. Have you guys considered talking to oncologists?" I'm like, "Yeah, we actually has one of the reasons oncologists love our products, not only safety and efficacy, how clean the ingredients are, and how they produce saliva and they reverse pH and they provide prebiotics, to provide support for the enamel, et cetera, et cetera. But the fact that the bristles are so soft, but also effective to keep the teeth safe and the gums and healthy. So she feels like, she said she went from excruciating pain to now she looks forward to it because it feels like a massage for her teeth and her gums.
Well, we're taught, or from I'm in the Gen X generation. We were taught like you scrub your teeth like you're scrubbing pots and pans. You know what I mean? Like you got to scrub just as hard as you
Exactly.
can. And it's the hard toothbrush, medium and hard, and you get in there and just as hard as you can. So the old habits are hard to break. And I've gone to a very soft toothbrush, but you still find yourself wearing those toothbrushes out, and you shouldn't be doing that. You know what I mean? Like you shouldn't be, bristles shouldn't be peeling back on those brushes like
Yeah,
that, and it tells you you're brushing way too hard. So I'm
exactly.
excited to have it and to train myself with a little bit better habits. So
Yeah,
hopefully we'll get it to a much better way and a much better
100%.
system, yeah, of
That's been
brushing
my
our
experience
teeth.
too, that we have two groups of people today. Well, one group that ignores their oral health, and the
Hmm.
other extreme is the ones that they scrub, disinfect with antimicrobials, you know, sterilize their mouth. Instead of coming up with like some reasonable, logical middle ground, right? That we want to safely and effectively keep our teeth healthy and clean, but clean doesn't mean disinfecting it, and doesn't mean scrubbing the enamel off of our enamel and causing gum recession. But unfortunately, this is our culture, right? We go from one extreme to the next. But hopefully, people like you and me and our doctors and our hygienists, we can change the next generation so we grow up healthy, not only healthy mouth, but healthy bodies as a result.
We've been programmed to believe a lot of this stuff. We've been programmed. Media's helped program it. Advertising has helped program it to where we believe a lot of things that are just not true. And we've tried, we've had to learn over the years new ways to think. And toothbrushing is another one of those things that we've got to learn. And mouthwash and everything else, we've got to find a new way to think. Dr. Haas, thank you so much.
Thank you
You
very
are
much.
always welcome with aaosh. And I want to say, from the bottom of my heart, I truly do mean this. Thank you guys at Supermouth for your support of aaosh this year. You were one of those first ones too that jumped right on board and said, you wanted to be a partner with us for a year, and we are so grateful for it. We look forward to seeing you, and don't be a stranger before now, but before then, but don't, guys, they're gonna be with us at annual session. We are looking forward to it, but don't be a stranger. Please come around and see us, and we'll have you again soon. And we look forward to seeing you in some of our webinars later on throughout the year. But don't be a stranger. Come back and see us, and we appreciate everything. We really do. Will you
Thank
pop your screen up so that everybody can see the QR code real quick? I think that's the last. Well, maybe now it's okay. We'll put the link up if you and Danielle already did it for me, so that
Sounds good.
everybody can get credit
Of
for
course, yeah,
your
we want to make sure
course.
they get the
So.
credit. You want me to do, or you say
No,
someone?
it's all right.
Oh, by
It's
the way,
good. It's all good. Danielle took care of it.
perfect. And one last thing before I go, I wanted to say the feeling is mutual, and I'm not really, I truly mean it. aaosh, I think, is one of the most important organizations, and it's up to all of us to invite all colleagues and friends to join aaosh, because again, I know you didn't ask me to say this. I just say it because I love this organization, and I love the people and the doctors that attended, the hygienists, the team members. When when you go to a meeting, every meeting has like a little culture. This culture is so open-minded. They want to learn. They're not biased for or something. They're truly there to learn. They want the best for their patients. And I just love this culture, and I love to be part of it. And I really appreciate it. And it means a lot that you feel like we're adding some value. So I really appreciate you having me and my team, and would love to be participating in aaosh activities anytime, anywhere. Thank you.
Yeah, absolutely. We appreciate that. And I do have a lot of pride and a lot of faith in the fact that we try to take all sides of the argument,
That's
that
right.
it's not just a very one-sided
Exactly.
organization, or you can't believe one thing, or we don't welcome this. We welcome everyone.
That's
And we want
exactly right.
everyone
Which
to
is so
be here.
wonderful,
And yeah, we
right?
want
This is how
both
we all
sides.
learn.
We want all sides of the argument. But how
Exactly.
else are we going to learn? We have to have all
Exactly.
sides of the argument and hear what everyone has to say, so that we can formulate our own opinions based on what we learn and what we know. So thank you
Love it.
so much, Dr.
Thank
Haas.
you
We
very much.
appreciate you so
Likewise.
much. Thank you. Have a
Thank you.
great
Bye-bye.
day. I'm going to
Thank
go
you.
ahead and bring up Dr. Parul Makar. Dr. Makar, if you are, I think you're on here with us. So we'll go ahead and let Dr. Makar come on. Dr. Haas was great, and we're always so grateful guys, if you've never had Super Mouth, any of their products, I encourage you to give them a shot. They're incredible. If you've ever wanted a toothpaste that tastes like vanilla icing or strawberry icing or chocolate icing, they're the way to go. Hello, Dr. McCarr. How are you doing today?
I'm well, thank you.
Absolutely. Absolutely. If you want to go ahead and start your presentation, you can do so. And once you get that going, we'll jump through a few of those introductory slides and then I'll introduce you.
Okay, so I share the screen, right?
Yes, yes. And Danielle, I think Danielle will give you permission and then you'll be good to go if she hasn't already. I think she probably has. There we go. Yeah, now we're rocking and rolling.
Okay.
So
Let
let's
me-
see here.
I'm going to get into the slideshow here.
So I believe if you go down, kind of roll over your slide, you should see a part where you can, that's interesting. I wonder why it won't let her.
Open in.
Possibly the button all the way to the right that looks like a square, like four little, sorry,
That's
the other side. Maybe it's the left for you by the percentage. All the way one lower. See how it looks like it's like four
this
little
one here.
L's that make a square? Yeah, that might do it. Could be
Okay, and
wrong
I
though.
guess I'll just move the slides.
Yes, and you'll take care of your own slides. That's the so Dr. McCarr is presenting for us the unseen scars of cancer. And her presentation, guys, is one not to be missed, and that's why I'm so excited to have her here with us today. So if you want to advance to the next slide, Dr. McCarr, you can do so. Uh-oh, are we frozen? That may have froze her slides up. So
Yeah, I think it froze my slides. I'm trying to
so
move forward. Hold on.
maybe click that button again, and maybe that'll take you out of there. And
Huh.
let's see if it'll let you. Huh.
Let's try this again. I wonder if I can just do. It's asking me. Maybe I open it up as PowerPoint. Maybe that'll help. Oh,
That's okay. We're in no hurry because the next lead in is mine. So we're in no hurry. Please don't worry about that. We're absolutely fine. So no worries.
all right. Maybe
There
this.
you go. Great deal.
Now let's
So
see if we can get this to
yeah, now there we go. So
slideshow. Here we go.
yeah, hold on. I think it's loading up for you. There you go. Glenda, I see your message. Hold on just a second. Glenda, do you mean, and you can type this answer in the box, if the link didn't work, you mean to get the credit for CE? Alrighty. So, and Glenda, you can just answer us there in the chat. And okay, so that, um, hold on just a second. We'll take care of that for you, Glenda. Let me go ahead and get Dr. McCarr started. So this is Dr. McCarr's conflict of interest statement so that you guys can see that. So now if you'll move on to the next slide and the next one, because we've already covered some of these for everyone. Yep. And the next one and the next one and the next one and the next one. And this is Dr. McCarr's course description. And the next one. And her learning objectives.
Oops.
And the next one. Oh, that's okay. And the next one. That's perfectly fine. No worries. And I will go ahead and introduce you if you'll give me just a moment here, get my notes up. Today, I have the honor of introducing someone whose personal journey has led to a powerful mission, Dr. Parul McCarr. Dr. McCarr's life changed forever when she lost her younger brother to oral cancer. Like her, he was a dedicated dentist, and his passing ignited in her a deep commitment to educating both doctors and patients about the risk factors, prevention, early detection, and treatment of oral cancer. She has become a leading voice in oral health advocacy, sharing her knowledge through articles in dental and healthcare journals, public speaking engagements, and podcasts, both as a featured expert and host. To honor her brother's legacy, Dr. McCarr co-authored the posthumous book, Life Interrupted, Dr. Dawes' Survival Guide, a work that has not only touched lives, but also won the CIPA's Evie Award for Motivational Inspirational Books. Through this, she continues to spread his message of resilience, awareness, and hope. In addition to her advocacy, Dr. McCarr practices general dentistry in Long Island, New York, where she applies her expertise and passion to patient care. She speaks at conferences nationwide, helping others develop a greater understanding of oral care prevention and early detection. Dr. McCarr's story is one of heartbreak turned into purpose, and her work is making a life-saving impact. Please join me in welcoming the inspiring Dr. Parul McCarr.
You're too kind. Thank you so much, Violet. And I had the pleasure of meeting Liz recently last weekend. So I'm very
Oh,
glad.
awesome. Awesome. That's great.
Person.
So you are good to go. Thank you so much for being here with us today. We really do appreciate it.
Thank you so much. So thanks all for joining. This is dedicated to, this is my younger and only sibling, Dr. Manu Dua. He followed my footsteps into the field of dentistry. I'm almost 8 years older than him, so I remember changing his diapers and how he started from, you know, crawling to walking, eventually becoming my peer, and we would even take courses together in dentistry. And he died in March of 2021 in the midst of COVID. And it was such a unprecedented times with really no manual left. And I grew up, I call myself a modern day nomad because I've grown up in 5 different countries. And now currently I call New York home, but I do have family in Calgary, Alberta. Manu went to school at UBC, so I have a special, of course, soft spot for Canada. And he died, and I didn't have a village of grief protecting me, acting like a buffer. I didn't have the same people that I grew up with, knowing it's sharing stories. My parents had a collective loss of losing a child, but I lost a sibling, and losing a sibling is a very untalked about topic because it strips you of your identity and it changes your perspective, and things that you were promised in the future are taken away by no fault of your own. So it's a very, tough loss to navigate through and alone. So this image, Manu had a tongue lesion, it's a squamous cell carcinoma. That was a lesion that was diagnosed on the lateral border of his tongue. And part of my mission is him being a dentist. He was diagnosed late, and unfortunately, it had, by the time of diagnosis, had spread into his into the nodes of his neck, which he needed a tongue resection. Half his tongue was removed and grafted. It was an 8-hour surgery done in Calgary with a team of doctors. And my point in sharing all of this is that oral cancer is just not, an isolated dental thing. And this is why aaosh is, I feel so passionate about having a team approach. Manu had, he had plastic surgeons, vascular surgeons, oral surgeons. There's a huge team that enabled him to recover from the surgery. Unfortunately, the cancer returned and it came back with a vengeance in 2020, April, right in the midst of COVID, needing chemo, radiation, second surgery. So there's a bunch of treatments, and he was on immunotherapy as well. So part of my education is like, hey, this was a dentist who knew what this was, and yet it was missed because Manu was just turned 33 at the time of diagnosis, and the oral cancer has been on a rise, especially in the young with no existing conditions or any risk factors. Manu was a social drinker. He was not a smoker, and the only familial history, we did have pancreatic cancer in our family. Our paternal grandmother died of it many, many moons ago. But other than that, there was no other contributory factor. So he would never think that, hey, I'm in my 30s, I have a thriving practice, I just bought my new home. This was in his house that he had just recently bought in 2018. And he was high on life. And, at that time, he's like, I can't have cancer. Cancer doesn't hurt. This lesion hurts. And unfortunately, it's right. Cancer doesn't hurt as it starts off as an initial lesion, but as it grows bigger and bigger, and and it starts going into the deeper structures, it tends to be very painful, hard to eat, swallow, earache, and some of the other symptoms attached with it. Those are my parents in the back. And I will talk about my dad a little bit towards the end because I want you to have a deeper understanding of what cancer does to a family. So I had flown in the midst of COVID from New York without being vaccinated in December of 2020 as his cancer spread into his lung lining. It was deemed inoperable. He was on borrowed time. We didn't know how much time. And I think time is really our most precious commodity. We're just not ever guaranteed what we have, and we have to just make do and make peace with what we've given and be blessed with it. So I flew without being vaccinated from New York, which was the epicenter. Canada was shut down. Those who are in Canada know how strict the Canadian government was with needing PCR testing and the mandatory quarantine of 2 weeks. I went with a compassion release letter from the government that was signed off by Manu, my parents, the doctors, which I had to beg for because they were worried about what if I got COVID, and Manu was already, one step closer to death. And what if I got COVID? And we didn't know what that would entail. So it was a very, very tough, challenging time as a family to make decisions. But I flew. And on this topic that I'm going to talk about, I'm going to take you guys on his journey. And I'm going to talk about this book, Life Interrupted, that my brother wrote while he was battling cancer in his last days. He wrote it as a reflection of life, knowing that death was around the corner and tomorrow was not promised to him. And incorporating that with the book, we're going on a bear hunt. And this book is actually a Canadian book, and I feel very special. I have 2 young kids, and I used to read it to them because actually I'm from Calgary. So finding a bear while you are driving around, Banff National Park is quite very much a reality. And this is a picture of the bear that I once saw. And the premise about this book is it's a family of 5 who go on a bear hunt, and they're filled with this hope that, we're going to have a beautiful day and it's going to be a wonderful journey and we're going to find this bear. And they're all filled with hope. And some of these quotes are from the book Life Interrupted. And Manu was filled with hope, and he knew what his prognosis was. He knew what his doctors were telling him. But he kept the hope of surviving and kept the hope of fighting back. And he said that the secret is that we cannot go back and analyze whether what we hope for will play out in the manner we expect it to, but rather have to be rationally optimistic that in this current moment, what we hope for will occur in the near future and ignore the realities of whether that's feasible or not. And I think hope's such an essential part of our lives that we keep hoping and pushing and achieving for the best outcome. Whether or not it happens, sometimes it's out of our control. So this is the family of 5. The book opens up to, you'll see the other member, and so it's a beautiful day, and along the way to find the bear, they encounter challenges. And the thing about challenges, they find like this big river, and they find a forest, and it's messy going through the forest. They find a snowstorm, and it's messy going through the storm. That's the thing about challenges. We're going to face challenges, and they realize as a family that you cannot go over them. You cannot go under them. You have to go through them. And we'll face challenges. Our family faced this big challenge of Manu undergoing treatment for cancer. But in life, I'm a dentist, I'm in private practice. We have challenges, especially during COVID. We're going to go through it with our work family or home family or within our own self, some maybe an illness or some drawback. But we know we have to face our challenges head on. We cannot go over or under them, and we have to go through them. And going through them makes us stronger, wiser, smarter, hopefully. And yes, with COVID, we had a ton of challenges. And the thing about challenges sometimes is that we may feel very unlucky about them. It's life deals you a set of cards. You don't know what kind of cards you get dealt. And some people are lucky, perhaps with where they're born, which family they're born into. They have maybe more resources than others. And you don't get to say what cards life deals you with. It'll toss you another card and throw you out for a loop. But the idea is that you realize the strength of your cards and you know what table you're sitting at and what game you're playing. Because you may think somebody is lucky depending on, oh, you know what, they already have all the tools that they need. They didn't have to work as much, or they have the economic strengths, or they're tall, I'm short, like there's always challenges. And you may think somebody's lucky. But Manu said that what is luck? It's a paradigm that's blessed upon some and not the others, that it's a complicated subject, and how we look on it depends on our perspective of how much we've been given in. Manu always felt he was unlucky because of his diagnosis, his practice was broken into, he had a flood, all these sorts of things. So he had a very different prospect on luck. But the key is we realize the strength of our cards and realize that, you know what, it's okay to get up from the table we're sitting at and walk away and sit in another table where our strengths will play the stronger and we will come out the winning hand. Manu was dealt with this hand. He didn't think that he should go without a fight. And, in suit, I followed, like I lost Manu, but I knew that sharing his story and sharing what oral cancer is and bringing that awareness is maybe to change the narrative of what oral cancer should be treated as, seen as. And the thing about a lot of the challenges that we'll go through that we cannot escape and we have to go through them is that they're a lot of times out of our control. Sometimes these are things but given by other people, and a lot of times in practice too, how other people react. We only can control what we do. We are going to have things out of our control. And as dentists, I can speak only for us as dentists, that we are love control. I mean, we control what hours we work, what materials we use, what instruments we use, who we work with, what hours, whether we want to work weekends or not, whether we want to be a fee-for-service practice or see the teach or, innovate something. So, a lot of times there are going to be things out of our control and we love it. And so losing control, and I think with Manu, losing Manu was the biggest thing. I lost control of what a tomorrow would bring. I didn't know. I was scared of it. And COVID was out of our control. I couldn't travel freely, something that I had taken for granted, going from US to Canada. Who would have ever thought that the world would shut down? Never did, never in our lifetime did we experience something like that. And so, and there is a lot of guilt attached to a family member from that. For me, it was, did I fail as a sister, an older sister? It was my job to protect him. He was my kid brother. And did I fail as a daughter, not able to help my parents navigate? They're older and they're navigating, having to drop Manu in and out of the hospital. I'm not there to help with the treatments, to maybe make a meal, to clean up, to do groceries. Did I fail as a dentist because I didn't go get Manu, get the earlier biopsy? There was a survivor guilt. Did I have the same gene pool. Why him? Why not me? Am I passing these genes to my children and to my future generations? So there's a lot of guilt attached with a cancer diagnosis that a family can be going through. My mom does experience that. She's like, what did I do wrong then? What was it my fault that I couldn't save my son? And so, and how Manu felt about these challenges and about, these adversities and these things that were out of our control is that when you are faced with adverse circumstances that may be in your control, may not be, the best advice I can do is to breathe and take it one day at a time. And that really is true. There's so many things that we try to control. Oops, yeah. And here we go. And he realized that in all these turbulent times, it was to continue riding the wave day by day. The ability to focus and get through to each day is imperative when the whole world collapses around you. And it really did feel like everything was going to stop for us. And, think of control being like you're trying to hold on to these elements of trying to hold sand in your arms. And like if you try to hold sand really, really tightly, it's all going to fall apart. It doesn't hold in your arms. And I had to learn that I had to kind of like let go, open my arms, open my hands, but kind of hold myself together and hold on to the fragments of sand, the fragment of time, and whatever things that I could control. Going back to this family that was going on a bear hunt, they go through this bear hunt and they go through these challenges. They realize they cannot go over and under, that they have to go through them. And what were they looking to find? They were looking for this bear, and they do find this cave. And it's a dark cave, and they're scared, but they're like, you know what? We cannot go over or under this. We have to go through this. And that's the thing. We cannot be scared and face and turn away from fear. Fear can be quite paralyzing, and fear of what the test result will show. Has my cancer returned? How will it affect my family? What's the next step? What's the next treatment? There's always this fear of people who have lived with cancer that what if it comes back? The challenge is that we have to learn to accept our fears. We have to face them, or we're going to be stuck in the same position that it'll freeze us. And that's not an option. Depression, anxiety, at least for me, were not an option, and that I had to move forward. So this family decides to face their fears, and they go through the cave, and they find, I don't know if they were looking for this cute, cuddly bear that they could snuggle with, but oops, there we go. But unfortunately, what they do find is this ferocious bear that's got these claws and sharp teeth and looks pretty darn scary. And, they look at it and they say, you know what? This is not what they want. And they decide they're never going on this bear hunt again. And they all run and they go back into their house and they are like, you know what? We're never going to do a bear hunt again. And I think they were in this illusion of finding this cute, snuggly, wuggly bear. And sometimes in life, we're chasing an illusion. And really, when we find that illusion, is it truly what we're looking for? And whether it's your illusion of success is defined by having lots of money or a fancy car, a big house, or is it having a family? What is the illusion that we're always chasing after? And Manu was very much in that frame of chasing illusions. And he found out that perhaps the fastest and the most difficult ways was to step out of this illusion, was to endure a loss in life. And could be a loss of health, status, occupation, so on. And it's that systemic loss to your natural order of things that it strips, removes away the superficial layers of fluff of what is real and what is important. And I think this goes to anything. If you've had some sort of loss, not necessarily life, maybe you couldn't practice the profession you're in, perhaps, you couldn't get to the country you wanted to be in. Whenever there is this loss that's beyond our control, and despite all our mistakes, and we've learned and we've become better and we faced everything, and we find this illusion is not what we're wanting, it's okay to get up and chase after something else. We just get wiser, smarter, better at what we want in life. For me, how cancer really affected me was after I lost Manu through no fault, and couldn't put the blame on anyone. It's no one's fault. It happened. This was the card that life dealt us, and we had to face it as a family. I fell to the floor. I struggled to breathe. And it was that very act that my brother, he couldn't breathe because he had fluid buildup and he had cancer in his lung linings, and he had to have a chest port and drain all that fluid out so he could take a breath. But I struggled to breathe because I lost control. And like I'd mentioned, I lost a fear, I had this fear of what tomorrow is going to bring. I was scared and I was paralyzed. But I knew I had a lot relying on me. I had young kids. I had a dental practice. I had my parents. I had my husband. And I couldn't be on the floor struggling to breathe. And I knew I had to rise and do something. This was the card I was dealt with. I have to face it, and I have to make something better out of it. And I had to learn how to rise. And I had to learn how to surrender, how to not be controlling, as I talked about, like just trying to hold on to these grains of sand, of time, of Manu, of, holding his ashes and letting him go. You really had to refocus and kind of reprogram your thinking. And Manu, who knew, he was very, very scared of what tomorrow would bring. He would keep all his fears to himself. He wouldn't share it with us. But he said to live with the strength that is not only impossible, but quite tangible if we simply let go of fears that will not serve us in any purpose in this life or the next. And really, so did, Charles Darwin. He said that it's not the strongest or the most intelligent that survives, it's the most that's adaptable to change. We as human beings, we're constantly evolving and changing. We change to how things change. Technology has been a big factor of our life. It's a big factor of dentistry. It's a big factor of our kids' lives. And we slowly evolve and we learn and we grow. And that's the whole thing. That we learn how to adapt into whatever our challenges are, whatever our situations are, be it good or bad, and we figure out the resources to help us move forward. And you can't think of always what's the worst that's going to happen, because when it does happen, you understand what it is to be truly free. If you fear everything, the worst that's going to happen, and it does. And for us, for my parents to lose a child, their only son, was quite devastating. And unfortunately, they didn't understand the meaning to be free. They were very much, my dad especially was very much in the grief process, and he never quite got out of it. But realizing to be free and to surrender, perhaps to the universe or divinity, however you want to choose to say it, is when life is not over. It truly is when it begins. So this family that, decided we're never going to go on this bear hunt, and it's scary, and it's, this is not what they wanted. This is not what they hoped for. And this illusion that they were chasing after wasn't there. The key was, while they went for their bear hunt on this beautiful day, and while they faced their challenges and they couldn't go over or under it, and while they went and they discovered that that's not what they wanted, and they became smarter and wiser, and they learned from their mistake, and they decided they're not going to keep making the same mistake again, because the key to failure is not an issue. To fail is okay, and it's human to err. But the key is that we don't make our same mistakes over and over again, and we learn from them and we become better versions of ourselves. So they decided they're not going to go bear hunting again, but they always stayed together as a family, and that was their support system, together, while they face life's challenges. And you have to realize where you find your support system from, whether it is your family, whether it's your friends, it's a doctor, it's a support group, whether it's exercise, how you find your zen, how you find your support to hold yourself together so you're not falling apart, whether it's God. For me, and I'll share the story with those who are aurora hunters, who I love the Northern Lights, and I've been chasing after them for 25 years. I've been visiting Calgary, lived in Calgary. I've never to have seen them, and I've gone as far as Iceland in search of these aurora borealis. And when Manu died, a week after his death, I grabbed my mother, and, sleep was a stranger to us. And, I said, Mom, the conditions are just right. I follow all the, you're tracking the solar winds, you're tracking the weather, the clouds are not there, it's a clear night. I'm like, let's go out and let's look for them. And so I dragged her in the wee hours of Calgary. It's cold, it's March, and we go past the city lights. And as we go past the city lights, I see these clouds, and they look like they're dancing. And see, the borealis will appear white to the naked eye, but you'll see these beautiful hues, and they'll appear on camera. So I start, taking pictures. I'm like, sure enough, this was the borealis. And in the Canadian culture, it is said that the Northern Lights are the old souls that are coming to Earth to take in the new souls. And that's a moment to celebrate and to rejoice. And if you listen ever so carefully, they sing to you. It was the day that we were cremating Manu. It was the morning off, and it was the day we were going to return Manu into the elements of earth, wind, fire, water, and his soul to another journey. And it was kind of the universe telling me that it was going to be okay, that it's okay to surrender, it's okay to let go, that he would be taken care of, and so would I. And that's the thing. Manu's gone, and people will come and go in your life. But you will never forget how you made them feel. And so, no matter the circumstances, no matter how challenging the times you don't know the battles the other people are finding. And just to spread a little kindness, a little joy in someone's life can go a long way. Manu knew, because knowing that his mortality was pretty defined at this point, we don't know what tomorrow will bring. It's not promised to any one of us. But Manu knew his tomorrow was definitely not promised to him. And he knew that we're all mortal beings. We certainly are. But the key to survival is to leave something positive for the world to remember you by. And he'd say that our lives will come and go, but our ideas will remain immortal. So the essence, the soul of our work will remain eternal. So seek not to fear your own mortality, but to embrace the challenge to create something that will outlive you and your fears and your wildest imaginations. Really, leave something positive for the world to remember you with, no matter your challenge, no matter your difficult situation. So, Manu's gone. He wrote these books, and like a typical younger brother, he left everything for me to do. He's like, "Here's the manuscript. I'd love to be published, but unfortunately, time wasn't on his side." And I wrote the epilogue, and I put it together to the book called Life Interrupted. And the reason for this title was because when I lost Manu and I entered his house, everything was the same. He had gone into the emergency room on a Friday, and it was very common knowledge for him to be going to the hospital for some reason or the other. And unfortunately, he moved into hospice the very next day. I was seeing patients. I couldn't leave work. I still needed the 3-day PCR testing. I'm struggling to get it. And on a Sunday, March 14th, I was on a video call just like you and I are at this point. And while his body was shutting down, he was on a morphine drip. And I'm trying to get this expedited within hours. On the Canadian consulate, they're like, no, a rapid test won't work. You need a PCR. And so while it is really an unprecedented, there was nowhere I could turn to get for guidance. And I told him, "Manu, you need to let go. It's okay. Don't wait for me." His bodies were shutting down, organ was shutting down. And he said, "I love you and I'll see you as soon as I can, but don't wait for me." And within hours of that conversation, he passed away. And I always say Manu bore these scars. He had surgery scars, he had a trach, he had a neck dissection, he had grafts on his arms, so he had scars from that. He had radiation burns, scar tissue. And if any of your family members, you yourself, have gone through cancer treatment, you are pretty familiar with all of these or some of these symptoms. Radiation dermatitis. He had a port placed in. He had definitely a lymphedema in a lot of places. But here are some things that people don't see and they don't talk about is the emotional and the psychological, that being scared of the test result, being scared of another thing that needs to be done. Your mind changes. You get there's fogginess. One of the reasons Manu quit dentistry after his second surgery was because he just couldn't concentrate. He's like, "I'm having numbness in my left arm where the graft was taken for, and I cannot concentrate. I get foggy because of chemoradiation." There's a lot of social isolation, especially in oral cancer patients. They had a neck, if they've had parts of their face missing, if they have a feeding tube, they've got their teeth missing. They don't want to be out in public. They don't want to be stared at. They may not be able to enjoy a meal out with family. It's just hard. And so they have 90% of depression and suicide rates, things that we don't often talk about. And it changes your perception of what you look like, and you don't look like yourself again. You don't feel good about yourself, and you may find yourself ugly. There's a lot of fatigue, and of course that fear, and financial. It's very expensive getting cancer treatment. Insurances may or may not cover it. One of our big things was I wanted money to be here in New York to get treatment done. However, the the cost of getting something private was so expensive in US that he was getting everything done in Canada at, social medicine. So it's a little different. It was much economically possible to do it there. But some of these families have a huge financial stress on the entire family. So how can you offer support? I mean, cancer, loss of death, any type of grieving, some losses are widely accepted, some are not. And, especially death, I feel like death is not as accepted. Like when you give birth, you get maternity leave. Do we really get any grievance leave? What I wanted to share about my dad was my dad went through depression and he went through psychological delusion. He was on medication right after Manu's death. We had cumulative other deaths as well. My mom lost both her parents and Manu within the year. And my dad had seen his only parent, his mother, die of pancreatic cancer, and he was the only child. And his dad died when he was very young. So watching his only parent die of cancer, then watching his son, and then losing my mom's parents was quite very traumatic for him. And he went through 3 years of in and out of depression clinically, would not get the help. And I think the part of it is being there for your loved one, to be there and listen and support them. It's hard to get somebody to get the care, to get the treatment, but being there for them and showing up. I would hate sentences like, God intended it this way, was meant to be this way. That doesn't help. But just saying that I can imagine, I can't even imagine what you're going through, but I'm here to talk about your loved one. I'm here to talk about your cancer. How can I show up for support? And what can I do to make your life a little bit easier, whether it's with shopping, cooking, anything. And maybe have meal trays or take the kids out out of their hair for a little bit so they can just be in their thoughts. And my dad didn't have any of that. And like I said, we never had this village of grief protecting us. And my dad went to India for a family wedding. He returned on the American Thanksgiving, this past Thanksgiving on a Thursday. And Friday, I get a call, and very similar. It was like deja vu all over. Like I knew for my brother, I was planning a funeral because he had died. But I get a call from my mom on a Friday as soon as I finish work. She was like, "We're a little busy. We're in the hospital. Your dad had a cardiac arrest 4 times. His heart stopped beating, and they had to revive him." And, long story short, he was on a ventilator on a Friday night after returning from this trip. And I spoke with the doctors. I got a hold of the hospitalist. And they told me that this man who never had any heart issues, had never had a single clot, has no blockages, nothing. The doctors could not give me an answer. They said his heart just stopped. He had a cardiac arrest. We don't know why he had a cardiac arrest, but he's on a ventilator. We're giving you 24 to 72 hours. So if you can, make it on a plane. And I did. They held his body for me, and I got there on a Saturday. And we collectively, my mom and I said, it's okay, we need to let go of him. He really just wanted to be with my brother. He died of a broken heart. And the depression and anxiety these are things we don't normally openly talk about. It could be as a person, we don't talk about it. It could be a community, it could be anything. But my dad he didn't open up, and depression really took him away. When Manu had passed, he had told us as his speech on Manu's remembrance of life, he said, I loved my kids equally, but I never wanted Manu to be alone and be without a dad because I never had a dad growing up. And his love for Manu was so strong that his heart pretty much gave up. So I lost him and cremated him this past December. So being there for your family in some ways, wish we could do more. Sometimes it's hard to push somebody, especially an adult, to go there and get them the resources, but find out like how you can help with cancer, and to reminding them that there is a lot of people that rely on that person. I still need my dad. I still wish he was around, and I wish he would have understood that he still had kids and grandkids that relied on him. But it's that constant reminder that they matter, that the people around them matter, and they need to be around for them, and to really be kind and patient with them, because dealing with depression, dealing with anxiety, these are it can be pretty paralyzing, as I said, and revalidating and encouraging, like, yes, you're valued. Yes, your feelings matter. Yes, you matter. And you need to take care of you, and I'm there along the ride with you. And if possible, financially, this could be very hard for a family. So we talked about the emotional distress. There is a lot of caregiver burnout. It's very tough to take care of a person who's sick. And I'm sure from your own experiences, if you've had a aging parent or a child or anybody who's had, chronic illness, it's exhausting. It's a lot of work, and you sometimes just want to walk away from everything. And it's valid to feel that way. And when you do feel that way, it's okay to walk away and to acknowledge your feelings and say, it's okay, I will take care of me and then I'll come back, because you cannot pour anything if you're empty in the inside. As I live in New York, my husband's family's here and they have all these celebrations, and I would go and I would tell my husband, I'm going to walk away. I'm going to take an hour out of the celebration to really refocus on me, because I cannot be in this space. Recognizing that um, you don't have to always say yes to everything, that no is an answer. And it's a full sentence. When you don't feel like showing up because you genuinely are not in that space, it's okay to say no. It's okay to walk away from situations, to not feel that burnout, to regroup and refocus and come back so that you can serve and you can be there for them. It changes your family dynamics. I mean, I became um, from a daughter to almost parenting my parents. It happens more so in, younger kids maybe playing the roles of taking care of their parents or an older sibling. Role reversals happen all the time when you lose a family member or when there is a chronic illness within the family. There's always that fear of like, oh my God, what happens when this happened? That fear of the worst. And I've touched upon the survival guilt. That is real. It's survival guilt can come in all sorts of forms, and parents will feel it, especially after losing a child, because it's just not the natural order of things. That's not how life is supposed to go. No parent shall have to cremate or bury their child. It's just not right. And so there's a ton of survival guilt. And so my mom has that. She's like, I lost my son, and then within a few years, I couldn't save my husband from depression. I lost him too. So there's a lot of guilt attached to it. Learn to say that it's okay not to be okay. It's okay to not pretend that you are a fighter and you are strong at all times, because we really are not. And to really, find that thing that can take you away from all of the anxiety and all of that troubleshooting, and whether, the support group, what is it? Whether it's your therapy, whether you have to take medicine, whether you have to go run a bike, for a few miles and come back, it's okay to walk away for a little bit. And, grief comes in many, many, many different forms. There is the anticipatory grief. That grief is more like, it's going to happen. It's coming. You just don't know when. We had that with Manu. I knew, the more reports were coming, we were all mentally like, yes, we have to be ready the day it happens. And that's grieving too. Like every day, you just don't know what tomorrow's going to bring. You have to learn to accept the loss. Sometimes it's like that delayed grief, that your body goes into, I felt at least, that it's in this autopilot. Like, I just have to do the things, like with my dad, he passed away quite suddenly. I had to take a week off work. I had to go back to seeing my patients. And I was an autopilot. I'm like, I need to plan the funeral in the same funeral home as my brother's, the same crematorium, the same priest, everything has to be. And I'm just checking off the boxes. Okay, obituary done, eulogy done, casket picked, you're just in this, I've done this, the body knows, like, trauma. Body accepts trauma. It's inside somewhere, it's storing it. And whether we take it out in some form, either we release it with meditation, with counseling, with therapy, and all of those resources. Otherwise, it can harness as an illness, like it did for my dad. And so acknowledging that, and that delayed grief, it comes back. It'll hit me at the least times I expected, like, oh my God, what has the mind processes a little bit later what the body has endured. Like, oh, I just did this. And it hits you a little bit later. So that's the delayed grief. There's the complicated grief, because you have all these emotions that, combined with guilt, combined with other sorts of grieving losses of the could haves, the should haves, the what ifs, the what could have I done differently. The thing is that we cannot hope for a better yesterday. I cannot bring my family members back. That's never going to happen. And to accept that loss and hope for a better tomorrow, then hope that by sharing my story, by sharing bringing the awareness for oral cancer, by sharing, making grieving, normalizing it, and accepting it, being there for other people who are going through this process, will help somebody else. And that's what I could change, but I can't change what tomorrow is going to be like. The disenfranchised grief is like, this is when I say, like, when others will say, like, oh, he's in a better place now, he's done suffering, you know. Perhaps these are patients who have dementia, who are there, but they're just physically there and they're not mentally there. And you're like, oh, it was better off if they were gone. No, it's not. And nothing is better. There is just no right or, answer to tell somebody when they're grieving. It's just, don't minimize somebody's grief. You just don't know. Even with siblings, Manu was my only sibling, but just like a child losing parents, they will have a different relationship compared to their siblings. Different siblings have different relationships with each other. Your relationship with the person who's passed is different. So how you mourn, how you grieve is very different, and you're entitled to what you have, and how you're feeling. Cumulative grief is when there is a bunch of griefs that are joined together. So, the losing of so much more than just, so I'm sorry, ignore my Alexa there. So cumulative grief is like having a bunch of griefs all together, like we did as a family. We lost many family members as together at the same time. Masked grief is what my dad had, where he did not acknowledge and send it out, and it eventually took over as a form of disease. The negative behavior grief is when, you're just acting like not yourself anymore. You are talking from a place maybe of anger or resentment, and you're not validating those feelings, and you're acting just rash. It could be spending out of control, or it could be doing actions that are not, quite logical. So that's your negative behavior. The distorted grief, that is more like, you have this mixed emotions that you just don't know where to place your grief, because you're dealing with a mixed bag of emotions all at the same time. And you don't know how to, like, put this into perspective, like, okay, I need to deal with this emotion first and then the second, because you may be angry at why is their life, that factor of luck. Oh, that person's so lucky, they have everything, they didn't even have to work hard for it. Oh, they have the whole family surrounded with it and I didn't. So that's the distorted. The exaggerated grief is when you're like, it just kind of becomes worse and worse, and over time you may have these grief outbursts. It will just hit you at some time. You may have these constant nightmares, that you have just worked it up so much in your head that your whole world has just stopped. But, life does have a way of beautifully moving forward. I've done the work to realize that. And I'll share how I feel that way is Manu had bought a Porsche when he found out that he had cancer. So after his treatment in the summer of 2020, he bought a Porsche and he loved riding in it. I would tell him all the time, Manu, I want a ride. I need you to pick me up on the Porsche. You have to get better. And unfortunately, in December, when I went to see him, he could barely walk. He was a shell of a person that he used to be. And I'm like, let me take you out on that Porsche. He's like, no, the cold air, everything is just, it hurts and I can't. He passed and he left his Porsche to his best friend. So some best friend that was. But you know what? I finally did get to take a drive down that Porsche. Manu bought a dog named Maya. Maya means illusion. And at the time of Manu's, when he was brought into the hospital, and my parents didn't know what to do with the dog. They're like, who's going to take care of it? I'm trying to just struggle to make across the border. Who's going to take care of this dog as Manu's moved from palliative to hospice, and then eventually his death. His palliative nurse, who used to come every day to change sports, took her in and she adopted Maya. She's now named Piper. And to this day, every summer when I go to visit Calgary, Piper comes visits the family and she will come. And we feel an attachment to Manu. And so life does have a beautiful way of moving forward. When Manu passed, I wanted the world to just stop for a second so I could process the reality of what was happening. Like, I didn't understand, like, what do you mean he's gone? What do you mean? Like there's that denial and that, the traditional stages of grief. But for me, it was just like, why is this? There's that anger. Why is the sun shining? Why is the newscaster? Why are there comedy shows? Why are the birds chirping? Don't you know? I lost my kid brother. And, eventually you realize that you learn to live with the grief. It's just a burden that you're going to have to carry. And some days it's heavier and some days it's lighter. Some days people come and they support you and help lift it up. When I lost my dad, they were Manu's friends and colleagues who showed up at the funeral 3 years after Manu's death, where I stood on the same podium saying a eulogy for my brother and now for my dad. And they showed up. And it's those people who are there for you after the tears have dried and after the flowers have wilted and after the ashes have cooled, after all of that, those people who showed up in your life, those are the people that matter. And those are the people that you should be there for, who are there in your hardest and the most difficult times. It's easy to show up on people's joys. It's harder to show up when they're in their sorrows and to lift them out of it. So I think I was down to what is an absent grief. Absent grief is when you are just not accepting the reality and you're just not acknowledging. You have to go through the emotions. You have to process through it. These 5 stages of grief, the bargain, the denial, the acceptance, they are all it's not a linear process. You could be stuck in one and you can go back and forth. And that's the importance part of grieving and the importance part, things that we don't talk about. We will go through this at any point in our life. There is no handbook to this. You're going to go through these emotions and it's not a linear process. And know that sometimes you're going to fall back, but remember that you can pull through this. You cannot be stuck in that state. It's like if you have a flat tire, right? And you're driving and you get stuck with a flat tire, you have options. You have 3 options. One is you can stay stuck there and you're not going anywhere. And you're just going to sit and brood over it and be like, woe is me, life sucks, what poor luck I had, I got stuck with this flat tire on this beautiful road and everybody's passing me by, but I'm stuck because I have a flat tire. You can choose to be in that state. That doesn't help anybody, definitely not you. People who are waiting for you to come through are still waiting, so they want you to come through. You need to push through. The other option is you fix it yourself. You learn how to address the problem and you fix that tire by yourself and you do it. I had to learn how to pick up myself and be like, that's not an option. I can't be stuck here. I have to take care of me because all these people are relying on me. And 3, you ask for help. You call up your mom, dad, your brother, AAA, whoever. Call somebody to come fix that tire for you. Okay, ask for help. And it doesn't diminish you as a person to ask. It's okay to ask when you are down and you're stuck. It's okay to ask for help. So not to be in that absent mind, like, no, I'm going to deny everything and I'm just going to ignore it. It's not going to go away. You have to go through these emotions. The existential grief is when you have the sense of like alienation, nobody understands this. This is the worst thing that has ever happened to anybody on this planet Earth. And that's not true. People go through a lot of tough situations and tough circumstances, and we just need to find our people that truly understand where we're coming from, what space we're in. So we need to understand that. You may have this loss in hope or loss in God or divinity or just this existential loss in humanity even, but slowly working through it, accepting it and moving forward. It never goes away. Grief will never, ever go away. It's a part of your life. It's the scar that you will have for eternity. You just learn how to accept it, realize that it's there, and acknowledge it, treasure it, because there was a beautiful reason why you had the scar in the first place, and honor it. So there are also secondary losses, with grief, like perhaps somebody who loses their life partner of 30, 40 years. There is, companionship loss. There is a loss of perhaps an income or things that could have, should have, would have. Losing my brother, I had to know that, I'll never be an aunt again. My kids will never have cousins from my side of the family. These are attached losses that I have. These are secondary losses to losing my brother. There's a lot that comes in. And when I like I planned my dad's funeral, Manu wasn't there to share the little stories about my dad and the nuances. And, it was a process I lost my dad and I had nobody else to experience that loss with because Manu wasn't there. And then there is the transformational grief, which kind of like changes your perspective of like, this had to happen for something more monumental to happen. Like you had to go through this. You can take this any way or form you want, perhaps I can apply it to myself. Had I not lost Manu, I would be pretty content and in my little world of doing dentistry and not speaking on platforms and sharing this journey. Because I lost Manu, am I able to stand on this stage and share him with the world? This would not been my path had Manu never had cancer. So I got to where I am because I lost Manu, and that's your transformational grief. So time is, to me, the most precious commodity we have. We cannot replace, return, exchange it. We can't refund it. It is what we have. We try and aim to do the best we can for the people that, spend it with the people that we love, doing the things that we love, and really treasure it, because we just don't know how much time we're given on this earth. Some of the end of life decisions you may have to think of: wills, of course, life insurance policies. If you ever have your end of life wishes, make them known, because you may want, I have certain wishes that I want my kids to do with my ashes that hopefully will bond them as siblings. Make lots of videos and memory books, things you'd love to hear their voice again. If I lost my dad early and my kids are young, I would love to have had more time on video so they know what that person sounded like, that essence of who was who in their own words, rather than stories that are passed down. Any letters, memory boxes, a way to honor their life, whether it is for me, it was the book, and it was a joint collaboration of the work my brother and I did. But it could be, planting trees. It could be putting a bench where people can enjoy beautiful scenery. It could be volunteer work. It could be charity. It could be nonprofit, whatever in a way that you choose. It doesn't have to be something magnanimous, that has to be larger than life, but just any way that you honor remember them on their special days and their birthdays and their anniversaries, cherish them, set up, like I said, set up foundations or something in their memory that could help. Your legacy is in every life that you touch. So, and in every life that you don't touch, you don't know what kind of ripple effect that you create as you leave your legacy. Your legacy comes from having a purpose. Going through life and creating a purpose will create a legacy for you and others to leave you by. And so I want you to live with strength, to live with integrity, to live with passion, to leave something positive for the world to remember you by. So there is so much good you can do in the world. Let not cancer, let nothing deter you from your path, that there is still light at the end of the tunnel. Life does move on beautifully, and we're here for a short amount of time. Live it beautifully. Thank you.
I am touched. It is absolutely beautiful. I gotta tell you, I have lost family very, very recently, and that was absolutely beautiful. So pardon me, you all. I am still trying to process a lot of this. So I'm going to tell you the comments in our comment section have uh, expressed the same type of emotion and feeling everyone has said. And I'll read you some of the comments from Camille. Thank you for sharing your story. Paul said, I really enjoyed this, but it is very emotional. It is very emotional. Glenda has said, such an amazing presentation. You have helped me deal with the death of my younger brother. You're so inspiring. Thank you, Dr. McCarr. Liz Landry, who just presented a few minutes for us, said this is the most incredible, enlightening presentation. Thank you, Dr. McCarr. We absolutely, this is the kind of thing that, when you work, I think when you work in any degree of healthcare, we sometimes become numb to a lot of the things that we hear, because we hear of death and dying and sickness and illness and chronic disease and all these things, and we hear it so much it just becomes almost a secondary thought to what we do because we hear it so much. I mean, you think about in a given day how many people we hear about, when we hear that 1 in 3 women die of heart disease. That kind of statistic just, it kind of blows over sometimes and you don't really think about it. And I'm thinking about, especially with wearing red today for women, we don't think about these things. They're statistics, they're numbers. They're not real people. And then you start hearing the stories of what people go through, and having a mother who died from early onset dementia at a very young age, diagnosed with it in her 40s, and hearing the story of you losing your brother, and all of us have a story some way that we can relate to to grief and loss. This really brings it to reality, and I want to thank you. I've been touched by what you've said today, and I think I can say for most of our audience that we've all somehow been touched by this and inspired by it. And I think one of the questions that I have for you, from a practitioner's point of view, when we know of loss, what can we do when we know that we have a patient? And I say I don't have patients. Lord have mercy, I couldn't do it. I admire all of you that work in any field of medicine that works directly with patients. My heart would break every day and I couldn't do it. All I would do is go home and be a basket case of tears and emotion all the time. So I admire all of you who work with patients, because I know what you see and I know what you go through. What, from a practitioner's point of view, how do you support? What are the words that you can say to support? How do you, without feeling like you're sticking your foot in it, or you're pushing yourself into a dimension that you're going too far, how do you provide support to that patient that you know that's experienced loss, or who is about to experience loss, or who you know is sick and may be very well coming to end of life? How can we go about sharing, helping them understand their grief and helping them deal with it?
Sure. No, it's true. And I hear that from patients all the time. Because I'm open about my brother's loss. One of the things is that people just want to be heard and seen. They just want to be seen. And just accepted that, yes. So when somebody tells me, oh, I have a family who's lost one side of the parents, and now the wife is about to lose her dad. I'm like, no, your kids are young. Why don't you spend time recording him, have him leave little mementos for your kids? Like, you are given a gift of time that you know it's coming, but try to cherish those. Um, you can give them little suggestions if they're open to it, but a lot of times you just want to maybe a simple hand on their shoulder or hold their hand and say, tell me what's so special about this person. Tell me something that brings you joy about them. Just have them talk to you about that individual. And that's all people want. They just want to share their loved one, that yes, they matter, and yes, you matter. So, yeah.
Absolutely. Paula says, thank you for sharing your story. It honors your brother. I believe, Marie, the code is back up for her book on Life Interrupted. I believe that code is back up, and we'll make sure that we provide a link to that as well in our email that's going to go out. That when we provide you with a link to go view to view the presentation again, we'll make sure that we provide Parul's or Dr. McCarr's information in here for you to be able to access that. So as well, if anyone else has any questions, while we're waiting just a few minutes to see if anyone else has any questions or comments, I want to say we always look forward to you joining us, because it does. Moments like this really do help put things in perspective in so many ways, and it's so important. It's dealing with grief. I think during COVID in particular, because we saw so much grief during COVID, that I think grief became almost numb in many ways to us, that we just saw so much of us, so much of it around us. You couldn't turn on the news without seeing a body count, a death count. And I think seeing things like that just numbs us to reality of sadness. And I think we're finally getting over the hump of that, where grief is becoming more real, and we're getting to a point where it's again, a central part of life. But I don't see any more questions. I want to thank you so much. I truly do. I want to thank you, and don't be a stranger. We love you at aaosh. We've had you on before. I'm grateful to have you during my tenure here now, and I hope you'll come back and join us again soon.
Anytime you want, I'm here. You guys are all very special.
Oh, thank you. And you are to us as well. We really, really do appreciate you. Thank you so much. We will put the same QR code, guys, like we've said before, works. There we go. For Dr. Parul McCarr's webinar, same one works. So you guys can go ahead. We'll leave that up for just a second so that you guys can get a real quick screenshot for those of you that are working off the QR code. And then I know that Danielle will stick the URL up in there so that you can get your credit for this webinar as well. If you are struggling or having any trouble with the QR code or with the URL, please do, like we've seen other folks do today, please let us know. Sometimes you do have to hit refresh. HubSpot will actually think that you're just in there just collecting credits over and over and over again. It won't let you do it. So you do have to refresh it sometimes and come back to it. So if you have any problems, we're here. We will do everything we can to make sure that you get those credits today. And if you have any trouble down the line, let us know too. And we'll be more than happy to help you any way that we can. Thanks again, Dr. McCarr. We appreciate it. Thank you so much. And I'm going to, let's see, I'm going to share something with you guys too, real quick, before we go to break. So I want to, let's see if I can share. I'm going to try this again, because every time I do this, for some reason, I go to share my screen For some reason, it never lets me do this the right way. So let's see if this time, Danielle, I can actually get it to do the right thing. So, Danielle, tell me, what do you see this time? Do you see my notes or do you see the right slide on here?
Looks great to me. Great job.
Okay, finally, we got it right for once. So here we go. I want to talk to you guys. We've talked a lot today about nitric oxide today, and one of our sponsors that we're so thrilled to have with us is a sustaining partner for us. It's going to be with us the whole year. You'll get to see him at annual session, is Berkeley Life. And Berkeley Life is the nitric oxide experts. And we are so glad to have them along with us. Now, healthy aging, we know, starts with nitric oxide, and it's often referred to as the miracle molecule. It plays a critical role in the body to raise your baseline health. So health goes where blood flows. Nitric oxide is the foundation of great health and the key to unlocking your optimal well-being. So as you continue to age, this nitric oxide in your body will continue to decline as well. This leads to decreased blood flow, impairing the delivery of oxygen and nutrients to cells and contributing to common age-related issues, including poor health, hormone imbalance, low energy, and decreased sexual function. So by the age of 40, your nitric oxide levels actually decrease by 50%. So Berkeley Life's vision is to leave behind a world in which nitric oxide is considered as fundamental to everyday well-being as proper hydration and exercise. And by sharing access to their complete source system, they hold the power to radically transform health for all people. So I want to show you something. Berkeley Life provided to me, if I can find it, this great kit. And again, I'm going to have to hold this in front of me. So this little starter kit is a great kit to start out. This is the total support kit for to boost blood flow. So inside of this kit, you get some test strips, which I'll probably have to do this in order for you guys to see them. You get test strips in order to test your initial nitric oxide in your blood, which I did, and mine was pathetic. So it was really bad. I don't know if I'm going to try to hold this up for you guys to see it. Mine pretty much didn't exist. I apparently had no nitric oxide in my blood at all. It was very low. And they also send in this box the nitric oxide foundation supplement, which is blending in, of course, because it's not being seen from my background. But they provide these supplements to you. You get in this supply 60 capsules, which is the same as a 30-day supply. And then you also have 16 pieces of this is a prebiotic nitrate chewing gum as well. And then what you do, you test it in 90 minutes after you take the supplement. And suddenly, and I've been testing this every day since, I am finally normal. So my levels are considered on target and normal just within the first day of taking this. And every day that I've tested after, I have either been at target or a little high. So on these levels. So this is a great little starter kit. If you go on their website right now, everything on their website is on sale. So I like beets too. So I'm a big beet eater, it was really surprising to me that even with as much as I like beets and spinach, that my nitric oxide levels were not as near as they should be to normal. So I was really kind of shocked that they weren't, as much as I like beets and spinach. So sometimes even eating, you think you're eating enough to get everything you need, and you're not. You're still not getting everything you need. But you can go from this absolutely pathetic reading like I had, which basically said I had absolutely no nitric oxide in my body, and I thought I was doing everything right, to being, this is target level and being right on spot. So I would encourage you to go to their website. They have so much great information at berkeleylife.com right now. Like I said, everything on their website is on sale, and you can get this great starter pack. The other thing that we're going to do for Berkeley Life today, so that they're going to offer some really great deals here coming up pretty soon too for aaosh members, we're actually going to give away 2 memberships to aaosh today as a part of a deal with Berkeley Life. They have sponsored 2 memberships today. So even if you're already a member, we'll extend your membership for a year. So we're going to do that as well today. So what we'll do is we'll take all the people who are listed on our attendance list who are in here. We see all the folks. We know who you are. What we'll do is in the email that goes out, we'll list your first name, last initial on the email that goes out to you. That's got like all of the links and all these presentations and everything that we've promised you today, and we'll list those two folks on there, and we'll get a hold of you by email. So we're actually going to give away 2 memberships today, and that's a pretty awesome deal from Berkeley Life, as well as you being able to go on their website right now, and just everything is on sale. So we are so proud to have Berkeley Life as a sponsor. We hope that you will engage with their products, and we will have Berkeley Life as a part of our sponsorship all year long. I will say, and we've got still one more sponsor coming up today. We are so blessed with so many great sponsors. I can't say it again. And how many people that have stepped up this year to sustain and help aaosh. We are so blessed. And we continue to be blessed. We still have people who want to step up and say, we want to be a part of this oral systemic revolution. We want to be a part of saving lives. We want to be a part of this movement. So folks, please support these folks. They're your people. They really are. They're your tribe. They're a part of your tribe and your people, and they want to help you be successful, to save patient lives, and to support and grow your practice. So we're going to take a bio break, and then when we come back, I'm excited about the next speaker that's coming up. I think you're going to be blown away at the myofunctional therapy that we're going to be able to talk about with our next speaker. So let's take a break. We'll come back in a few moments here. And when we come back, exciting stuff coming up with our next speaker. So let's take a break, guys. We'll be back in just a few. Hey everybody, just you still got time. We've still got 3 minutes. I want to just kind of come back on, and I've had to change locations. My dogs went crazy because this is the time of day that kids are up and down the streets, and you all don't want to hear a beagle scream. I promise you, it's a very loud noise. So I'm trying to help everybody out. So we've changed locations to a different part of the house where it's a little quieter, and hopefully they won't hear as much noise. But we are we are so close to being done with today. We've got one exceptional speaker left for today, and then we will be finished. But welcome in. I put a note in the webinar chat. If you are a CDE and CME junkie and you like going to things like this, and you go to all of our webinars, and you have been to Collaboration Cures, and you love, hello Lily, and you love going to every thing that you can get your hands on related to oral systemic health, even if it's not with aaosh and you just got tons of CE credits, apply for a fellowship. It's a great way to be recognized for all that knowledge that you've got in your head and all that knowledge that you've learned on paper. And we will help you. Danielle and I will both help you find your way through the fellowship. And the great thing about it is you'll be recognized at annual session. You'll be recognized on our website. You get to carry those credentials with you. And there's steps in the process. So once you become a fellow, you can actually apply for different levels of fellowship up through the master and through the diplomat status. So please apply for it. If you've never done it before, look into it. Let us know if you've got questions. We would absolutely love to have you join us as a fellow for our fellowship program. So please check into that. We'll give it about another minute and a half and let people roll in. Guys, we've had a great day today. It's been really good. All the speakers have been great. Um, we've had some just awesome information. I'm always so awestruck at the talent of the Speakers Bureau that we have here, and it's always such a joy to me to be able to organize these things with Danielle and bring these folks to you. And I think we're just getting started. I'm really excited about what the speakers we're bringing to annual sessions, our webinars. I mean, just in February alone, we've got two aaosh rock stars. In February, maybe a third coming along. We know for certain that Dr. Ellie Campbell and Dr. Alan Reisinger are going to be presenting for us for webinars in February. We've got a great lineup coming in March and April. I mean, we've got practice profitability coming up that Dr. Nabil Femi is going to lead for us. I mean, we've got some great stuff coming along. So we really hope that you will keep tuning in, keep joining us. We are super excited about what's coming down the pike. Laura, I see you're in here with us. Hi.
There you go. Hello.
How are you doing today?
Good, how are you?
Doing good, doing good. So I think this is one of the most exciting things that that aaosh has been able to really bring to the forefront, because we've always got we've got all the oral systemic health. We talk a lot about the mouth side of it. We've had a lot of talk. We've even had talk today about grief counseling and things of that nature. We've had a very diverse group. This is exciting. Myofunctional therapy is something that I have hoped that we would be able to get our hands on somebody who would come in here and really bring us home on myofunctional therapy. And you're going to do it today. And we are so excited to have you and to have your organization on board with us. What I want to do is allow you to go ahead and introduce, as a sustaining partner for us, your organization, and let you talk about that first. And then what I'll do is let you get through those slides. Then we'll start the CE portion of the presentation, and then I'll kind of introduce you on a much more professional, higher end level, like I've done the other speakers today.
Okay.
So I'll let you talk about your business first and let you do that, because then that'll allow me to kind of break off and say, okay, then we're going to start the CE portion, so that our creditors go, yeah, you're okay, and I don't get in any trouble.
Oh, gotcha. Okay. Thank you so much, Violet. My name's Laura Walls, and I'm a speech language pathologist, and I've been practicing for about 34 years now. And I started in with adults post-stroke and Blomsinger fittings for tracheostomies at the VA in San Francisco for my postdoctorate degree. And then I went on to be a NICU feeding specialist for high-risk infants and infants with feeding difficulties. And then I started my own practice about 25 years ago. And currently I have two companies. One is called Innovative Oral Solutions, and that's working in the dental space, myospace, swallowing space, TMJ, and headaches. And that's what I'm here today to present. My other company is a pediatric company called Innovative Therapy for Kids. And I have about 14 therapists that work with me, and we have about 17,000 visits a year. And I've been working in this airway, myo, ortho, dentist space for about 17 years. And the past 4 years have been so exciting. And that's what I really want to get into today to explain to you what to do and how to really get to the roots of what's happening with your patient, figuring out a really great treatment plan, and being able to have checks along the way to make sure you're on the right path. I think that's what I do really well. My goal is really to get to the root of the problem and then have success for any practitioner that's treating an airway disorder. Is that good, Violet? Any more?
That is great. That is
Okay.
absolutely great. So if you want to go ahead and start sharing your slides with us, I will walk you through your presentation.
Kieran's going to get the slides up.
All righty. Hi, Karen, by the way.
How's it going?
Hey, doing good. So if you'll start at the very beginning, and what I'll do is just say next slide as we work our way through it, and then when I'm done, you guys can rock and roll. So today we are going to talk about decoding sleep disordered breathing for airway optimization with Laura Walls here today. So if you'll hit next slide for me, because we've gone through some of these.
Yeah.
So this is the course information. The next one, please. This is our accreditation on the next one. You can go ahead. This is our disclosure and our disclaimer. Next one. Method of participation. We can move on from that one. This is our course description. And then our next one. And there's our learning objectives. And then our next one. There's our practical applications. And then our next one. And Laura, I'll go ahead and give you a little more formal introduction. It is my privilege to introduce a remarkable professional and a pioneer in speech and myofunctional therapy, Laura Walls. With over 30 years of experience, Laura has dedicated her career to helping patients overcome swallowing and communication disorders. She holds a master's degree in speech and language pathology and audiology from California State University, Hayward, and completed a fellowship at the Veterans Administration Hospital in San Francisco. Her expertise extends to pediatric rehabilitation with specialized training in neonatal intensive care, ensuring even the most vulnerable patients receive the care they need. Laura is a true innovator in her field. She developed the My Program and Oral Placement Appliance, pioneering a whole body approach to myofunctional disorders. Her work has transformed treatment methods and improved countless lives. Beyond clinical practice, Laura is a sought-after speaker at Myra Costa Community College and holds a child advocate certificate from the University of San Diego, demonstrating her commitment to supporting children beyond the clinical setting. She is also proficient in electroequiscope and nasal release technique, expanding her ability to provide comprehensive and effective treatment. Laura's dedication, innovation, and advocacy have set new standards in therapy and rehabilitation, and we are honored to have her here today. Please join me in welcoming Laura Walls.
Thanks. That's so nice, Violet. Thank you.
You're welcome.
I appreciate that. So my goal today is, thanks for all the nice emojis. That's cute. I want to go over sleep disorder breathing and how we can identify this and then optimize airway function. And so that's the goal right now. So we talked about myself already enough, both of us. So we're going to skip that one. The goals for today's course, I want to explore the complexities of sleep disorder breathing, and I want everyone to understand the latest advancements in airway health. And I think it's so important to know why it's so confusing. And we're going to go through this and talk about this more. We're going to talk about sleep disordered breathing and the different types for optimization of airway health. We're going to look at global awareness for different data points. And I think data is so important because it drives your service and it tells you if you're on a good path or you need to adjust your treatment path in some way. We use a technique called MyoRhino that we developed, and some of the techniques we use in that for data collection is obviously assessing the oral musculature, peak nasal inspiratory flow. I'm going to show you all this, sleep test results, and then 4-phase rhinomanometry. And that will be really fun to see what would fit into your clinical flow. And then finally, we're going to monitor and assess and learn effectiveness of different treatments. What's out there? How much does it really work? Does it not work? What if we pair all these together and what that looks like? So ready for the next slide. So the types of sleep disordered breathing, there's really 5. And the 5 are OSA, obstructive sleep apnea, central sleep apnea, mixed sleep apnea, UARS, which is upper airway resistance syndrome, and then snoring. For our purposes, we're really going to focus on OSA, UARS, and snoring, and then look at all of these and how the impact of the airway affects these and their treatment. So, okay, when I started in this sleep disordered breathing, it was so confusing because I would read literature and I would say, okay, wait, AHI, RDI, what's going on? How does my insurance bill this? So we bill insurance, and there's 80 types of sleep disorders, period. And these terms, the different types are used with different terms, terminologies. Some have acronyms. Some insurance accepts AHI as their index measure. Some accept RDI. And it's really interesting to find out how challenging it must be for people in the airway space to bill this. And so what I want to do is just break it down into obstruction, learn how to treat this, and teach you terminologies that would focus on successful diagnostic and treatment. All right, so for a change to occur, this is in your assessment and treatment, both of these have to be there. First, you have to identify what's going on. So what's happening? Is this person not sleeping? But what does that mean? And so we need to go into the root causes of why is this person not sleeping? What kind of stress do they have? What kind of environment do they live in? Do they have allergies? Is it genetic? Is it something in their environment? Is it something that they eat? So we're going to look at all of those areas in our health profile that we give to the patient. And then what we do is ask the patient, hey, what do you think about this? Are you sleeping well? And a lot of people say, I don't sleep well. I don't feel rested. And then we say, okay, well, how do you breathe? They always say, good. I breathe so good. And then I go, oh, okay, let's break it down. Do you breathe really well at night? Yeah. How come your lips are chapped? My lips are always chapped. My kids' lips are chapped too. And so really identifying what is a mouth breather. Are they aware of their body? Are they aware of how body posture, sleep position, different things impact our system to cause that function, to cause a dysfunction? And I'm going to go through that. Then we go into assessing, okay, is it weakness? Is it occlusion? Is it endurance? So we break all of that down with the patient, and during our assessments and treatment, we're constantly checking and monitoring what's happening. Then we apply all of those skills into some type of generalization. So what that means is I'm going to take an exercise that I'm doing or a breathing measurement, and I'm going to take that and have them use it in their everyday environment. And then finally, the biggest part of this is making it a habit. So what we're doing is changing parafunctional habits, breathing structures, weaknesses, and we're cleaning all that up. So we're making this perfect specimen. And now we have to keep this perfect specimen. And by doing that, we need them to have a habituation of these habits. And I'm going to talk to you more about how that looks. All right. So the 3 breathing abnormalities that we use right now in sleep and on sleep tests, they're really based on these 3 things. And different insurance accept different areas of sleep. And typically what they say is the AHI the measure. And what that means is apnea hypopnea index. And so apnea means there's a cessation of breathing for 10 seconds or more. So that's the apnea measure. The hypopnea measure means there's a reduction in breathing and a drop in blood oxygen levels, so a DSAT during sleep. Those two together give your AHI index. And so there's a rating scale there. What they are starting to look at now more is RERAs, and RERAs are respiratory effort related arousals. And this means that you struggle a little bit. You're going to start relating this to RDI, or respiratory distress index, where you move a lot, and so it wakes you up at night. And we'll talk more about that. All right, so it looks like my slides look different. Okay. So what an AHI looks like, and everybody's probably pretty familiar with this. So remember, you have to stop breathing for over 10 seconds. You have to have a desaturation of oxygen during that time. And what they do is take the whole night of how many times this happens and divide it by the amount of sleep. And that's how you get your AHI score. So I think everybody would know 5 to 14 is mild, 15 to 29 is moderate, and 30 or greater is severe. They typically start treating insurance starts treating at about 30 or more stops in breathing cessations, and this is per hour. So you could imagine if you have breath stopping in that hour, what that does to brain function, your lymphatic system, your respiratory system, and your lymphatic system. And so looking at that just seems too long to wait to me, and I'm going to show you what I mean and how we could look at it differently. I think the last one is the respiratory disturbance index. And so what that is that's your ROI, and that is your AHI plus your RERA index. And I'm going to show you on a form that I love using to be able to break up what's happening with that. Okay, then there's the snoring. So snoring is not considered a sleep disordered breathing diagnosis in a lot of areas. I consider it the precursor to a sleep disordered breathing. And in treatment, it's super important to identify the snore type so we can treat that when we're doing any kind of myo exercises, when we're measuring the airway. We want to look what type of snore the person is. There's 5 types of snoring that you should be aware of. And so the first kind and most common is the nose type of snoring. And what that means is there's blocked nasal passages or high nasal resistance. This is typically because of allergies or anterior valve collapsing in the front of the nose, or posterior valves collapsing in the middle sinus structure. What that sounds like is a whistle or a grunt. So we have this on our intake form when they come in for a myorhino, and it just kind of breaks the ice, like what kind of snorer are you? So are you a whistle grunter? Are you a rumbler, a high pitched? And the spouse always has the right answer. The patient might not, but it's good to ask them about this. And then from your testing, you can confirm what's happening. The second type of snorer is a mouth breather. So I think this would be really easy to identify. They typically have chapped lips when they're sitting there. They have a forward head posture, lower lips often really weak. And so the mentalis might be right here, might be taut. And so it's pulling that lower lip down, and you can see the lower dentition. That's often with a mouth breather with a retracted chin. That type of snoring is more of a rumble. And so we'll go into this as well. And then when you're a tongue snorer, this is when the tongue drops into the back of the throat. And this is when your patient says, oh yeah, I really snore when I drink or alcohol, or I really snore at night. But when we do positional changes to the left side, for example, we'll notice that snoring ceases. And that was a positional change that we needed for the tongue, also indicating that they have tongue weakness. And that type of snoring is more high pitched. Now, when you have a palatal flutter, which is what most of you probably deal with, that really deep, serious snoring where it wakes up the whole house and the family's sick of it, and that's why they're coming to you, that's called a palatal flutter. This is the most serious type of snoring, and it's linked to obstructive sleep apnea. And so once they get through this and they have a palatal flutter, it's probably because the tongue's retracted, they're mouth breathing, and they have a high nasal resistance. So it's a sequence that goes down. And then the final fifth type of snoring is all of these in one. And that is very common by the time we get these patients. All right, so I love this. Scott lets me use this from Sleep Apnea Matters, and I love that website. It has a ton of information on, they're a nonprofit, so I don't get paid for this, but they have a ton of information on sleep disorder breathing, what is AHI versus RDI, what's an apnea and hypopnea. And this is a great chart to reference. And so as you can see at the bottom of this chart, you can see it says no disease. So nothing's happening. Normal breathing, no nasal resistance, no upper airway resistant, adequate palate, good lip closure, tongue's on the correct spot. That's where we want to be. And as you creep up this chart, you see then now the snoring starts, but it's still not a disease. But we know that, as we just referenced, those 5 snore types are leading us into greater disease. And so I think it's so important to know the progression of how a sleep disorder breathing happens. So we look at the snoring, we know there's 5 types now. You can ask your patient, okay, what's going on? And then we go into, all right, now we're getting into this, the sleep apnea space. And so we're looking at, typically when you look at UARS, you're looking at your CBCT and you're seeing if there's a constriction within the oral pharynx, and you're seeing, okay, how tight is that space? It's usually associated with people that are tall, slight. That's your UARS clientele. Those people always have high nasal resistance. If you have high resistance here, you're going to have high resistance in the nose. That's Bernelli's principle. It's really important to remember this. If we're treating expansion, we can overexpand and cause more restriction on either space. And that's why these measurements are so important to understand what's actually going on with the structures and function. All right, now we go up, and so now we're going to say, okay, mild sleep apnea. So we're almost halfway up the scale, and now they're starting to accept that there's some kind of issue. The insurance is allowing some kind of treatment. So mild sleep apnea is typically treated with expansion. It's treated with some type of brackets, braces, Invisaligns. It's treated with mandibular anterior devices, some oral appliance treatment, and myofunctional therapy. So we want to watch this to say, why is somebody having some kind of sleep apnea? Why are they unable to breathe? Why do they have DSATs? If it's an obstruction, which this is linked to, why is this happening? And your assessment would be able to say why this is happening. And even just by using the simple snore chart of your 5 different snore types, we could look to say, oh, this guy has a palatal flutter. Obviously, there's oral weakness. There's postural changes that needs to happen. We need myo work. We need to measure this person's respiratory system. So then you get into your moderate sleep apnea. So remember, that's 14 and above stops of breathing per hour, where you have oxygen desaturation. If you're at risk for anything such as stroke, Alzheimer's, dementia, as you guys know as a group, this contributes to poor brain and cognitive health. This also contributes to poor lymphatic flow. So if you're at risk with, let's say, an autoimmune disease, or if you have poor lymphatic drain, or you have circulatory issues, we have some serious issues that are compounding these factors that need to be looked at and addressed. And then finally, we go up to severe sleep apnea, which is where most people get treated. And so when you look at this huge spectrum, we could do so much before we get to the place where the person has been suffering. There might be brain damage. They already might have lymphatic issues. They might have triggered the system into an autoimmune response, or might have caused tons of stress, anxiety. They can't sleep. they might have job issues, personal issues because of their respiratory support system. So I want you to think of this a little bit differently and say, okay, what's getting me to this level? And then even more so, what can I do to prevent them from getting to this level?
Put the stop sharing real quick.
What?
When I translated or converted it to the thing, it messed up a bunch of stuff.
Did she tell you so?
No, I just noticed it right now. One sec, guys. Sorry.
We're going to restart your presentation so we can get everything lined up for you here, Laura. So, guys, give
Thank
us
you.
a moment. We're having just an itty bitty technical difficulty, and we're going to get restarted. I want you to see what an amazing presentation that she has. So we're going to try something real quick. We've got Karen in the background who is literally he's a techno genius, and he's going to make this work. He's going to make this work, right? Yeah, he's going to make this work. 100%.
Okay. Oh yeah, I like to do that. Okay, yeah, this looks so much better. Okay, is it working?
It is. That, can you guys see that?
It is
Is that
starting.
good?
Give it just a see. There you go. Look at that. That's
Okay.
that's how we do it. So we are so glad to see that. Absolutely. So there we go. Yay. 2 thumbs up
Awesome.
for that. Absolutely. I wonder if my little thumb up icon will work for me. Maybe not. Nah, it
Maybe.
won't work for me. I'll try that one instead. So
So
there we
much
go.
better. Thank you. It was
There we
confusing me
go.
too.
So
Okay, hopefully this makes more sense to everybody. So this is a summary of sleep disorder breathing. So again, we're looking at the bottom in the green zone. That's no disease. That's normal breathing. And just one step above is your snoring types, which really is already suggesting you'll know then, uh-oh, we're in trouble. We're going up this graph. We're getting up there. Then we go into UARS, and then we go into sleep apnea, and then we go into mild sleep apnea, and then we start treating in the red zone typically. And what I'm proposing, if we do correct assessment, if we do correct treatment, we should be able to keep them at least down in the yellow zone and in the green. Hopefully that's our goal. Okay, is this going to look good? Okay, we're getting on to assessment. How do we do this? How do we know what we're doing? And that's what I want to do. So this is in our book, in our practice, this is considered old school examples of airway function measurements. And they're still used today all the time. And I think Cottleman could be on here too, but basically our doctors, they would say, what's the mirror test look like? And what that means is they would take a mirror like this and put it under the patient's nose, and they would see if they made any fog on the mirror. And if they did, then it's a plus that they're a nasal breather. We don't know how they breathe. We don't know when they're breathing, but they give it a plus. Our ENTs use more of the 3-minute water test. And so what that means is you have the patient take a big sip of water, fill their mouth, hold it, and for 3 minutes you time them. And if they can hold it without spitting on you, then you know that they've done a great job and they're nasal breathers. Well, we don't know how they're breathing. We don't know the function of their airway. We don't know what this looks in a supine position when they're sleeping. And so it doesn't really give us all the clues. Lots of people use only a patient questionnaire where, so patient questionnaire, there's a nose scale. So we'll say, okay, tell me about your nose. Tell me about your breathing. It's a subjective measurement. All these things are great to understand the self-awareness of a patient, but it's not great in a diagnostic criteria or inventory for the patient to talk about function. And then finally, some people even use a Bolt test, and a Bolt test is a breathing oxygen level test. And what that is where you take a big breath and you hold your breath and you blow it out. Then you hold your breath and you time yourself, and you will see how long does it take before you feel like you need to gasp or swallow. And that would be called your Bolt score. Those are the 3 kind of old school ways of testing. We love using a bolt test for patients as they're going through a respiratory program. It's a great way to monitor to see that their respiratory support and gas exchanges are functioning better. But as a diagnostic tool, it wouldn't be the only thing we would want to use. All right, so these are new school, or what we use, effective ways to measure the airway and the function of breathing, and what that means for the patient, especially when they're stressed, sleeping in a supine position, maybe using their oral appliance in their mouth. So we do a test called a myo-rhino, like I said at the beginning. And so we measure peak nasal inspiratory flow using a PNF, and I'll show you what that is. We also use an NR6 or 4-phase rhino manometer. And that's so hard for people to say. But rhino manometer measures the 4 phases of a respiratory cycle intranasally on each side. And it's an awesome test to show clinically where to take your therapy and what's going on. And then finally, we use incentive spirometry. And incentive spirometry is old school, where they have a little spirometer, and I'll show you what that looks like. If you using those, I'm going to go through what they all mean. This is a PNF. I can't see my picture, so I can't. This is a peak nasal inspiratory flow meter. And what this does, it measures in milliliters how well a person can inhale through their nose. Now, it's pretty limited in its diagnostic ability, but one thing it's awesome at is showing if a person is safe to sleep tape or not. And so for us, if a person, an adult, anybody over the age of 15 does a PNF test, actually, can you grab my PNF? It's in my bag. I'll show you. You do a PNF test and you see on this right here, on this measurement tool, you see it goes 50, 100, 150. At 100, that means you'd be safe for sleep taping. And so this is, I think, such a responsible way to do therapy, because then you know for your patient, even if they have a valve collapse or a posterior valve collapse or a nasal phenomenon, we would still be okay to say, yeah, you're safe to sleep tape. We might add nasal vents or cones in, but it would still be safe to do that. So this is what a PNF is, and they're $100, and I think they're a great tool. A lot of patients buy it. Here's an example of what one looks like, if you guys can see it. And basically, this is how long the test takes to do. You go like this, and you get your reading right here. And that's it. So we do the best out of 3, it's done. And so remember, 15 and over, you want it to be to 100, and 60 and above for children. And that's a pretty safe place to go and super easy to do. It doesn't take a lot of time. This here is a 4-phase rhino manometer. And we use this for every patient coming into the clinic as well. And what you do with this is you put the mask, where you tape up one nostril, and you have the mask over the face, and it tests each side of the nasal intake on inspiration and expiration. And it gives you awesome numbers because it shows that, okay, is the anterior valve collapsing? So that means when they breathe in, do their nostrils suck in, preventing them from breathing in? Or when they're exhaling, does that mean there's something, or the turbinates are inflamed, causing a restriction inside of the nose, usually because of allergies, or structural issues or deviated septums? Is that happening? And then we could look also at their flow. So if they have a low flow, we need to make sure that we do sleep position changes to increase flow. And so we would look at that and make it a consideration for treatment. The 4-phase rhinomanometry does a lot of great testing, and we include that in our testing. Yeah, we love it. We've been using it for about 3 years. This is just a spirometer. And a spirometer, super easy to use, has a little tube, you take it. And what's so important about the spirometer that we added to our test, even though we're telling everybody you have to breathe through your nose, it's so important. Don't be a mouth breather. But we also need to measure diaphragmatic expansion and use. And so patients that don't have good diaphragmatic use take a breath and they do. we call it a vertical breath. And so they move their shoulders in order to move the rib cage in order to expand the lungs. If that's happening, we know the diaphragm's not expanding, which means they have a vasovagal issue. We know that they have non-dissociated patterns, and it gives us tons of information for their treatment program. I think they cost about $8, super cheap also to add into your clinic flow. All right, so that's the assessment part that we use. I also want to talk about what we do for mouth function. We look at posture, breathing, jaw, lips, tongue, speech, and swallowing. And so along with our airway assessment, we add those assessments in to make a comprehensive assessment to create a treatment plan for our patients and our doctors. So we do a lot of co-rehab with people who have had expansion, with the orthodontist, dentists, oral surgeons, to see that they're not over expanding. And so with our testing, we could see that they're on the right track, or sometimes people go too far and it causes an increased resistance in the nose and in the throat. And so we can monitor as we go. Even just using a PNIF, it would be an indicator to show that overexpansion is happening and we need to change up our treatment plan. So the same identifications that we use for initial assessment is the same treatment strategies we use for treatment. So again, we need the patient to be aware of what their body is doing, how their body feels, and how it functions in different positions during different activities. Our goal is to find out what function is causing a dysfunction. And in order for that to happen, we have to understand our bodies. So a lot of people will come in and they're crossed over, their arms are crossed over, or their legs are crossed over, and that's going to inhibit respiratory support. If you're crossing your arms, your tendency is to lean forward because it's more weight on the front than the back, and that's going to potentially cause an open mouth posture. So simply by adjusting their posture, a patient will say, wow, it's super easy to close my mouth and keep my tongue on the roof of my mouth. And so understanding that awareness, we would do it in sitting, standing, walking, sleeping, watching TV, driving. So that's a big part of the initial piece of the program. The second part is to increase awareness and proprioception. And so proprioception means understanding where your body is in space. And sometimes I think it is so interesting to say, okay, I've had turbinate reduction, I've had septioplasty, I've used medicine for such a long time, I've had expansion, and I still cannot breathe. Well, I think what we forget is, even though we have access to nasal breathing, it doesn't mean our body knows how to nasal breathe. And so it's really important along the way to teach a person how to nasal breathe before any of these, hopefully not, but if they have to do some of these interventions. And then really important to do during and after the interventions to make sure that they are breathing. One of the techniques that we use is a nasal release technique for turbinate proprioception and mucosal proprioception. So we use ballooning in the 3 sinuses to open up the airways and increase proprioception in all 3 of the sinus spaces. The next thing we're going to do is talk about body strength and function. It doesn't matter how old you are, your body supports your airway, and your airway really contributes to body posture. So we go into posture and the effect on breathing. And then, okay, now what are my jaws doing? What are my lips and tongue doing? Can they dissociate? So a really good way to just check is say, if you can have your patient poke into their cheek, and say, if you could poke into your cheek without moving your head, not like this, we know, okay, hold on a second. This is a great prognostic indicator. It's going to be way faster than a patient like moving their whole body to the side. And then to add more to it, we would say, okay, poke your cheek this way and look this way. No, this way. No, and try to get that coordination. And that's part of this, to have dissociated patterns. And what that means is the jaws can sit super nicely and easily. the tongue can maintain its posture while the lips stay closed. And so we need to be able to move those things in isolation, jaws being neutral, lips being closed, and tongue being on the roof of the mouth. So we do all these fun activities to make sure that that can happen in all areas, because if we can't move our eyes this way and our tongue this way, well, when I move to this side, my jaws are going to still slide. My mouth is going to open. And so that really helps with the next step, which is generalization of those skills into functional activities. And then we habituate and make sure everybody can maintain these exercises, strength and endurance that we've taught them. The biggest thing with all of these treatments, I think anyways, is remembering it's 350 to 500 times to establish a neuro plan. So I'm going to say that again. In order for something to become a habit, you need 350 to 500 times to establish a neuro plan. That means automaticity. That means a habit. So if I'm breathing in my nose, I need to do it right and well 350 to 500 times. So let's say during the day, I'm doing awesome. I have my tongue on the roof, my jaws are relaxed, my posture's back, it's neutral. And then I go to bed and I lay on my stomach and I have jaw pain and I lay like this on my stomach. Well, what do you think's going to happen? It just undid everything that I did before all day. And so what we need to make sure is this happens in our entire environment. And that's what that looks like. All right. So this is so interesting to me because when we think about all these treatments, how do we treat sleep disordered breathing? How do we identify sleep disordered breathing? How do we bill for sleep disordered breathing? Am I even doing the right thing? How does this work? What am I doing? And I find even sleep specialists, there's questions along the way. And I think it's so important to say, okay, look at these treatments. This is the success rates of these treatments based on these different diagnoses. So for obstructive sleep apnea, they often use CPAP, and there's a 34% success rate with that treatment. I don't know about you guys, but when you think about these percentages and you think 34%, so I have about a 60% chance of failure. I don't think that's a great ratio. I mean, I wouldn't drive down I know there's a chance of getting in an accident, but knowing 60% of the time you're getting in an accident when you're going to get in your car and crash, I don't know, I wouldn't. But knowing 34% success, that seems low. Why? Why is it not working? Well, if you think about it, when you push air into a system that doesn't allow anything to go into a system and there's resistance, which means there's resistance, why would that work? So maybe your nasal snore type that has a full mask is part of that 34% success because they still have some kind of opening in their airway. But it's really interesting to think about this. So the second one is dental expansion and jaw repositioning. Use MARPs and SARPs, and I'm part of a lot of cases with this. And that's about a 70% success rate. There's variability, but the relapse is 50%, showing in the data right now. Dental relapse after 10 years is about 50%. So what's causing the relapse? Muscle weakness. Remember, muscles guide bone. These are all muscles, ligaments, and tendons. And the teeth are bone, and the jaws are bone. So if we have parafunctional habits or weakness or non-dissociated patterning, well, of course, it's going to fail over time. And that's why it's so important to have a comprehensive program, because that success, 70% is pretty good. So you pair that with some really good myofunctional therapy and some breathing strategies, and you're going to hit a home run. That's awesome. So your next one's surgery, 70 to 90% initial effectiveness, and that's your turbinate reduction, septal deviations, tonsillectomies, adenoidectomies, that type of thing. But the again, rate of relapse is high. You're dealing with muscles, tissue, ligaments, and tendons. I'm almost going to be 60. It's nothing like when I was 40. You know, it just gets harder and harder to maintain that muscle integrity. And so we have to think about this. We could take everything out and open everything up, But you know what's going to happen? Unfortunately, over time, it will collapse, it will weaken. So we want to make sure, even though we're doing surgery, what is our treatment plan during that time? We have to do myo, we have to do airway, and we have to assess a full body function to know what the root cause of this is to maintain success. So mandibular advancement devices, I don't know why I'm looking at 30% right now in a lot of the data, which seems low, but I don't know why that's, I need to look more into that, but that's right now what it's saying. I really like the use of MADs and oral appliances. I think it gives a really good option for a patient when they're pairing it with therapy. When they start going to the second, third click, I definitely see a correlation with jaw pain, headaches, especially temporal pain, sometimes ear ringing, ear issues where they notice they get a little stingers in their clogged ears where it starts throbbing. That's pretty typical with MADs because remember, it's pulling the jaw forward, and those jaw muscles are all here with the temporalis muscle, which is all related to your anterior posterior muscles, and then SCM, which is going right up here. So 30% success for that. Myofunctional therapy, there's actually some studies coming out. We have one study right now that's going through assessment, and it's interesting. We do a 16-week study and a 16-week program, and we have really, really good success. And we've been checking this for over 5 years. So our hold is 5 years, so it doesn't have long-term efficacy, but we're getting there. But basically, the data shows that you can decrease hypopneas by 50% using myofunctional therapy in adults and 62% in children. However, there's no long-term studies to show the efficacy over past 5 years. And so we would want to look at that. We need to pair again and do great assessments so that we make sure we maintain the integrity of those tissues. Nasal release treatment. Can you grab me that kit and I can show Ben? Nasal release technique is something we've been using in our practice for about 2 years, 3 years. And basically it looks like this. It comes with this blood pressure cuff, and you affix a balloon on it, and you blow it up like this, and you insert it into one of the 3 sinuses. And we do all 3 sinuses when we do our treatment. And this has been really impactful for opening up the airway and also reducing the size of the turbinates. So when the turbinates get rubbed, they calm down, they release nitric oxide, and it's so helpful in establishing nasal breathing. So that's been a game changer for us using the nasal release technique. Medications, daytime sleepiness is another treatment for sleep disordered breathing, and there's tons of rebound effects, side effects with the medicine, and you have to keep upping it because people get used to it. And so it's something that we don't recommend for long term, but we do in our sinus protocol have a patient on a sinus release or an allergy release for the first 7 days of our program. And so obviously from these results, we're looking at anatomy, we're looking at parafunctional habits, and we're looking to say we need better success rates for what we do to make more of an impact on our patients. And this is kind of cool. I love anatomy, and just looking at how much of the airway, and you guys probably know from your CBCTs or your x-rays what it looks like, but when you really, really think about it, the tongue is, the placement is the lower part of the sinuses. And so if you don't have correct tongue posture, that means being on the roof of the mouth, it doesn't help take the mucus into the posterior nasal pharynx. And so if you have a low resting tongue posture, this sinus cavity is just hanging out. And when you open the mouth of somebody that has a low resting tongue posture, you'll see down the top of the palate. In my longer class, I could get more into depth, but you can see on the palate, you'll see white or yellow or even green. And what that is it's mucus that's been left there because the tongue isn't pulling back that mucus. It's so interesting, but I just want you guys to look at an ideal airway placement versus a narrow airway placement. So everything being in there. And so being in this space, there's so many different theories. Palatal tori is caused by, some people say they don't know. For us, what we look at is from clenching, and there's palatal tori and then sublingual tori. you have scallop tongue, you have linea alba. All of those are because of parafunctional habits. And so those are great things to look at to see what's happening anatomically to cause these parafunctional habits and then these deviations in the anatomy. All right, we did it. Is that good? The end?
Question.
Okay. Violet, did you see all that?
Yeah, I sure did. And I mean, everybody's just thrilled with this. I mean, look at all those claps and all those emojis. I love it. We are so thrilled for everything. It was a great presentation. It was fabulous. So we have some questions. Cheryl, I see your note. Are you talking, and if you will just put a note for me, are you talking about the one regarding metal in the mouth, or are you talking about the one with different elevations? If you'll let me know which one, because sometimes, I think you mean the one, the metal in the mouth. So Cheryl had a question. Does or can living in different elevations impact O2 saturation levels?
Yes, and it's by 5% about that it shows in the data. But you remember your norm is your O2 sat norms are really, they say 92 is normal, but 94 to 99 is within your normal range. And so even if you're in higher elevations, where you should be at least at 92.
Gotcha. And then the next question we have is from Paul. It says, with palatal expansion, why a 50% relapse?
Why do you think? So if you're expanding, only expanding, pulling something, but you have a habit of sucking your cheeks in, or you have a tongue thrust, or you're a mouth breather, and you've expanded the whole palate, but now the cheeks are pushing in the palate. Remember, the muscle guides the bone. And the tongue's pushing out the front of the mouth because there's a tongue thrust, or you bite your lip like this, or you only chew with your front teeth. That's going to collapse the bone and cause an inversion of the teeth again, creating more of a narrow palate, crowded dentition, and airway issues.
Gotcha. So Sandra asked a question about toleration of CPAP, and this is something that's kind of near and dear to my heart. I worked in a sleep medicine clinic. That was one of my first introductions to oral systemic health, about people being able to tolerate CPAP.
Yeah.
With only about 34% being able to tolerate it, we had so many people that would come in that they truly could not tolerate it. While people on CPAP, once you can get them used to it, a lot of folks are truly successful with it. They can adjust, and it takes time to titrate them up and go through their titration and get them used to it. There are a lot of people who truly just cannot tolerate it. They cannot do it. A lot of it, I saw a lot of veterans with PTSD. A lot of women who, heaven forbid, were sexual assault victims. They just couldn't handle it, and unfortunately, I was one of those people who could not handle it due to a number of things, PTSD being one of the biggest. But I couldn't handle anything over my face. I struggled during COVID with a mask. I learned to tolerate it, but it took me even a while to get used to that, to the point I almost became a homebody, and it took me a while to get used to going back out after COVID was over, to just get back out in the world. But they asked, what do you mean that only 34% of people can tolerate CPAP? I learned that CPAP is 100% successful.
Okay. I think I don't know where you learned CPAP is 100% successful. So that means everybody that got CPAP would be able to tolerate it. And in my experience and in the data, that doesn't show to be true. And the reason why it's not true in my experience and in the data is because of, Violet, exactly what you were saying. There could be some trauma there, claustrophobia, but basically, if your airway structures can't take anything in, so if you have high nasal resistance and you have a nasal cannula, the air can't push in, and so you start gasping like this. And so then people rip it off. And that is one of the ways to not be able to tolerate. If you have a posterior tongue position that's occluding the back of the airway and you put a mask on, they can't get the air in. And so some of this is looking at that. We do CPAP with the 4-phase rhino manometer to be able to test to see what's actually happening with the respiratory structure during the wear of the CPAP. And I know there's data attached to the CPAP machines, but our job typically from when we get the patient is the patient that cannot tolerate CPAP. And so that's the group that we get the most. Palatal expansion therapy with them, so we maintain those results. And the second one is, okay, I have sleep disordered breathing, I can't do CPAP, and I have jaw pain, so I can't wear an oral appliance. What do I do? And that's what we're at. I hope that answered, Sarah. CPAP 100%. I've never heard that
For
before.
Sandra, yeah.
Yeah. So yeah, that's why.
She's asking if they can tolerate it, they're successful 100%.
But those that tolerate it, they are 100% successful. Yeah, probably. And if they can tolerate it, I would look at it and see, what are your OSATs? What's your brain function? What's your lymphatic system doing? Do you have any other autoimmune issues that are associated with sleep? Do you really feel rested after sleep, even though the numbers show it's being tolerated? What is the brain function after? What is the word finding? How are you functioning within your day? Where I think it's really important to look at the whole picture. And that might be awesome that somebody does tolerate CPAP. So good. But they often have autoimmune disease. And they might also have anxiety and depression and jaw pain. Why? And I really think it's so important, especially with a group like this, to look back at the root causes and keep going back. Okay, I can make somebody successful with CPAP, but how come they're still sick? Why is their immune system function so low? Why do they have gut health issues? Why do they have a vasovagal response when you even just go to try to touch the mouth? How come they have such high anxiety and depression? What's happening? As airway specialists, the first thing we do when we come out of the womb is breathe. And nobody measures it. We don't measure it. I don't know why we don't measure it. We try to pop on a big mask to say, now you're fine. But we don't measure the function on how we're doing this. And so, okay, they're tolerating it, but what does that look like for their entire body health? What does that look like for their entire body psyche or cognitive health? All of that matters so much. And that's where we get our patients is we work with a lot of sleep specialists, neurologists, and psychiatric groups. And they usually pair that work with what we do so they can have a more comprehensive, program and treatment outcome for their patient.
Yeah, Laura, if I'm not mistaken, with insurance, I think 4 hours was considered by insurance to be success for CPAP tolerate. Then they would pay for your device. And we used to
Yes.
do remote patient monitoring during
Yes.
COVID for our patients. And what we would try to do is at least coach them to that 4 hours, because we would tell them, listen, if you're not averaging at least 4 hours a night, insurance is not going to pay for your CPAP. And,
Right.
they would be like, what do you mean 4 hours a night? We're like, well, you have to wear it at least 4 hours a night, or insurance is not going to continue to pay for your machine, and you're going to be responsible for this cost, or we're going to have to figure out something, because DME, they're just not going to pay for it. So that was always very interesting to me. It's like, but do we consider 4 hours a night good
Enough
sleep?
sleep. Right.
Is that really enough sleep to survive? I don't know about you, but I'm not a happy person to be around with 4 hours of sleep. I'm not someone you want to tolerate very much after 4 hours of sleep. I'm kind of, Danielle can tell you, I'm not one that you could tolerate me very well, Danielle, on 4 hours of sleep. So she could tell you
It
all about
doesn't
that. But
work.
yeah, we have a question. Is success AHI resolution?
I think so. Yeah,
All
I think it's
right.
partially, but you need to still look at the whole system, because even though you get your hypopneas down and you get somebody to start breathing, you want to look at the quality of what that looks like in the day. You want to look to see that they're nasal breathing appropriately, that they have good oral function and good oral health that leads to good cognitive and immune health. And it's so important to keep going further. Like, okay, cool, we did this. We get a ton of people off CPAP. We're really good at mild to moderate. Severe, we can get them into an MAD. So we have not been successful thus far getting them off something. in the severe realm for a high HI, in the 30s. And so, but the goal is how do I make this body most optimally functioning? How do I provide them with an opportunity for less stress? And that's what we're looking at, overall health. And what does that look like? And why do parafunctional habits contribute to dentition collapsing or dental crowding? And why is it that if you can see the lower dentition, that's often a root cause, not a root cause, an indicator that that person probably has sleep disordered breathing, because orbicularis, oris, buccinator, and resource are weak. And so we know with that we have a forward head posture and we're going to have a shallow airway. So looking at all these different trends over the last, it's been 34 years, you start seeing trends in your patients. And some people, I would never take their CPAP. I'm not saying it's bad, but I want to make sure that it's good. And so to me, 4 hours isn't an adequate sleep. In terms of sleep quality and rating, that would be called severe, poor sleep quality. And so it's really important. It's not only about the funding or the name or the title. It's about how is my system working with this type of breathing or apparatus. That's what's so important in our practice.
Yeah, insurance is one of the worst indicators of good health on planet Earth. It's not a great indicator of health,
Not that
unfortunately.
great.
Yeah,
No,
it is not a great indicator of health. So,
no, it's a beast.
Cheryl said tolerating CPAP or appliance without resolution of apnea is the same as masking the symptoms with meds. So, yeah, absolutely
Yeah,
agree with
yeah,
that. Yeah,
100%.
absolutely.
Yep.
And
And
Paul
that's why it's so
says,
important.
yeah, Paul says so during day is heavily posture driven. So,
During day is heavily posture driven. Yeah. So anti-gravity, posture is anti-gravity. So when we're sitting up, I think maybe this is what you mean. I'm not sure exactly, but when we're sitting up, we want to make sure that we're supporting the pelvis. So it's all about your pelvic tilt and your pelvic position. The reason why is the pelvic supports your torso, right? And the torso supports the breathing apparatus. When we're aberrant or we have a high shoulder, this is collapsing part of our airway. If we're always using one hand and you have this high shoulder, your airway is going to be compromised. And then typically what we do is, because there's nasal cycles, is we start breathing through our mouth because we're humans and we go the path of least resistance. Whatever makes it easier during our day is what we do. So to support posture is a great way to support the oral articulators for success.
yeah, absolutely. He said vertical versus horizontal. So that was his,
Okay,
yeah.
vertical. Yeah, so vertical breathing is like this, up and down. So you tell your patient, take a breath, and they'll say, well, that's so uncomfortable. That's a mouth breather. And so, and it's shallow. So that's called a clavicular vertical breath. And so that's like this. Okay. And so we know that air only goes to about here. You're going to have poor gas exchanges. But when you have a horizontal breath, that means the rib cage expands. The diaphragm expands. The intercostals in the rib expands. That lets all this lymphatic system go. That means you have an efficient breath and your diaphragm is working well. Remember, the second brain is the stomach. If you don't have good horizontal diaphragmatic breath, you don't have engagement of the stomach or the vagus nerve, because that's where it travels to.
Yeah, we've got
Bye.
two questions over in the Q&A. One asks, what about tongue placement is good and nasal breathing is happening, but low O2 happens at night in REM in the 85 to 89 O2. Would be think stress or needs exercise?
Oh, I think it could be both. And that's where you want to look at your patient to see what's happening. They might just be an inefficient breather. They might have high resistance in their airway. That means occlusion somewhere. They might be a mouth breather. They might have poor physical health. They might have trauma. And our trauma guys, our vets that we work with, they have a lot of jaw issues with the trauma. So with Dr. Moeller, he's in Virginia. We get a splint made for the vets, and it really helps them get into a deep REM sleep. And a lot of them have really shallow respiratory support, but it helps them get into a better sleep state. And while we're training tongue posturing. So yeah, it depends. It could be all of it. That's why it's so important to have a comprehensive assessment of your patient. Doesn't mean they need to be marathon runners. It doesn't mean that they have to, be an Olympian. It just means that they need efficient respiratory patterns for their person. And that wouldn't be like this. Right. And so that they have good nasal breath, that they have good support. And see, the left side is the best for your organs to release all the toxins and to open everything up. Some people are uncomfortable with that. So there's a ton of ways to sleep to support the airway system. It doesn't have to be one way only.
Gotcha. And then the next question from Cheryl was, do you have any recommendations for myo training programs or what to look for in a program for those who would like to get certified?
Yeah, so we're here we're in the process right now of getting a comprehensive program certification together for oral health practitioners. And so what that looks like for us is really having patients know practitioners know, okay, posture, breathing, you have to test it. Jaw, lips, tongue, speech, swallowing, and vision. And vision is the craziest thing that has been added in the past 10 years because your vision muscles are attached to your sphenoid. Well, 11 of them are, one isn't. But there's 6 muscles on one side, 5 on the other. And if the vision is off, your airway is going to have resistance. That's probably post-concussive. That's trauma. That's anything that's happened to the head. It could be postural changes. So we're looking into that right now. Any speech language pathologist is certified to do swallowing therapy or myofunctional therapy or oral pharyngeal therapy. I think most of some programs are a weekend long. That's it. So you really want to look to see, is it a comprehensive program? I would think all the participants here, you guys are high level airway, whole body people. You would want a more comprehensive assessment before you just say, okay, put your tongue on the roof of your mouth. Because that's not always the right way. If you have TMJ, you don't want to put the tip of your tongue on the roof of the mouth. It will cause more pain from the medial pterygoids and digastric muscles. That's a big fat no, so don't do that. You would rather have the whole tongue on the roof of the mouth for a TMJ person because then it has a full tongue release and it allows these temporalis muscles to calm down, which helps a ton.
Absolutely. So, there's actually people who are volunteering to beta test for you when you're ready to go with that program. That's pretty awesome.
Yeah.
So yeah, there we go. So we love to see that. We are so excited to have Innovative Oral Solutions with us. They're going to be with us the entire year. This will not be the last time you see them. You will actually see them engaged in more webinars with us. You will see them engaged in more of our of these day-long training sessions with us. You will see them in annual sessions with us, and we are so thrilled to have them as part of the aaosh family. And they're going to be with us for the entire year for 2025. So folks, don't think this is the last time that you're going to see this. You're going to be able to spend an entire year with these folks. And we are so thrilled to have Laura and her son along with us for this journey. So we are so excited to have you here and
So
to
fun.
be a part of this.
Thank
So
you.
we had another question that says, why 6 versus 7? Which side 5? Which side 6? So
Oh, for the eye muscles. You know what I'll do is I'll put a slide. I can put a slide up, or I can send you a whole visual of the eye muscles. It's really complex. And show you what that looks like, and I'll put it up there. Why? I don't know. But I can show you what it looks like, and how we release it is using nasal release technique and then external and internal manipulations. I don't think, even though a lot of practitioners say they move the sphenoid using different bodyworks techniques, I think the most effective way to do it is intranasally using a balloon. Well, we use nasal release technique because that's what I'm cleared for, but I think that works the best to release the eye. It's incredible, really.
awesome. Absolutely awesome. Well,
All
Laura,
right.
thank you so much for your
Thanks,
presentation today.
Violet.
We are so grateful for
Oh,
you
thank you
and
so much.
for thank you for your patience for all the things with the slides. We got you up and got you rolling in the
Yeah.
right direction, and that's what we wanted to do. So we were so glad. Thank you to Karen for troubleshooting as we worked through that
Yeah.
and got you going. He's the technical genius for the day. Thanks a lot. We appreciate it. And we're so glad to have had you today. It really kind of tied everything up into a really nice, neat bow on our nice present today. So we are so grateful and thank you guys for everything. So Danielle just put the link up again for how to get access to claim. Go ahead and claim your credit for this CE today. And I'm going to go ahead and roll us out of here. So I want to thank everyone today for attending and for your participation. I got to tell you, I'm humbled every time that we have an event because we just continue to be more successful from one event to the next. And this one was by far one of our most successful virtual events. And I want to thank you from the bottom of my heart for your continued support of the aaosh and our mission to save lives through the mouth body connection. If you've enjoyed today's event, I hope that you will see this as the first stepping stone of 2025's great lineup of events, speakers, connections, collaborations, and opportunities. We're dreamers here, we're believers, and you are all of our friends. And we want to help you grow your practice, grow your knowledge, and become your trusted source for all things oral systemic health. Just as a reminder about your CDE and CME, please don't wait to gain that credit. It's so important that you do it as soon as you can. We'll submit to AGD PACE as soon as we can and to our CME accreditor. So if you have any trouble obtaining your CME credits or your CDE credits, please email support@aosh.org and we'll get back with you just as soon as we can. The recording will be sent to everyone, which you will be able to access on Vimeo by Saturday evening. We'll send a password to access the recordings. Those will be up for 90 days. After that time, we'll close access and we will not be able to open that back up for you. So please be sure that you get a hold of the recordings, spend some time with it, get all the credits that you need, and then we'll move on. And it'll be time before you know it for our next big virtual event. We hope that you will consider joining us as a member if you've not done so already, so that you can get credits for our webinar series, join our future virtual events, and of course, our annual session. We want to give just so much special thanks to our sustaining partners and friends who joined us today. We honestly could not have done this without you. So we wish each of you a great evening. Stay in touch with us. If you enjoyed this today, please let us know. We really would like your feedback and we certainly appreciate it. And know that we are here to support your oral systemic health journey, whether you are an RDH, you're a nurse, you're a doctor, you're a dentist. No matter where you are on this journey, we're here for you. Goodbye, everybody. And until we meet again, stay safe. We'll see you again very, very soon. Take care.